I'm glad it's an intimate space. Okay, let's see. And consultant to WHO, International Agency for Research and Cancer. I know. Yes, hello. I don't know. Sure, check it. Do I have one? Yeah, and so you think, do you ever come to the US? for the Okay, I think we can go ahead and begin. Thank you all for joining us early in the morning at the World Health Summit Regional Meeting. My name is Ru Chang. I'm from the Gates Foundation. I lead a team called the Women's Health Innovations Team. I'm both an OBGYN physician as well as a drug and medical device developer. Watch a short video that will highlight the issues we will discuss in this session, and then we'll continue with the Q&A panel. Okay. Thank you to the organizers at the World Health Summit for creating this space to talk about women's health and the opportunity that it provides, as well as the gaps. And we are all here to solve for this together because, as you'll see and hear about during the session, it is a broad area, and there's more than one topic within it that requires the attention, and it will require all of us working together across sectors, across regions, and across industries to really move the needle for this very important topic. So I'm going to just introduce our speakers and invite them to come to the front, and there's some shuffling of the name tags here, so don't mind that, and just focus on the people. So I'll go in alphabetical order. First of all, I'd like to introduce Dr. Neerja Batla. She is the former professor and head of the departments in gynecology, and is also a consultant to the WHO IARC, which is the International Agency for Research in Cancer. Additionally, she is with the All India Institute of Medical Sciences in New Delhi, AIIMS. Please welcome Dr. Batla. Next, we have Dr. Sumita Ghosh, who is an officer on special duty in health as part of the NITI Aayog organization, Health and Nutrition. Director, the head of who is a professor at the National University of Singapore and director of the Global Center for Asian Women's Health. And then last but not least, we have Oleg Zarov from Strategy and Operations at Ferring Safe Birth Initiative as part of Ferring Pharmaceuticals. Yes, just give us a moment here. Okay, now, as we're getting settled into the front, I think we can go ahead and play the video. If our colleagues in the back could, play the video, that would be great. That video is always so inspiring to see the images, and I think it gives you a good visualization of what we're thinking about and talking about here when we talk about the gap in women's health. I will just open by saying, as an OBGYN physician myself, I have seen what happens when we do not invest in women's health, and actually it's the health of women. Healthy women truly are the foundation of our societies. They are important for our families, for our communities, and for our economies, as we saw in the video. If women don't do well, they cannot be well. For a long time, women's health has not been given the attention that it deserves. It has been treated as an afterthought. It is underfunded, under-researched, and as a result, our solutions are not serving our women well. The cost of this neglect is quite high, lives are cut short, potential is unrealized, and progress is left on the table from an economic standpoint. But when we put women's health in the front and center, everything can change. Girls can stay in school longer, women survive childbirth and go on to have healthy, thriving children. Families grow stronger, and communities become more prosperous. And as more women join decision-making tables, they have the power to shape policies that reflect these lived experiences, building a more just and resilient world. So today's conversation is really about the challenge and the opportunity. The gap is real for women's health. It's driven by data blind spots, research disparities, delivery failures, and chronic underinvestment. The good news is that solutions are within reach. We will spotlight some innovations that are shifting what's possible and show why now is the time to double down on investments in women's health. Because when we invest in women, we don't just improve lives, we transform entire societies. Okay, so the first part of our session today, we'll talk about the women's health gap and what does it mean, how does it manifest in real life scenarios, and what is it costing us? It will come as a surprise to no one in this room, I hope, that this gap is real and costing quite a lot. We know anecdotally that women live longer than men, and this has actually been shown in the data as well. However, women spend 25% more of their lives in poor health. When you think about the investment dollars, only 2% of global medical research funding is allocated to female-specific conditions outside of cancer. That seems like a big mismatch when you consider that women make up 51% of the population. There are conditions like endometriosis, postpartum hemorrhage, that remain underfunded and under-researched. And too often, women face the consequences of having their symptoms dismissed. So I want you to imagine a world in which medical research really sees women, really centers on women, because that is not our reality today. Women have been overlooked in clinical research, which has created gaps, data gaps, and blind spots in our healthcare as a downstream implication of that. But if instead we have health systems that responded to the needs, the unique needs of women, and we have data that is disaggregated by sex. So if you don't look for it, you won't see the differences. Women are not small men. Every cell has a sex, and so those differences can have an interaction in terms of how drugs are metabolized and the effect on those cells. Additionally, women experience disease differently than men. And so providers need to be trained to recognize those differences and how to look for them. This is not, in terms of medications, it's not a one-size-fits-all, and we need well-funded research into these conditions because they affect women from head to toe. The current gap is not just inequitable, it's also inefficient. Closing the gap, as you saw in the video, is actually a $1 trillion economic opportunity for growth by 2040. Globally, every $1 invested in women's health unlocks $3 in economic growth. That's a pretty high return on investment if you ask any business person. So the opportunity is enormous. So is the cost of not taking action. So with that, I'm going to turn to my colleagues here to share more about what they see in these gaps and barriers to their work. So I'm going to turn first to Dr. Sumita. Could you just share with us what is the regional vision for women's health as you see it? You can use your mic.
So I start with, health is the fundamental attribute and the cornerstone of any development. So no one can be left behind. And am I audible?
Yes. Just pull it closer. Yeah. No, just closer to your mouth. Yeah.
So this is the, no one can be left behind. And as we read, uh, 51% of the population in that age group. And, uh, the health needs of this women group is very, dependent on the various age groups. Like a child, a girl child, definite need for nutrition, early child development. Then coming to, higher age group, the school education, the taking up of lifestyles, habits. Then adolescent, again, a different health needs. Hygiene comes, the nutrition, of course. Then the reproductive age group, again, different needs. And when that ends, women live much beyond that now. So that age group needs. So this is what we must understand, that each age group has a special need, and if they are not met, they sort of compound more and more and more and more, and that's what happens. Biologically, the longevity is higher for women, and more or less it has been established now all over. But the poor health part, which was shown, 25% is lived in poor health, not so healthy. So that paradox, survival paradox, that you survive more but you suffer more. So that is the issue here. So the vision here is to have this, this is determined by not only biological sex but various determinants which women are particularly subjected to, the socio-cultural norms, the economic disparity, the educational gap, and especially the prioritization by women of their own health. They are not very health conscious. They take care of everyone but themselves. So that kind of mindset. So the vision is to address all of them together. It's not only that, women's health as such. So the vision is that the life expectancy increases further. The healthy life expectancy, more importantly, is increased. The age, the gap of 5-6 years between healthy life and life expectancy, that must be addressed. Universal health coverage, giving the quality of health to all of them for their age-specific health needs. The the another thing is making them aware of being health conscious, the health literacy, their self-care, their lifestyle, their nutrition. Nutrition is another very big area where women, they don't take care and they suffer. So these empowerment for health, prioritizing health, that is another vision which should be done through all collaborative efforts. And finally, getting to the SDG targets, which are there for maternal mortality, bringing it down substantially. The SDG targets of 3, health and well-being. Well-being part is very, very important. And also the, the gender gap, filling that gender gap, where we stand. So that again is a thing. So we want to, the vision is to add life to women and add years, as well as add life to those years. So that is where we must aim for.
Wonderful. Thank you so much. I'd like to turn now to Mr. Gaurav. In maternal health, let's zoom in on that point in time. What are the key challenges you see there, and how does this have an effect on practice?
Yes, thank you very much, and I'm very honored and humbled to be here. represent Ferring Pharmaceuticals. Ferring is a company which is one of the biggest committed operators in the space of maternal health, which is actually to say that we're a smaller size pharma company, and the fact that we are the biggest kind of name in the maternal health is also saying something about the global interest to that topic. For the last several years, I'm focusing on Project Family Safe Birth. That's our commitment to bring heat-stable carbetocin for the prevention of postpartum hemorrhage to all developing countries at the access price for the public and not-for-profit sectors. This is the great achievements which, for example, the government of India has achieved over the last 25 years or so in reducing the maternal mortality ratio. Also, like the effect is also seen in many other Asian countries. However, we still see that postpartum hemorrhage remains the biggest key contributor to the maternal mortality. And for us, it's important also to see that this innovation is accepted and scaled up. And this is where we see the need for the policy decision makers, for the political will to be more pronounced. Because, for example, the product is already registered in 25 countries. And it's a special initiative. We were collaborating with WHO, with MSD for Mothers, with other organizations like UNFPA, like GPIGO, and the implementation research. But what we see is just even when this innovation is well researched, when it's well documented in terms of the real world impact with the outcomes, the acceptance and the implementation in the public sector is very slow. For example, in India, in the private sector, this is a well accepted use already. Like over the last 4 or 5 years, we see that almost 3 million doses were used in the private sector. In the public sector, we only see now that states are very slowly starting to accept. We see Tamil Nadu starting to implement, and Karnataka. But those states and areas where the disparity is still there, and just where the benefit would be the highest, we still see a lot of barriers on acceptance, on the implementation. Our project is focused on 85 countries, and we see very different level of engagement and the speed of implementation. And I think the scale up of the innovations which are available now, well researched, cost effective, budget positive. So this is something which could be not only saving women's lives, but also optimize the use of healthcare budgets. I think they should be accepted and scaled up much quicker, because if we follow the example of Makueni County in Kenya, where the governor Kilonzo about 3 years ago said that we should stop piloting and we implement the heat-stable carbetocin for the prevention and the emotive bundle for the treatment of postpartum hemorrhage. Over the last 2 years, they recorded 0 postpartum hemorrhage-related maternal death. Meaning, if postpartum hemorrhage remains a big chunk of the problem, we could eliminate that, like turn it to 0, and we really need to act fast. Then we could be also focusing on the other related topics, because there's still anemia, there is preeclampsia and eclampsia, there is lactation challenges for the mothers and their babies, and the impact of that is dramatic, because if the mother does not survive the childbirth, the likelihood that the baby would also succumb in the first year is multiple times higher. If the mother is not there, then the impact on the health and the economic situation of the family is profound. The longer term consequences of maternal death and near misses on the mental health, just on the long-term health of the children is also quite significant. So we need to do what we have already. We implement that, and we continue to explore the opportunities to close those gaps in the rest of the women's health area. What I would like to say, just it takes a village, as they say, to bring up the child. So when our project is an example where the collaboration of very different organizations and stakeholders was critical from the very beginning, from the clinical development, where WHO and MSD for Mothers were collaborating with Ferring Pharmaceuticals to bring that product for the prevention of postpartum hemorrhage after the vaginal deliveries. Manufacturing, like a setup, we collaborate with Sterilogen in India and the Ferring Pharmaceuticals own facility in China to scale up manufacturing capacity to address the public sector needs. We collaborate with the Concept Foundation on the regulatory framework because we have so many countries to cover. It's a task which is tremendously challenging. We are collaborating also with WHO CRP team, the Collaborative Regulatory Procedure team, to accelerate the processes. Still, there is barriers around that. On distribution of the physical product, we collaborate with IDA Foundation on the international distribution. With various professional organizations, OBGYN Society, midwife societies, we collaborate on the policies, policy change guidelines, but also on the training the healthcare professionals on this of the use of the innovation. And definitely we do collaborate with the governments, but also we need to expand that collaboration to accelerate the formulary inclusion, the procurement, and scaling up the trainings for the public sector use. So this would need to continue, and we just discussed before this session that a lot of innovation would require base science to catch up, and because a lot of mechanisms are not well researched. So this is a long-term type of investment, but without doing that now, we will have difficulties in the R&D and clinical development and subsequent innovation implementation. So thank you.
Thank you. Okay, I'd like to turn to Kala now. From your perspective, what are the gaps that you see in terms of data gaps and enablers that are emerging from the current local insights?
Thank you very much. I think it works. Thank you very much. Very honored to be part of this session, and very well summarized by all the speakers until now. So from a gaps perspective, from a data gaps perspective, there is a systemic underrepresentation of women, okay, starting from research to clinical trials to every portion of data, starting from the data pre-generation to the generation of the data to the analysis to everywhere. So let us look at why this is happening a little bit, right? I'm going to probably reiterate some of the things that you talked about. So if you look at what's happening in the interventional studies, about 50% of the interventional studies, they are recorded, and many of them have sex disaggregated data. Out of this, 64% of the women feel that the way they are treated, it's not effective or not accessible. Whereas if you look at the gap for men, it is only 10%. There is delayed diagnosis even for women, right? There was a study which was done in Denmark for 21 years, and they said that in 700 cases, there is a delayed diagnosis for women. For example, 2.5 years when it comes to cancer, about 4.5 years when it comes to diabetes. Okay? So this is the reality. And overall, there are invisible conditions. You talked about endometriosis, right? And WHO says that about 10% of women who are in reproductive age live with this condition. Okay? There is a global disease burden database. They say it is about only 1 or 2%. Just look at those differences. It's 8-fold discrepancy. If you look at many more things, like less than 30% take the HPV vaccine, right? And about 20% undergo the cervical cancer screening, whereas this is in LMIC, like, whereas if you go to high-income countries, it's about 84%. So this is the reality, okay? And if you look at FDA, they said that in 90s, they, I wouldn't say mandated, but they asked for data to be gender specific. And in the same way, for the clinical trials, more and more focus is being given. So overall, as you rightly said, because of all these conditions, 25% of the time, like, even if they live longer, women, they live with poor health. This affects the quality of data. Dr. Sushmita also alluded to that, right? So it's extremely important for us to see how we can take, I would say, how we can consider women population in everything that we do. I represent Siemens Healthineers. This is one of the healthcare company which is a market leader in many segments. And our association with the World Health Summit and then also the Global Alliance is predominantly in the breast cancer and cervical cancer areas, right? And what we are trying to do is be much more conscious when we are taking the data. By the way, data is power. The whole world is moving towards AI and AI-assisted support for all the caregivers and also the physicians because they can focus on patients. This is going to be a companion. We have developed many companions, the RAD companion, which is going to help the radiologist, a companion which is going to help in contouring for oncology, etc. It used to take days and then hours, now it takes minutes. So this is all possible because of the data, because the AI model, we talk about AI. AI is as good as the data that you're feeling. So the data strategy is extremely important. As a company, we work with all the associations here, including AIMS, and we look at how to collect the data and how to have much more focus on women data and also the ethnicity out here, because that is going to help with understanding the disease prevalence. So overall, if you ask me, starting from data, there is a big gap. At least nowadays, there is a conscious effort to reduce the gap. There's a gap in awareness. As she rightly pointed out, there is a need for us to improve the awareness and the education. There is a gap in access. So this is where a company like ours, of course, I'm going to talk more about that later, where we put some of this equipment in the van and then increase the access. So overall, there is a data gap, there is an enabler gap, but there are efforts that are being put in order to reduce this gap. Thank you.
Thank you. Thank you. Let's go now to critical data gaps in women's health research and how they can be addressed. And I'm going to ask Zui Ling to address these.
Good morning, everyone. Thank you for coming to this room. And also thank you, Dr. Chen, for chairing this session. It's really a great honor to be here, to be with my colleagues, to talking about these really important questions. So I came from academic background. So I'm going to talk about these data gaps from academic perspective. And many of the gaps actually have been covered by my colleagues. So I'm lucky. So when in academic research, when we talk about research data gaps, so the first question I would ask my colleagues, what are the research questions you want to address using the data? What will be the goal of the research? So for me, I think for women's health, it's really important for promoting women's health from both health span and also lifespan perspective. So I'm going to talk about data gap research from these two perspectives briefly. So in terms of health span, so in the past, even now, there are lots of attention to disease, still from the sick care perspective. So I would say there's quite a lot of gaps related to women's health, the general health and the well-being. It's not just about disease. It's about the overall health and the well-being and mental health. So some subclinical phenotypes very important for women. For example, the men's health, the menstrual health, and menopause, perimenopause health conditions are really important, but not enough data on those, especially in diverse population. But in the past year, I was very happy to see their increasing awareness on these subclinical phenotypes and general health perspective for women, not just only on disease perspective. So that is one thing I like to highlight. Is not just about disease for women's health. It's far beyond pregnancy, maternal child health. It concerns other perspective of women's health as well and well-being. So the other thing I would like to say, some also been covered by some of my colleagues. So from the health span perspective, like again, lots of data from the research perspective published based on Western populations, Caucasian populations. Not a lot, I would say high quality data from the diverse, like low middle income countries. Using Asia as an example. So this is also one of the reasons after I lived in the US for more than 20 years, I came back to Asia to set up the Global Center for Asian Women's Health at the University of Singapore. So I think on that, so that's quite a lot of gap on that. Okay, and in terms of lifespan for women's health, I would say it's also covered by some of my colleagues. So lots of quite a research data focusing on maybe postmenopausal women and maybe, so we need more data about younger women, especially like with increasing evidence about the importance of development origins of chronic disease. So early life, childhood, and preconception, periconception are really important, the time windows as well. Some of the topics have been discussed yesterday in several very, very important sessions as well. So I think early life is important. We need to more research invest in females' health, women's health in early life, preconception and periconception, not just to focus on postmenopause where women become sick. And then on the other extreme, it's also been mentioned by my colleagues. So they mentioned about, I would say this is a feminized aging. So like women live longer, but they are likely to be healthy. They live a longer time with a healthy life. So we need more focus of data on the other extreme end among women for women's health. I can keep going on and on, but I just want to save time. So I like to look into this research data again from both health span and the lifespan perspectives. So a lot can be done, can be addressed. It's very hopeful, like just seeing the improvement in the past few years. Lots of more attention to women's health and more data, and there are lots of new initiatives. So I just like to end my part by saying like women's health is not just about reproductive health and pregnancy. It's far beyond that. It's about overall health and well-being. And as just Dr. Chen opened the session that women's health is so important for the next generation and for their partners, for the whole family, and also for the entire society. Many data gaps we have to address along all these lines.
Thank you, thank you. Turning to Dr. Nirja, I would like to hear from you. What do you see as the main barriers facing women's health? We heard about maternal health, we heard a little bit about the lifespan, but are there any other points in time or conditions or overall health that we should be thinking about?
Thank you, Ruth. Thank you very much. And thank you for the invitation to be here as a part of this very exciting multidisciplinary panel. And thank you to all who have come early morning on Sunday to listen and participate. I've had the privilege of being the head of department at a hospital like the All India Institute of New Delhi, where we have a large variety of patients of all kinds. And so oversight on the maternal health, high-risk pregnancies, gynecological conditions, benign, malignant. Of course, my special interest has been in cancer and in preventing cervical cancer in low resources particularly. So I can say that we've had a lot of shift, which has been partly because of the contributions of our professionals, of course, and professional associations too. but also majorly driven by the policy changes that have helped maternal health gain the advantage, and also the reductions we have seen very impressively in maternal mortality, even though we may not be at the goal, but the trends indicate we will be there. So it's very, very encouraging. But as Dr. Sumita said, it's all part of a continuum. We even know now about the fetal origins of adult disease, so we cannot really work in silos. And yet, policy needs to be necessarily in silos, so there have to be ways in which there can be interactions periodically between different verticals. And as I say about verticals, we have felt very acutely recently, particularly, the need to address the adult women's care needs. Because if you look within the ministry, you will see that there are people focused on maternal health, there are people focused on child health, but if we go for issues which concern adult women, and we have aging populations now, and we have situations where we have to look at menopausal needs, we need to look at problems, for example, like unnecessary hysterectomies, which we have been seized of. We don't know whom to talk to. There are no verticals to deal with the geriatric woman. There are no verticals to deal with the age group beyond maternal health. So there's a lot of overburdening of people with additional tasks that are, and so you need a periodic revamp to look at what are the critical issues today and make some roadmaps down the future to say that this is foreseeable and this is where we act. Because we all recognize the role of preventive care, and we all recognize the need for task shifting in every domain. Even in maternal health, for example, we do need to promote the role of midwifery. We need to see that we get more people at the grassroots. And in Asia, everywhere, we are seized with this problem of wide variations in socioeconomics, wide variations between the haves and have-nots. And also, I feel a disproportionate amount of natural calamities in this part of the world, which lead to disruptions in services. So people don't get access. And as was said about women not reaching for years, and this is something which has also changed. We used to see cervical cancer women coming in where we could smell the uriniferous odor and know that there is a stage 4 cervical cancer entering the room. This doesn't happen so much, fortunately, anymore. But women used to be concerned about, first of all, putting themselves last, and secondly, the feeling of helplessness that nothing can be done. So there is a strong need, for example, to promote the advances, awareness about the advances, the need to report early, the need to get screened, for example, the need for women to take charge of their own bodies, to understand. If it's a maternal health, there's data from the Indian Council of Medical Research that shows that when the mother dies, there is higher infant mortality. And also, unfortunately, that if that child is a male, there's more chance they would survive because some relative will look after as compared to if their child is a female. If we look at cervical cancer, we know that these women are younger in age than women with breast cancer or ovarian cancer. The years of life lost are far more. Their children are still young. They may not be toddlers. They may be adolescents. They still need their mother. There's a lot of price they pay. Their own careers get thrown off. Their education gets thrown off. So it is for governments to realize that they are not just talking about a statistic. They're talking about a whole family, a whole community, and a whole socioeconomic structure, as I can say. And we heard about AI also, and we know that we should be leveraging the AI. And there are options now for that, because we have demonstrated, for example, in the cervical cancer space, that health workers can be trained to use these new devices that are now being done. We have demonstrated how they can upload those images to an expert sitting at a remote location, because we know that we are very far from the ideal. Whichever country of Asia we may take, we are very far from the ideal ratio of doctors to population. We will never have that many doctors. We have to leverage the power of nurses. We don't use the nurses as well as do some countries, but then we don't have enough nurses also. So we need the ANMs, the auxiliary nurse midwives. Everything goes to the ASHA in India, the accredited social health activist. Everything seems to be her domain, but can she really do so? We have to see beyond the present, the expanding role of preventive health care, the need to make it more systematized, the need to have appropriate levels. And one last thing I would like to say about the research. Of course, in women's health problems, they will all be women, so that part is taken care. But do we have representation of different ethnicities? So now that is coming in, fortunately, there is thinking about that to ensure that different ethnicities are represented. But when we talk about collecting data, sometimes the biggest bridge, the gap and the biggest drawback is that where is this data going to be published? And sometimes you've done phenomenal collection of data, but journal doesn't want it. They say it's just more of what we knew. And they don't want to publish the fact that this is new data from a region that didn't have it before. So we have to find a way to put it on maybe ministry websites, or where do we do it, and accept that this data is as good even if it is not in a peer-reviewed journal. So I'll stop here for now.
Wow, that was a lot to take in. Thank you so much. I'd like to turn our thinking now. So we've heard about the gaps, and let's go to progress. We've heard a little bit about progress, but there's reason for optimism, right? There's been a lot of progress in recent years, as we heard. One initiative that was co-led by my team at the Gates Foundation is the Women's Health Innovation Opportunity Map. That was created in 2023 with about 250 global experts in women's health to define 50 high-impact areas for additional investment to really move the needle on women's health R&D. And we published our first progress report in January that shows some incremental progress, also significant collaborations that are driving the change. So if you guys have not seen the report, I don't have it on a QR code, but if you were to enter into Google Women's Health Innovation Opportunity Map, it will hopefully come up. Areas where we've seen progress in our progress report is in cardiometabolic conditions, which drives a deeper understanding of sex and gender differences. We know cardiovascular disease actually is the #1 cause of death for women. It is not a female-specific condition. It is not breast cancer, although a lot of people have fear about breast cancer. And this paves the way for more precise prevention, diagnosis, and treatment strategies. For female-specific conditions, including new drug approvals, we do see progress in the area of uterine fibroids and polycystic ovarian syndrome, and some advancements in maternal health research. So that's really positive. There's been inclusion of pregnant and lactating individuals in a tuberculosis clinical trial. So pregnant individuals are actually the most underserved population because they're very much thought about. If women are considered an afterthought in clinical medical research and clinical trials, people who are pregnant are even further pushed out in that domain. So that is really important progress to note. In addition, there have been some high-impact innovation hubs that have come together that are expanding what's called femtech initiatives. So these are these tech-enabled solutions and apps. So there are some ready-made opportunities in this opportunity map, and all of this, for me, shows that we're at a turning point. The tide is beginning to shift. It's a large ship to turn, so it won't be a rapid or a sharp turn, but we are beginning to see a turn. And I would like to ask our panelists what they think. I'll just ask for volunteers, if we could just hear from each of you. What are some key initiatives aimed at improving women's health that you see, and what are the lessons learned? And I'll open it up if anyone would like to volunteer.
Thank you so much for put this in a very optimistic way. I do agree there. From the research perspective, I see quite a large impact from the high technology and innovation. I'll just give a few examples. For example, the technology in the field of omics work, like the measurement for genomics, gene mapping, and also characterizing metabolites, the global metabolomics work, and the microbiome. This really help us to input a bit in terms of understanding the etiology of disease, in terms of identifying biomarkers for the early prediction, and even for like more precise diagnosis of diseases related to women's health. For example, using diabetes as example, the gestational diabetes is very common, especially in Asian women. But with integration of omics work, especially metabolomics work, the early prediction of gestational diabetes may be really possible, like using samples from early pregnancy. So that is one example. And another example I was thinking about is a wearable device, like telemedicine. So this also make it feasible. For example, I just mentioned, also my colleagues mentioned how to better characterize like women's phenotypes, like mental health, like hormone changes over like menopause status, like some a wearable device is really help us like to measure that, like the Apple Watch. I'm not advertising, but there are studies ongoing, global Apple study ongoing, try to using like the app to better characterize mental health like globally. So this is just, there's so many examples. These
Yeah.
are a few
It's exciting.
examples I like to share. So I'll
Yeah.
leave this to my
Yeah.
other colleagues to comment.
Anyone else?
Thank you very much for this important comment. Actually, I would like to say that it's very encouraging to see the new centers like your Center for Asian Women's Health Development. And I think this one potential enhancement in that space is this scientific collaboration, and especially from academia to fill the gaps in base science and just really explore things which would be useful for the future development collaboration and just in clinical development, in also enabling other kind of cross technology collaborations with AI, with devices and so on. So I think I would like to say also just it's great to hear that there is an optimistic trend in several disease areas. I would like also to say, for example, the Champion trial, which was this largest trial in the area of obstetrics, with almost like 30,000 women recruited for the development of heat-stable carbetocin for the postpartum hemorrhage. It was including a significant population from like India, from Asia, from Thailand, Singapore, also from Africa, from Latin America, and Europe. So it was a 10-country study. Now the new study, which is looking for the treatment indication, heat-stable carbetocin in a treatment indication for PPH. It's also like 7 countries with a very, very significant sample. We are looking to see at least like 6,000 women to be recruited for the treatment. But that means that over 100,000 women would be going through the prevention first. So the efforts are made to make this the different countries, different ethnicities to be represented there. So it's difficult to fix the past, like the old studies which were done in cardiovascular space, for example, in the 80s. Like we cannot fix that and cannot repeat them necessarily. But I think there is a way to collaborate more and have more opportunities in different geographies collaborating across the spectrum. Thank you.
Yeah, thank you for this question. Actually, lot I can say, but I won't. So we are talking of millions, at least in India, millions we are talking about. So individual interventions and all, it will be too many to talk about. Systemic thinking is needed, what is needed. And in India, I can talk about, it has been prioritized. If you ask me what is the greatest invention and application in last 100 years, which have changed women's life, I think all will agree it is the planning of family, the birth measures. All of us are here because we have been privileged to have come to that era where it is there. So family planning program has been taken up very early. India is the first country which took up as a national initiative all over the country, 1952. So a lot of happened, and we can see the results that it has slowly improved the total fertility rate. It has added to the well-being of women as well as the children. So that is very important, and lot of mortalities can be prevented if we can prevent unwanted pregnancies, if we can provide safe abortion. In fact, that report you are referring to, McKinsey's, this maternal, this is the biggest contributor, you can say, where survival as far is concerned. And then, of course, the various health needs, which have lot of programs have come. And one of the important one I want to mention is the RMNCHA, clubbing together in a lifetime continuum of care approach. Dr. Nija said, yes, there are silos, because programmatic silos have to be there. Some person can see only some aspects. But the idea was to sort of have a reproductive, maternal, newborn, child, and we added in India adolescent, then nutrition. So it is a big program, and lot of funding, lot of investment, lot of initiatives have come, individual needs. So that is again another area. And women's health cannot happen in silos. It has to be embedded within the general health system, systemic strengthening. So that area also needs a lot of care, like infrastructure, number of beds, number of HR, doctors population. So many things, is happening so that the general milieu of general health improves, and in that the women get the special focused attention. I would like to mention here, which is a very important issue here, that because of the societal and cultural and traditional thinking mindset, girls are discriminated against. So they face discrimination even before birth. So that again, lot of programs, lot of ICs, lot of communications, lot of incentives had to be given so that the child survive, because there is no discrimination before birth. So there is very important program, Beti Bachao, Beti Padhao, like let them survive, the girls survive, let them read, let them study, let them be educated. So that kind of initiatives have again given a lot of impetus. And the determinants, health is not an isolated thing of medical health care or definitive targeted intervention. It is about the milieu, that is the drinking water, safe clean hygiene, toilets, menstrual hygiene. So all these different programs have come, and so they are being pursued, and I would rather say that these have contributed much more to the survival of women in particular, because women, they wear the veil of secrecy. They don't talk, they don't like to tell. They, even if there is at one point has not yet been mentioned, the violence part. The violence, it's a huge health issue for women. So that, again, that also has been taken into national programming, one-stop centers, sensitization, then various, legislations have come, acts and all. So always the efforts are on, and we can really see the impact, and we do believe, and we are committed to that action, and we hope that these kind sensitized issues on women, like they are not just another part, but the commitment has to be there, that to look through their angle, what is their cardiac problems, how the myocardial infarction presents, not the usual oxygen and all, maybe some fatigue, maybe something. So that kind you wanted for a research question. So that kind of research studies, data, disaggregated data, desegregated financing, you know, like how much is going forward, the gender budgeting part. So all these needs, have been done, but there is of course a lot more to be done.
Thank you. I would just
Thank you.
like to pause for a minute. We do have some seats in the front that are occupied
Yeah.
with bags. If people
can.
want to come up and we could just put the bag on the floor, we can provide some seats for a few additional people. So please come in and make yourselves comfortable. Yeah.
Maybe I can
yeah,
add.
yeah.
I think very, very well said, Dr. Sushmita. So apart from the maternal health, like, if you move into, cardiac diseases, you're right. The symptoms of cardiac diseases for men and women are very different. But unfortunately, in the medical schools, correct me if I'm wrong, the way that we are taught is to look at the symptoms, which is predominantly men. So this is something which is getting improved. Apart from this, just continuing on the part of the cancer care, it is becoming one of the killers, right? So there is a need for us to improve the awareness and then also screening. Extremely happy that if you look at the public health vision, as you alluded to, there is a lot of focus on systemic improvements. Okay, so for instance, the Ayushman Bharat Infra Mission in building a resilient and inclusive healthcare framework. Okay, from that perspective, there are a lot of diagnostic centers and primary care centers which has been established, about 1.5 lakhs. And also, there is a strong focus on the cancer care, reproductive care, and then early detection. And there is a lot of focus on improving the knowledge of the people who are serving in this primary care. And again, through this ministry initiatives, many of the women who are about 30 years of age, they're put into screening. For instance, they have screened about 82,000 people, okay, and in the last few years. And this is about, the women goes into screening at least once in 5 years, whereas it's very different in the developed countries. Okay, and again, the National Program for Prevention and Control of Cancer, Diabetes, and all the other diseases, there are 667 screening centers which has been established. So there has been a lot of movement, even from the government perspective. Now, coming to how corporates, okay, there are a lot of corporates which have been established in India. If you look at it, there's a huge growth. If you, we have multinationals who have established here, not just as resource augmentation, but they're focusing on India much more. For instance, I represent Healthineers, Siemens Healthineers. We have started to do programs with some of the local hospitals, local key opinion leaders. For instance, along with the Kovai Medical Center and along with the Rotary Club of Metupalayam, we have established mobile screening units, okay, for mammography. This is just an example. And basically, we want to cover about 10,000 people across 30,000 square kilometers with 200 events happening in a year. So this is the effort that has been put. Along with this, we have clinical relationship with many of the hospitals here, where we go understand what are the pain points. As you rightly alluded, Dr. Neeraja and Dr. Sumita, there is a big gap in the skilled workers, right? For instance, if you want to get the data, it's about 11 doctors and nurses for 10,000 people, per 10,000 people. That is the gap that we are having. If you look at WHO, what they kind of refer to is 44.5. So there's a big way to go. So this calls for us to look at making the workflows much more easier, right? And not very intrusive, but making it much more easier. And as you bring up the knowledge of different people who are operating that, if you make the systems much more intuitive, okay, along with the AI that Dr. Neeraja was mentioning, India and the world would be in a better place. And finally, my learnings, whatever are the few learning steps that we have to look into, especially when it comes to women's healthcare. One is equity is extremely essential, and data is the power. And collaboration drives programs, and sustained investments is the key, right? As you rightly alluded, Dr. Neeraja, we cannot do it. It is not, healthcare is not a silo sport. It is a team sport. And we have to collaborate together in order to drive better outcomes. Thank you.
So I think so much has been said and so beautifully. Dr. Sumita really, I think, summarized in a nutshell, and everybody has added. So I just want to make 2 points here. One is that, COVID taught us some very good lessons, left us with some very good tools. And one of the things which WHO really emphasizes now is the need for self-care. So I think that is something which is not something a person does just by themselves, but it is supported and supervised at predefined intervals, and there are predefined strategies. And that can apply to a lot of conditions in both obstetrics and gynecology, looking after themselves for their diabetes or checking on their blood pressure or doing so many other things, including, for example, in cervical cancer screening, we have self-sampling coming up as an option. And we've had a beautiful demonstration from Malaysia in the way of Operation Rose, which has shown how you can help women to collect their own samples, removes a lot of the barriers and inhibitions, in addition to the fact that you don't need resources like sterilized instruments and proper examination rooms, and you can go and collect it from the woman's house and so on and so forth. So that is one important thing. And the second point I want to make is that when we in the Federation of Obstetrics and Gynae Societies of India recognize this, that we have very good workflows for the base model, for the primary healthcare. But we, at the outset, I said we have both these in all countries. We have not just one, but we have the low resource and the higher resource. So we actually brought out the resource stratified guidance. Not only is there low resource and high resource, I change my hat regularly from the time I sit in my tertiary center to the time I go out and do a camp or an outreach clinic. So there should be different guidance for different things, and we have brought those out for certain conditions, but I think it needs to be across the board, clear directions as to what you can do at which level of care. Thank you.
Thank you. So that chirp you heard is a signal that we're coming into the final 15 minutes of the session, which is perfect because now we will turn to the path forward and how can we work together to close the data gap. So there are a lot of opportunities when we think especially about the rapidly shifting foreign aid and research budgets. The Global Alliance, which is a sponsor of the session, is leading on several initiatives to drive momentum in this area, despite the headwinds. And so I will ask our members of the Alliance to speak to some of those. One important point that the Global Alliance is advancing is this health impact tracker platform. So it's the first of its kind. You know, if you can't measure it, it doesn't exist. And so we need a tool, a measure, something quantitative and concrete that we can point to that shows how progress is being made both across countries and across health conditions. So this health tracker will look at the efficacy gap in terms of systemic lack of understanding of conditions that affect women, as well as lower effectiveness of medical treatments for women compared to men. The tracker will also look at the care delivery gap. As we heard, it's no good to have research and data if we can't pull it into the care setting. And this will look at the disparities in healthcare access. We heard a lot about access and the access challenges, especially when there's millions of people involved. And then the quality is also an important component of access. And not having access contributes to worse health outcomes. The data gap, we talked about a bit already. We know the data is incomplete and inconsistent on women's health conditions, which makes it less visible as a condition, and it decreases the sense of urgency and investment. So I'm going to turn to our panelists again and ask them to comment on multi-sector collaborations like the Women's Health Impact Tracking Platform or the Global Alliance in general. And how do these collaborations enable contextualized solutions? You know, we heard that it has to be very specific to the context and the country and even the health level of healthcare setting, right? That these solutions are thought about, and how to break down barriers to access and advanced care. So, Kala or Oleg, who would like to go first here?
Yes, thank you. I would like to comment on the collaboration with expanding collaboration around this global activated network for maternal health. This is an idea which was promoted by World Economic Forum and PMNCH, the Partnership for Maternal Neonatal Child Health, where Gates Foundation and Ferrin and other multiple players are catalyzing the dialogues at the national level. Like, for example, this first big meeting on this global activated network on maternal health was held in Nigeria with the new initiatives which were initiated by the Minister of Health, Dr. Patede. Despite all these challenges with the global development funding, Nigeria has committed $1.5 billion into the programs which are going to be running in the next few years to address the disparities and inequalities in the area of maternal and child health. The idea is also spreading with, like we were talking with the government of India. India is also planning to run a similar program, and also the government of Indonesia is interested in that. But even more importantly, I think, is going to be the cross-country exchange of data, information, experience, and just establish more kind of platforms for this continuous dialogue across geographies and also across different types of organizations, because we see the need to continue and expand coordinated efforts across various places. It's the private business, it's the public healthcare sector, it's the philanthropy, both global and regional and country level philanthropies, and all of those organizations, they need to be making time and making an effort to have this cross-sectional dialogue start early and continue. So that would enable us to achieve better results and better outcomes. And indeed, the context could be slightly different or significantly different, but there is still a lot of similarities and a lot of learnings across countries and across the sectors, which could be taken as good examples of best practices or kind of good examples of implementation successes, and also the common challenges which could be addressed at the policy level, the global, at the country level. Thank you.
Thank you. Just adding, one thing I like about the platform and the Global Alliance, you've come up with a practical path, okay, the 5-pillar approach that you have talked about. I really like it, and then I think that is the path forward. And as you rightly pointed out, it is a team sport. It is the public, private, and then also the government partnership which has to come together in order to make a difference. Apart from this, there are technological improvements which are happening, okay, especially with the AI coming in. There are models where you can actually simulate the heart, whatever happens for the women, especially add in the morbidities information that the women have, and work towards something like a digital twin of a patient itself. Of course, it's a vision, which is a little far away, but still there are steps which are taken towards that. For instance, we have an algorithm which can simulate the heart, the way it is going to work in next 1 year in about 5 minutes. And now if you add some of the information, profile it to a heart of a woman, it can tell what happens. At the same time, there are technologies which will help you to really predict, right, how the disease or the treatment is progressing, and then what are the different things that we need to do going forward. So I think we should continue the focus that we have across the government and then also the corporates and the different, I would say, ethnicity, and then ensure that we have the data collection and ensure that we have better precision when we are treating women. So with that, I would say we will continue the collaborations with the hospitals and with the women. And I think as women sitting in this room here, it's important for each one of us to go and share our experience, make people speak up. Of course, it's happening. Let each one of us take the responsibility to do that. then we can create a better world. Thanks.
Thank you. Tui-Ling, would you like to add anything to that? In terms of public-private partnerships and bridging the gaps?
Yeah, sure. I completely concur with the previous two speakers, my colleagues. To moving forward, we really need to further strengthen the multidisciplinary, transdisciplinary, cross-sectors collaborations. And as I have some experience with the tracking platform, I really like it because seems to trying to get to the bottom of the problem. Because to really address women's health issues, we need good data, high quality of data. We need to know what's going on. We need to have the description about what has been done. But one thing I noticed that when we came to national data about different disease problems, for example, endometriosis, PCOS, but there's lack of data. So I was thinking about, as a research academic, we really need to have investment in designing like good studies, maybe a global women's health study, try to capture high quality data. So this way, we have a gold mine for the future. We can really have something where we can rely on to address this critical question with women's health. Otherwise, without high quality data, without representative data, we don't know what whether we really tap on the right research question. What we know is really true or not. So that is one comment. I really hope the investors, the sponsors, they can think serious about having this kind of study, trying to collect high quality data across, like globally, across continental, across different sections. So I have other point I want to make, but I leave this opportunity to my colleagues. So
Thank you. Dr. Sumitha, would you like to add anything about how we can ensure that the women's health agenda remains a priority in the global health, especially in times of crisis?
Crisis, yes. This region, lot of some of my previous speakers said a lot of climate crisis, extreme weather events, also conflicts, lot of things are happening. And women being vulnerable, they at such situations they become more and more vulnerable. And again, among women, the extremes of age, the disabled, the migrants, they become further this thing. So I think collaboration is very important, learning from each other, how they are coping up with challenges, and also, having a resilient system. How, some area, some region, some country may be facing conflict, and how they are dealing with it, how this best can be done. We often do send our doctors and all. So the collaboration is very important. Data, of course, because India being a very, very big, huge population, so data validity, data, in time data, real time data, it's very difficult. And for AI inventions and all, which is the future to come for healthcare, data is, and sanctity of data is very important. So we can, always we look towards other regions with, smaller populations, smaller age group. What is the disease incidence? What is the prevalence? So that we get an idea to start with, because, collating data from so many units in India, it's a huge, humongous task. So collaboration is very important, and this happens like G20 happened, and their health was taken up very seriously for an equity-based, resilient health system. I think, especially in cases of normal conditions, we are sort of able to manage, and we can somehow got the idea how to do it. But conflict situation, of course, collaboration is needed, and a resilient system is needed.
Thank you. So I'm going to just turn us to close now. Thank you all for being a part of this.
Is left.
Oh, sorry, Neera.
I will not really take much of time, except that I did want to speak about the the role of civil society organizations, because governments do have the responsibility to provide the backbone of healthcare, but they can't do it all. And I'm actually just thinking as I'm sitting here, like we have a recommendation for the number of doctors per or healthcare per population. Does the World Economic Forum have a recommendation for what % of the GDP should actually be spent on healthcare by countries from different resources? Some kind of guidance to increase the spending, because I think that would be a helpful guide. And the other thing, of course, this is something I just thought about sitting right here, but I wanted to talk about organizations like Rotary and what a huge role they have played in supplementing government efforts like in vaccination. And we now have HPV vaccination coming up as the next most important innovation in preventive strategy. And I think that and other, of course, there are many others, Lions and so many others, and they can do a wonderful job, really. And what you spoke about, the corporates and the corporate social responsibility that we have in India, I think that's a model that has worked really well and should be replicated. Getting 2% of profits donated for certain sectors, and healthcare and women always figure, has been a great boost for bringing healthcare down to the masses. So thank you very much.
Okay, thank you. So just a few closing comments here, and I know we're a bit short on time, so I'll just ask if people have questions, perhaps our panelists could stay for a few minutes afterwards, and you could approach at the end of the session just because we're running short on time. I think we heard today that there are challenges, there are gaps, but importantly, there's progress, and we have things to be optimistic about. A few key takeaways for me that stood out is we heard about the power of data, in the sense that it will inform AI, and that is moving so quickly. But we need high quality data. We need data from low and middle income countries. We need data from different segments of the population that have been traditionally underrepresented in the studies. So we need ethnically diverse data. It cannot be done alone. We heard that healthcare is a team sport, and we need policy. We need policymakers, and it takes a village. We need to work across sectors, civil society, governments, researchers, funders, et cetera, to all work together. And by doing so, we can add health to life, because just being alive without health is not the goal. But we want to flourish as a society and as women. And there's a role for all of you in this room. I would say it's important to center our work on women. When women are at the table, they can help shape the decisions that are being made. Who does the work shows up in the work, and so we need that representation. So I would challenge all of you as a call to action as you leave this room, for the leaders, the policymakers, the researchers, the civil society, share your stories, share what you heard in this session today, and help us to move the needle. This is a big needle to move. We cannot do it alone, and we need everyone to come together to break down those silos, to work cross-sectorally, and to help to advance the health of women. It will also advance the health of men in our entire communities. So with that, I will close, and I want to thank all of you again for coming to the session early Sunday morning, and thank you to the World Health Summit Regional Meeting for including this panel. Thank you. And if there's any questions, if people want to approach our panelists can we take a few minutes? I'm looking at somebody in the back. Yeah, perhaps. Okay. I saw a hand in the back first. Yeah. Oh, okay. Yeah.
Actually, we had not touched the oral aspect. Oral health is very important for the fetus, the neonatal stage of the baby, and it has to be taken care of very seriously. And secondly, we are in the era of gender equality. So I feel since we are dealing with the women's health, men's health are also very important, and I have got cases of 2 deaths at the age of 55, the men, due to over-exertion and over-pressurization of the multinational company, did get severe, massive heart attack very recently, 2 weeks before. So we are very much concerned about our husband's health and etc. And I wish that some points can be, if it can be added, I will be grateful.
Thank you. Thank you. Next, Maybe in the front here? Do we have a microphone?
Yeah. Thank you very much, and good morning again. Ma'am, you all touched on constraint facilities, the prevention part, barriers to care. Uh, do we, I wanted to understand, are we looking at addressing the cultural aspects? And then how do we empower a woman to seek care? Are we pushing a health care or are they coming to the facility? I think that's a balance. I'm just trying to understand what efforts are being done over there. And in this context, I'm talking about 600 million women in the country. How do we reach and empower them so that they know when to take care, they should ask questions and they should come to the facility on their own, because that can fundamentally transform the way we're thinking the future of health.
Yeah. So the beeper keeps going off. I don't know if that means we need to leave the room or if it's okay to continue.
So, one of the things that we are doing, I work for Healthy Years, and then the CSR, as part of the CSR, we are trying to go and increase the awareness. That is the most important thing. At the same time, we are coming up with, the mobile mammo clinic, which will go to the places where they want. And very recently, we have put an MR in the container so that we can improve the access to care. So, we are trying both the sides, where we increase the awareness and then push them to come take care, and at the same time going where they are to provide the care.
Thank you. I think over here
Just
there was
a very, very quick one.
I would like
there-
to
there is-
add.
Yeah,
I'd
okay.
like
Many responses.
Yeah, that going to the community, going to the houses, that India has taken a very important step. We have community health workers, the officers who are placed at sub-centers, and 1,75,000 of them have come up, and each cater to, on an average, 6,000.
Yeah, it's a
So
lot.
it has come closer to their home so that women can approach. Then we have this linking workers, ASHA accredited. Again, that is a success story where they are linking each family, each mother, each woman, each child to the health system to
Yeah.
increase the point of contact. School health program. So it is reaching to the community because, see, it is important that when there is a secondary care needed or a tertiary care needed, they will approach the facility but the prevention, promotion, and the primary part, the system should go to the community.
Also
So,
linking with the Ministry of Education to put it into school curricula and to get the children to know it and to take messages home to their families.
Yeah, I'm so sorry to interrupt this, but I've been told that there is another session in this room. So we can step outside, and if there's additional questions, if our panelists wouldn't mind sticking around for a few minutes, we could address some questions
Okay,
outside.
the mental health part should not be left
The
behind.
mental-
That's a huge thing. It was not mentioned.
But can we,
because
can we talk about it outside, just because I think there's another session in here? Thank you. Thank you all.
हाँ इससे प्रेजेंट करेंगे हम लोग। नहीं ये लैपटॉप से नहीं करेंगे। सात टेबल्स हो गई ना, सात में भी है ना, सात हो गई मनोज की, ठीक है। हाँ एक और है, दो चेयर है, किसी को उठवाया ये तो दोनों डाल रहे जवान आदमी, दोनों मिलकर उठाना, अकेले नहीं ये अलग हो। हो गए सारे, एक और लगेगा बेटा इधर। हाँ उसको ऊपर उठाना बेटा, उसको बोतल पे नहीं लगे, माल को उठाओ, बोतल नहीं गिरे, कांच की बोतल संभाल के लो, इधर पे नीचे लगा दो इसे चेयर से। कहाँ लगेगा आपके पास ये ना, खाली वाली हटा देना बेटा, है ना, ये हटा दो, आधी यूज भी हटा दो, ये लगना है मनोज जी, ये लगना है, आधी खाली वाली हटा दो। ओके Okay, okay. Good morning. So while the others are getting ready, good morning, all of you. Welcome to this session on immunization implementation research priority setting. This session is being organized jointly by the WHO Southeast Asia region, IBD, and the Vaccine Delivery Division, and the Incline Trust International, which conducted the research priority setting. And for the panel discussion, we have our extremely learned panelist, led by team leader Dr. Narendra Kumar Arora, Executive Director of Incline, with Dr. Binod Bura, the lead for the IBD division at WHO Southeast Asia region. We have Dr. Arindam Ray from Gates Foundation, who has been leading the vaccine portfolio for quite a long time. We have Dr. Vivek Virendra Singh from UNICEF, and we have Dr. Anurag Tomar from NIMS University, Dr. Rahul Srivastav from, again, the IVD WHO Sierra Division, and we have Dr. Achishman Mahapatra from Grid Council. So how we structure this session is that we will start with a brief introduction, and then we'll give you an orientation about the research priority setting, what we did for the South Asia region, followed by the panel discussion, where we'll take forward how the research priorities identified will move forward and what are the action plans in further. So just to start the session, I'll request Dr. Narendra Arora to give a brief introduction and then take the agenda forward.
Good morning, friends, and thank you very much. Welcome to our distinguished panelist. And as Manoj told us, that we are going to talk about immunization research priority setting, research priorities for whole of Southeast Asia. The question arises, why should we be doing research priority setting? And before I say about that, I want to make two statements. One is immunization program globally is the #1 public health activity, not only, public health. It's the #1 public activity which has the deepest penetration. So whether we talk about coverage for primary vaccines, for boosters, no other public program has such deep penetration. Because our communities and populations do understand the value of vaccination, prevention. And it is almost like an insurance for a healthy and disease-free life. Now, with that context, when we now talk about research priorities, the question arises, should we be doing research in immunization sector? And the answer is very much yes. There are two reasons for that. One is, COVID gave us the example that suddenly, for the first time, almost everybody, all adults in this world were immunized. They were the target. And in India, we were able to give 18-year plus, 94% was our coverage for 2 doses. But we were able, and this was first time we were doing it. The second is that still a lot of pockets are there, or sections of societies are there, where children or even the other vulnerable populations are not reached. Now, it is in this setting that we need to constantly move forward and to see how do we reach this so-called zero-dose concept. and we will talk about that. The third dimension is that why immunization is important. So we are talking about today vaccine preventable disease, VPDs. But very soon we are going to talk about, and there are vaccines in the annual, that is that once the disease occurs, you give the vaccine to take care. So anti-cancer vaccines and even other vaccines which are coming up. Even for treatment of HPV, we are talking about treating it with a vaccine. Or somebody has already tuberculosis and you give a vaccine to see it complements the therapy. So various dimensions of vaccines are coming. Therefore, vaccine is an area which is very fertile, which has huge dimensions, and therefore vaccine research priority setting is extremely important as we move forward. And now we are talking about life course. So with this background, once again, we all welcome you for this session, and we would request a very active participation beyond the panelists from the audience also, and what you have, and please feel free to express your views explicitly. Thank you very much. Manoj.
Thank you, Dr. Arora, for giving us the context. Now, I'll take you towards the other side. Is research priority setting necessary? As Dr. Arora has alluded that, okay, it is very much necessary. Why is it necessary so much? Oh, everybody is getting the vaccine. Children are getting the vaccine. We have a very good coverage. Still, why do we require a the research priority setting for that? Because when we look at the research priorities, immunization is figured very minimally in the National Research Council or the research priorities which are set for the thing. We see NCD, we see cancer, we see the child health, nutrition, everything. But we don't see the immunization as a research priority in the agenda where we see, oh, research funding is being given. It is only meant that, okay, WHO will take care of the foundation, will take care of somebody else. But is that a national priority for the region? So I'll request Dr. Bura to give us a context about why research priority setting is necessary and what the WHO has its in portfolio, what agenda is to be taken forward. Dr. Bura, please.
Namaste and a very good morning to all of you. As our esteemed panelists and all our guests just initiated the importance of vaccination and how vaccination played a central role in this COVID pandemic. So last year in 2024, EPI completed 50 years globally. It was in 1974 that the World Health Assembly had first passed a resolution requesting member states to set up a formal vaccination program on completion of the smallpox eradication. And that's when countries launched their EPI program with very modest few vaccines, and since then it has progressed through a number of antigens worldwide. And a study done last year revealed that almost 154 million lives have been saved by the vaccination program. That translates to 6 lives saved per minute. So as Dr. Arora was mentioning, this is the biggest public health program which has foundation in every house, in every family, in every individual. We all have taken vaccines of some other forms, and we all eagerly want our kids, others to be vaccinated. But why are we talking about research-related issues on vaccination? Although EPI is considered to be a very successful program, we have eradicated smallpox, we are on the verge to eradicate polio, and many other diseases are under control. But unfortunately, in this world, around 22 million children don't get any vaccines. Last year, around 22 million children globally did not receive vaccines. So you can see the tragedy of those children. Even in our region, in our country, we have a significant number of zero-dose children, means who don't get any, and zero dose is defined as those who don't get the first dose of DPT. And there are lots of others who are partially vaccinated, who take few doses, don't complete their schedules. So to understand some of these areas, you need to have some insights into what is the reason. Is it a system problem? Is it a beneficiary problem, or something in between is happening? So I'd just like to highlight why research is important in that context. So we all know all of you know what is WHO, and we all think WHO is basically to set norms, standards, monitor the programs, tell the situations where things are. However, WHO also has a very strong responsibility is to shape the research agenda and to stimulate and generate and disseminate application of all these things that I've talked. So research is a very core function of WHO to advise member states on areas that need prioritization, areas that need to be invested in research, And based on that, as Dr. Manoj mentioned, we see a lot of research happening in other areas, but in immunization, sometimes we don't see, it's not very much visible that what is happening. Research led to change of polio vaccine from a trivalent vaccine, we switched to bivalent vaccine, then we had monovalent vaccines. All this was because of research, and we found that trivalent is not working now. We need a monovalent vaccine. So just giving one example that why research is such an important tool, Globally, the immunization program is driven by a topic called as IA 2030, which is Immunization Agenda 2030. It has 6 core functions. We are talking about a life course and an integrated program, coverage and equity, commitment and demand, outbreaks and emergencies, supplies and accountability, and there is a research and innovation angle in that. So at a global level, we have a pillar which we call as strategic priority number 7, and that pillar guides that we should strengthen and support all the member states to identify research priorities for innovations and to create local specific issues to be addressed out there. So at a global level, there is a mandate, there is a guidance to do that, and it has to be need-based innovations, how countries should go about that. And when we look at our Southeast Asia region, so within Southeast Asia region, we have our regional vaccine implementation plan, which guides all the member states of the Southeast Asia. And member states basically based on this guidance develop their national plans. In this plan also there is a strong focus on research and research component, And we basically advise this member state is to establish and strengthen capacities at all levels to identify priorities for innovation and to create and manage innovations, So it's an important element, and at every level this research is needed in order to understand the success as well as to understand the reasons and root cause why things are not happening. So I'll not go through that. This agenda is available online, we can share with you. But just some examples to demonstrate. There have been 6 public health emergencies of international concern in the last couple of decades. And out of 6, 5 had a vaccination response. We had swine flu. Polio is still continuing as a public health emergency of international concern. We had Zika, we had Ebola, we had monkeypox, we had COVID, and we don't know about future. We don't know what will happen in future. There are so many pathogens and viruses which are of life-threatening nature, and the moment they jump to human beings and there's a human-to-human transmission, we'll be in a big trouble, And so we need to have all elements of our research ready. In last couple of years, 23 new vaccines have been introduced in this region, and there are 6 other vaccines which have been planned for introduction and for expansion, and all these introductions have a research component, whether you have to look at the disease burden or you have to look at the demand or the providers, caretakers, barriers, what are there, So there is a strong component on research, Just for example, I'll just explain you these slides. We have these key elements for new and underutilized vaccines. When we talk about a vaccine introduction, we talk about disease burden, vaccine efficacy, safety, cost effectiveness, affordability, program capacity, and availability of production, domestic or regional, And then there is a component of research. From the time the vaccine is discovered or it is ready, by the time it is implemented, it takes a lot of time. So vaccine, to create a vaccine, it takes almost 5 to 10 years at times to produce a vaccine. But since it is produced, to its utilization, there is a long lead gap. And what is the problem? Why these vaccines are not being used? I'll just tell you, we all have heard of typhoid. And I think everybody in our family has suffered from some typhoid. But still typhoid is used only in one country in this region. And this region is considered as the global hub of typhoid. Every hospital, everywhere, European doctors write suspected typhoid, and we don't have typhoid vaccine being introduced. And vaccine is available. Our neighboring country, Nepal, has introduced typhoid for all the children. Last year, 2 years back, they've introduced. So what is missing? And there are examples of other vaccine. We have HPV vaccine. We still have not introduced in India and in DPR Korea in our region. We have rotavirus vaccine, which is not introduced in some members' place. Pneumococcal vaccine is there. So typhoid is a very classical example that what is lacking to introduce these vaccines. And I think that's where the topic of today on research and innovation comes into play. That what are the areas that we have to look into more closely, what needs to be researched, what needs to be more better understood in order to use these vaccines. And these vaccines are life-saving. I mean, typhoid, we get very few deaths, but the amount of out-of-pocket expenditure we get from typhoid, or the children who don't go to school because of a pain abdomen and fever, is enormous. School absenteeism rate in Nepal were 10% pre-introduction, and they fell down to 3% post-introduction. Just as a simple of hand washing and typhoid vaccine introduction. So I think in that context, there's a lot of things to be discussed in our session today. Again, at our headquarters and at our regional level, immunization is a priority, as I mentioned. And in Southeast Asia region, immunization research, we have looked at the prioritization. We've done some immunization research taxonomy with Dr. Arora's team out here. And we want to bring the program and academia on the same platform to understand what the research tells and what the program wants to do. And the regular dissemination of important research publication is also very important in this area that we have started at our regional. So I look forward for a very thoughtful discussion in next 90 minutes. And again, I would encourage all of you to please ask questions. There's no wrong or right question, but I think we need to stimulate why and what research is needed to better implement the immunization program. Thank you very much.
Thank you, Dr. Bura, for giving this context of the research priorities for the Southeast Asia region as a whole, and also for the WHO. Now, moving towards the research priority setting, what was undertaken for the Southeast Asia region in the 2024, all of us know that research priorities are important, but there is also a need for systematic documentation and process of priority setting. Otherwise, traditionally, we have been doing actually through a group of experts sit and, oh, this is my priority, this is okay, we all agree on this is the priority and taken forward. But that's how the things have started, but over the time, we have refined the methodologies for research priority setting, and we have used a methodology which is called the Child Health Nutrition Research Initiative methodology, the CHINRI methodology called. So we'll give you a brief about what we did for our research priority setting and what were the findings from that. This research priority setting was undertaken by INCLIN with the collaboration and the guidance from the WHO, and all the 11 countries in the region were included in this. Okay. So I and Dr. Rahul from WHO would be sharing the presentation to give you a brief, because on that basis we can then take the panel discussion forward. So the outline is that we'll give you a, can we have the presentation visible? It's not visible here. Yeah. So the outline is that first we'll give you some of these research importance of the priority and research which have been given, and we'll give you some orientation or information about where we stand in the Southeast Asia region, followed by the activity of the research priority setting which was done, and then the way forward. I'll request Dr. Rahul to take it forward, the initial sections, and then I'll, Dr. Rahul.
Thank you, Dr. Manoj, and very good morning and namaste to all the panelists and all the audience up here. So in next 5 minutes, I'll be just taking you to a brief, setting up the scene that why this prioritization exercise was done. But before I start, I would like to comment that since a very long time we have been discussing that, to prioritize immunization research, to prioritize implementation research in the field of immunization and vaccines. While we are discussing this, prioritization exercise, the need for data, the need for evidence is exponentially lagging, meaning that we are actually, going very slow, and now it's a high time that, we very quickly move forward with the prioritization and start implementing impactful and actionable research, which actually is going to help the programs to strengthen them. Moving forward, I mean, just continuing what Dr. Vinod Bura left, the importance of research. So this is, a trend of immunization research conducted in the region. So we are very happy that we are actually doing a lot of research. But when we compare to the global, the amount of research which is being conducted is very few. We are almost equivalent to, say, about 5 or 6% of the global ongoing immunization research. There are many factors related to it. You may call it a funding or lack of enthusiasm to do research or to publish them. So there are many factors, but still the numbers are quite low. So that's something, a trigger for us to prioritize research in our academia, in the program, and as well as advocate very strongly with the government. So we can see that there has been a plateau, but there was a peak during 2022, and we all know why this peak came. It's because of COVID. And this is something which I would like to touch a bit more towards the later of my presentation. So amongst the immunization research which has been done and which we studied in our bibliometric analysis, we found that 35% of the research is related to the development stage, and which is quite evident. The region is a hub of vaccine production. We produce almost 46% of the global vaccine needs. And this makes a case. The same thing is shown in this slide, that the 35% of the research is being conducted because of being a manufacturing hub, and most of the research is being conducted by the industries. But what about the later part, the epidemiological part and the implementation part? It's quite low, and that is why it's very high important to focus on these. Now, when we started of thinking that we should do a prioritization exercise, there were several factors associated to it. The first was resource allocation. We all know that resources are limited, and resources are always going to be limited in future. So that is why we need to be smart, and we need to be efficient in putting these limited resources in the right area. There are many agencies, there are many institutions, there are many, even I would say, governments of the countries. We have very similar objectives, overlapping objectives. And we are actually, if you go through the research articles, we can see that there are many duplications. So now it's very important that, we should start talking with each other. Do not replicate or duplicate these activities. And the prioritization is something which is going to help us in doing this. So that's why prioritization was very important. And that is where, the field of collaboration is very important. We, a day before yesterday, on the first day, we had a very important session on vaccine regulations, where DCGI was there, the head of regulatory aspect from Indonesia was there. There were very esteemed panelists up there. And one of the most common word during that session was collaboration. Collaboration. So that is why, we need to start talking, we need to collaborate, and we need to ensure that all of us are on the same platform. Now, we talk a lot about research, doing implementation research. It is very important for us to add a word before implementation research or research. Let us make it impactful implementation research, a research which is needed. It's not only for the publication. We should understand that what the program needs and do those research which has policy implications. Just increasing number of research will actually, force us to use these limited resources in not a very efficient way. So that is why it is important to do impactful research. That strategic planning, that's again, I will like you to go back to the first slide where there was a peak during COVID-19. So this peak was there because the resources were available that time. Everybody was analyzing the knowledge gap by themselves and then doing research, which actually led to very unregulated kind of research, and many of those research were not very impactful, meaning to say that there was an infodemic as well during the COVID-19 period. If those resources would have been very judiciously used and ensured us that we do impactful research, the outcome would have been a much better and much expedited way. So for this research prioritization exercise, there were several models available to conduct this prioritization exercise. And to be very frank, in around 2018 and 2019, WHO did an prioritization, did an activity where they analyzed that how many prioritizations are being done. And it was shown that there were thousands of prioritization exercises done. Unfortunately, those prioritizations were done on paper, the report was generated, but those, the report was not used. So WHO came up with a very strong report that we need to be very careful in doing prioritization. We need to adopt a standard method of doing prioritization, and we have to, the real exercise starts when the prioritization is completed. So, and during the same time, WHO also recommended 4 or 5 ways of doing research prioritization. One was the CHNRI method, which Dr. Manoj mentioned. So in that method, we first identified the stakeholders, and one of the most important stakeholders of this exercise were the program people. So for the first time, we ensured that we get very heavy inputs from the program, from their needs, so that in the final outcome, their needs are very well documented. Then we defined the context and criteria. Then we identified the evidence gap. So this is actually a new phase in the CHNRI model, which apart from doing the desk-based work, we also did a bibliometric analysis just to see where the knowledge gaps exist. And then we created a matrix, and then once the crowdsourcing was done, we matched the bibliometric exercise with this crowdsourcing methods. Not a part of a traditional CHNRI method, but it was adapted based because the neo trend which is coming is assessing this evidence-based gaps. Then we formulated the research questions, we scored them, we analyzed them, and then during our regional immunization technical advisory group meeting, which happened in August 2024, where it was more than 120 stakeholders participated, being a partner, being from the EPI program, WHO, all the people. So we again, started going back to them and asking them what are the priorities which they think are important. So some of the people who attended those meetings, I'm sure they must be remembering how we troubled them to, fill that 4 or 5 page questionnaire during our regional ITAG meeting. So this is the CHNRI model. I mean, a model which has been developed in 2008, very extensively used. It's a bit flexible. It's a very systematic approach. There are several advantages associated with it. It involves a consultative method. It's very transparent. It's replicable. We can replicate it. And then it's, again, a very comprehensive method. So now moving forward, I'll again invite Dr. Manoj to take forward the methodology part, and I'll again come back with the way forward section. Thank you.
Thank you, Dr. Rahul. I would like to add here that the CHNRI methodology, although was developed in 2007, it was actually advanced during 2010 onwards or so, where it was used actually more than 150 research priority settings globally, and INCLIN was the secretariat also for CHNRI for about 7-8 years from 2010 onwards. So during the last decade also, we conducted the largest research priority setting for Indian Council of Medical Research in India on the maternal child health and nutrition research for India. So taking the experience from there, we did this exercise for the research priority setting in the Southeast Asia region, where, as Dr. Rahul mentioned, that we did a literature review and also the bibliometric analysis of the gaps and also potential domains. So we identified over 13 research avenues. So avenues are actually the areas where the research can be taken up, but these are not the questions. These are only the bullet points under which several sub-points and the specific research questions can be listed. So if you look at that, the domains range from the security, infrastructure to supply, the AEFI or vaccine safety, the data decision making, the social and also the epidemiological plus the anthropological aspect, also the risk communication, including the vaccine preventable disease surveillance and the linked ones. And within this, the 13 research avenues, we asked the people to contribute their ideas, their options and their interests which they should take it forward. And then we invited the relevant experts and the contributors from program, from the academia, from the researchers, and also from the policymakers and the WHO and other people who are the UN agencies who have been facilitating a lot of these vaccine-related activities in the countries. So we got about 1,347 options from these different people from different countries. And just to tell that all 11 countries were involved, and every country with participants or the experts contributed to this process. And then a group of people, we sat together and looked at each other. There were a lot of overlaps between these questions and the options, and we consolidated them into about 43 research areas of the options, and we consolidated them into about 43 items to be taken up for the scoring. And these 43 items were actually put forth for these experts again to score. And these scoring were done for the 5 criteria. If you look at the answerability, relevance, innovation, equity, worthiness, or the cost effectiveness, and then we asked them to score in a whether they would like to take up this research question and consider this as a relevant or not relevant, and they would like to recommend this one or not. And then what we did as an additional thing is that we asked for a larger reference group. And Chinri has actually a crowdsourcing option, plus it has also a weightage given for the policy and the program decision makers, how they would like to invest on these research options or the points which are emerging, because they have limited money. And they have a lot of questions which are put forth by the researchers. So how they allocate their money into different baskets. So the larger reference group, we included about 15 experts from the region for who were the program manager, the secretaries, and also the investors on this. And they assigned that what points are relevant for them and which one is weighed higher. So if you look at that, relevance, equity were the highest weighing criteria, followed by the answerability, innovation, and the worthiness. So these criteria were applied while getting the scores. And we had 2 types of scores. One was the unweighed score given by the experts or the people who scored, and then the weighted score, and when we applied the larger reference groups preferences or the weightage to get a final score. And then we analyzed these parameters. And so this was the description of the stakeholders who contributed from the different regions. So we had a near reasonably equal distribution of the gender and also countries wise. And if you look at that, all stakeholders from the immunization and vaccine research and investment were participating in the process of contributing and the scoring. This is how the scores look like. So if you look at in these, there are the areas which included our 43 areas which we took up for the scoring, and then the 5 criteria for the weightage, and then we had a IIPS, which is the intermediate research priority score, followed by the rank based on this. So whoever got the higher score got up on the rank. And then the weighted RPS, which is the weighed research priority score, when we applied the larger reference group preferences to this, and then we got the weighted priority score rank also. So if you look at this is for the first top 10 or so, we don't see much difference between whether this was weighed by the larger reference group or this was indicated by the experts who scored them. So we got these assessments, and then this is how we did for all the 43 domains. And these are the research priorities which we got. And if you look at these are the top 10. And the top 10, if you read, these look like, okay, health system readiness and adult life course vaccination, socio-behavioral and the anthropological context for the vaccine hesitancy, because we all know that, okay, hesitancies have been, acceptance have been emerging as a key thing. And then decision making based on the evidences. Then sustainable technologies for the cold chain infrastructure and the logistics. Then sustainable financing. All the countries are facing actually introducing new vaccines and sustaining them. So financing was one of the key things. And then coming to the epidemiological evidences to use the underutilized vaccines or push the underutilized vaccines and add new vaccines. Then the data models and the interoperable systems for getting the data from different sectors, from immunization, from the vaccine preventable disease, from the delivery systems and the cold chain logistics systems. Then for the introduction of new vaccines, what tool and what systems would be used to do that. Then vaccine preventable disease surveillance linked to the other disease surveillance, including the environmental surveillances, and then the epidemiology and the background rates and those things related to the adverse events, because vaccine safety is important. As the vaccine is increasing, we are also facing the issues of vaccine safety related issues. These are the next 10, the 11 to 20 research priorities, which includes the health functionary capacity competence, innovative technologies using for the vaccine delivery and the vaccine preventable disease diagnostics, Then the evaluation of the zero doser prevalence. Why are we missing the children getting vaccinated or partially vaccinated? Use of the digital and social media for addressing the vaccine sentiments and then addressing the hesitancy issues. Then integration of the services with the other existing services like the nutrition, the primary health care and the social security systems, point of care diagnostics related to the vaccine preventable diseases and the surveillance, including the multi-pathogen surveillances, then identifying or the strengthening the partnership from the different sectors, the academia professionals and the investors, then investing on the social determinants of the vaccine preventable disease and the vaccines, then public health and the epidemiological impact of new vaccines introduced, then evaluation of the feasibility and incorporation of the live course vaccination on the whole program and on the other systems. These are the 21st to 25th, where the VPD antimicrobial surveillance integration, decision-making tools and protocols, immunization program performance and live course vaccination strategies, including equity, vaccine wastage, and reducing the environmental footprints of these vaccine waste which is generated, and the challenges related to the new vaccine introduction. So the strengths were that these contributors were from various domains and sectors, so these are not limited to only the researchers or the program people or from the development sectors, and involvement of all people, the adjustments from the larger reference group and the decision makers. Also we used 2 questions as a validation effort also, so that okay, whether these were all getting only as they are scoring, we added 2 questions which checked up as a validation, and we got a very good correlation between them for the validation. So we thought, okay, the scorers were getting the things good. Challenge was that although we got a response, but lot of these items were actually going across domains. And if I can tell you, Chinri considers the setting or the items under 4 Ds: the description, discovery, development, and delivery. So these 4, and there were a lot of overlaps between some of these domains: the development, delivery, and description. So description is the epidemiology section, while the development, delivery, and the discovery were actually the things which are new, either to be done in a new manner. So there were overlaps which we cannot actually avoid to a large extent. I'll request Dr. Rahul to summarize and then take it forward.
Thank you, Dr. Manoj. So I'm sure that you must have had a very quick glance on the 25 priorities which have been developed, and it's very interesting. Some of the priorities are our traditional priorities, which we are talking for decades, and some of them are very modern. We talk about, multi-disease surveillance system and, use of technology, developing model. So now we have 2 paths to choose. One, I'm sure that these research must be going around, somewhere in some country at some point of time. So either we move forward, we become active and start doing it and become independent and without waiting for, the research products to come from the other part of the globe. Or the second is we can still wait, we can be slow, let's wait for the other countries to come up with the research products and then we start utilizing them. So by following the second path, the advantage would be that we would be saving some of the resources because it's being done somewhere else, and we would also be having a very easy life to go in. But if we take up the challenge, I'm sure the resources which we are saving by not doing this research, we are actually using this saved resources in many folds time in duplicating activities, in doing the interventions not in a right way. So I will urge all of you, all the academias, everybody, the partners and everybody, so let us be very active, take up these priorities and move forward without waiting for the research products from the other part of the globe. So amongst these priorities, 70% of the priorities are the operational research. So that's quite evident that where the main challenge lies. 30% of them are related to epidemiology, vaccine development, and strategic modeling. So this strong operational focus is very much aligned with the real-world challenges like vaccine rollout, system integration, sustainability, and pandemic preparedness, which actually perfectly balances the immediate field needs with long-term disease control strategies. Now, the critical emphasis is placed on behavioral and anthropological research to tackle the vaccine hesitancy. That's an area which is, coming up very strongly, and we need to tackle that because, the new vaccines like the TB, dengue, whatever we are talking, these are all complicated vaccines, and we need, very strong data and a very strong community mobilization as well, because these vaccines could be a very important game changers in coming time. Now, moving forward, the priority list which we have showed is not a static list. So it's a list because new needs is going to come up. So it's a list which we are going to modify, include new priorities, remove the priorities which have already been done. In short, making it a dynamic list. So every year, maybe once or twice, we are going to modify this list. So all of us should always keep a watch on what the current or the new needs are coming up. Then as a WHO, what Dr. Vinod mentioned, that we will be very actively sharing it so that, there is awareness amongst the research community that what exactly the needs are. So we have created a WHO dashboard, which I'll be showing to you and would be coming online very soon. Then our another effort would be to bring the program people and the academy on the same platform to make them talk. Make the program people, make the academy understand what the needs are. Then at WHO, which is our core activities to catalyze. It's very difficult for WHO to take up all these 25 research activities and start doing them. So we rely very heavily on the member states to conduct these activities. Our role is to to catalyze those research. We can talk to partners. We can do several activities to initiate the activities, but the onus lies on the member states. Then. Just as a step in the same direction, we actually come out with publication or sharing of important research activities every month, just to ensure that the important research products which are available is very well communicated to the program people. And also we are going to make the prioritization research activity as an agenda item in our regional immunization technical advisory group meeting. The topmost technical advisory group which makes recommendations for the member states on immunization. So this is the dashboard. So on the top you can see all the prioritized activities, then in which area of activities these research avenues lies. This will actually also help us in monitoring that, where most of the research is going on, so that, it's not important that we target all 25. We should target the one which are the most important ones and where the work is not going on. So that's why we have created this dashboard, and it should be online very soon. So thank you very much. Happy to answer any questions.
Thank you, Dr. Rahul. And I think without wasting much of time, let's move forward to the panel discussion, unless we have some questions which are urgent to be clarified. Okay, so we have introduced all of you the extreme learned panel. I'll take the first request from Dr. Bura. So looking at the results from these research priority setting, and how do you find the research priorities identified align with the global immunization agenda 2030 and the NITAG's priorities at the country level? Because WHO considers that, okay, the region has to move forward also both at the regional level and also the country level. So how do you find these things being applied in which, although you have told us about some way ahead for your thing, but can you further elaborate on that?
Thank you, Dr. Manoj, and also Dr. Rahul for presenting this whole scenario of the research work. So if we look at the immunization agenda, which is the global guiding document IA 2030, it focuses on vaccination as a life course approach. That means vaccines are for all ages, depending on the disease and the need. And then there are some regional vaccines also, which are not for the whole world, but it's because the disease are very much localized. So some of this research basically addresses those needs which will come up. Another big challenge is on equity, to understand the need, what are the social behaviors as to why some people don't take vaccines, why some take, and why people don't want injectables, they are comfortable with the oral vaccine, and what is the understanding of a health worker when she has to give
multiple injections at one time. So what are the barriers, knowledge gap barriers, I think. So a lot of these research activities will address the challenge issues which are in the global immunization agenda. And also from the regional perspective, you know, many countries were and are being supported by Gavi for their immunization program to introduce their own vaccine. But gradually they will go out of Gavi, like India has graduated out of Gavi, you know. So the financial sustainability of these programs is very important, and doing research to understand how these programs can be self-sustained. And another area of our regional priority is to ensure we learn from this COVID pandemic and have better preparedness on outbreaks and response mechanism. How countries can ensure that they have the right skills of surveillance, they have the skills of the laboratory, and they have the delivery mechanisms. So now is the time to prepare for the next pandemic, not when the pandemic hits. Yeah? So a lot of research is needed into vaccine development, and what are the the threat pathogens that we have where we need some. So I think these 25 priorities, I think, are very well aligned on the global and the regional priorities. You know. Thank you, Dr.
Thank you, Dr. Vinod. And, you know, very rightly said. And I think the key word was, you know, now is the time to invest on the pandemic research. We should not wait for the pandemic to happen and then we start thinking and we start doing. So now moving forward, I'm going to my friend from UNICEF. Both of us are on the same board, Dr. Vivek. So, Dr. Vivek, my question to you is, how do you see UNICEF's role in taking these identified research priorities on immunization at country level and at the regional level? I'm sure that there would be many challenges.
At the outset, I thank Professor N.K. Arora, sir, and the organizers for inviting us to this very important panel. Very pertinent question. I can speak from the India perspective. I'm the Chief of Health for India, but it makes large part of the region, so that will add to the regional perspective also, I'm sure. Value of research and what we want to do with it. I'll take 3 case studies. And I'm looking at NK sir again. India was spotlighted recently in the UN IGME estimates for mortality reduction. Exemplar, spotlighted with 6 countries globally. ICMR did a research priority setting for the country, 10 priorities. And we were referring to a RMNCHA research priority setting exercise, which was led by Professor N.K. Arora, sir. And that is what we were using in all the states across the country, when we were going state by state to have context-specific strategies for child mortality reduction. Reminding that within your resources, where do you get the best returns for your investment? So that was the document we were using, and very much aligned to the research priority setting then happened at ICMR. So this value of research, very rightly said, day to day, you know, where to focus. Like when we say, are you playing blind or do you have a sight? So I think this value of research everybody knows. But coming to vaccine research, I want to hold the thought to the fact the most important finding is that 70% is around socio-behavioral. 70% is around socio-behavioral. You have the world-class vaccine, but if anything goes wrong in the community, you will not be able to deliver that product. So I want to use 2 use cases. Measles vaccine in the 50 years of UPI has saved more than all the vaccines combined, the number of lives saved. Out of 154 million lives saved, 94 million is by measles alone. And today, if you see in the US and other countries, they are saying measles vaccination leads to autism and all of that. Socio-behavioral issue. So you have a best buy, proven globally, yet something goes wrong, and if there is, you know, the people who are not using evidence properly or the communication of the science is not proper, then the other side wins, and you still start losing gains from a proven vaccine, which has proved saving lives more than others combined. The second use case, let's take the use case of HPV. HPV was first launched in 2007 by Australia. 20 years, and a country like India will be doing it now, 20 years. Now, another use case, out of HPV, 74% of WHO member states that have introduced, 24% have gone on to gender neutral HPV. Because boys and girls, both, if they get it, then it's even more effective. And we are yet to launch it. Why? Again, a case of socio-behavioral. Something happened in 2013 when, because of the lack of research, the fraternity in the country was not able to prove that whatever few deaths that happened were not linked to the vaccine, but were linked to other factors. So these are all elements that you can see in the research priorities, which are around socio-behavioral, which are around surveillance, which are around AEFIs. Because had we been able to quickly, swiftly prove that these were not adverse events from immunization, but these were other issues, then we would have stopped it. Now, this use case is very important because despite the best intent of the government, India has done remarkably well in immunization programs and with a lot of intent. Despite this fact, politics is such that nothing could be done after the 2013 incidents. So these two cases prove that research in every component of the health system and in the process is required and needs to be used. That we'll do it. And I'll close by saying we are sitting at the World Health Summit, which has now been translated into a World Health Summit Lancet Commission. It will be a 3-year commission, which will have 4 mandates. And I'll just read the last 2 mandates given to the commission. The last 2 mandates are, how can academia simplify science for communication to society? And I think that is also very important. So I think that's one thing that we would do as UNICEF, how to simplify science for communication to society. And the 4th mandate given to this commission is, then how do you use that science communication for societal change? So as you rightly said, if I have a publication in Nature or Lancet or whatever, it doesn't end there. Was I able to explain to somebody who's refusing vaccine in the village that why this is important? And that is, I think, where the fraternity can play a role. Thank you.
Thank you. Thank you so much, Dr. Vivek. And, very important points, especially, the last one about the commission that, the evidence is not only for the policymakers to frame policies. These evidence should now even go to the community to build the trust. I think that's going to be very important. Now, moving to our next panelist, Dr. Arindam Ray from the Gates Foundation. So, Dr. Arindam, I would like to ask you that how do you find these identified research priorities align with Gates Foundation's agenda and activities at various levels, keeping a balance between implementation and new research and development?
Thanks, Rahul, for asking that, and I hope it's not a trick question for Gates funding, because that's way beyond my pay grade. But first of all, thank you, INCLAIN and WHO Sierra for, for organizing this timely event as we celebrate the World Immunization Week, and this week in this World Health Summit. So, the Gates Foundation actually follows a 3D value chain for vaccine and immunization programs, which is starting from discovery. That means you are coming with different candidates of different vaccines or technologies or system innovations, and then the development, so that you can take those ideas to scalable production mode. And then the third is the delivery. So discovery, development, delivery, that's what we do. So the priorities that have been enlisted here very much resonate with the overall, the philosophy or the work plan or the activities that we are following up with a whole ecosystem of partners across the globe, and particularly in the Southeast Asia region as well. I can call out a couple of them, but before that, I just like to have a little bit of pointers or principles that we follow while deciding our priorities for research, as well as some mechanisms through which we take it forward. So the first principle is actually aligning with the priorities of the country government or the program. So, and that may vary from geography to geography, region to region. Contrary to some of the popular critics, being a private foreign philanthropic foundation, we need to operate within the priority framework in a particular country, as mandated by the government, agnostic of regimes. So that's a very vital point. The second is, our work is always for impact and how we can accelerate that impact. Because while all the governments are dedicated to serve their citizens with certain services and goods, they may have certain limitations in how they operate, particularly in terms of, I would say, the capability to absorb risk and their capability also to engage with the private sector. Because these are the areas where being, a private foundation, probably we have a comparative advantage and more freedom to operate, to engage with a wider set of partners. And that's how we can actually bring more out-of-box ideas to dwell in and to develop. And our risk tolerance is quite high. So suppose if, I'm seeing Dr. Mathuri sitting here, if suppose ICMR is investing in something cutting-edge research and that product fails, you have to kiss 1,000 frogs to find a prince, right? The government doesn't have the luxury of unlimited resources to actually, why vaccine used to take, say, a decade to be developed? Because the probability of failure is pretty high. Now the question is, being custodian of public resources, you don't have that mandate because you are under kind of a very stringent audit system which will question the expenditure of every rupee. Now that's probably one of the comparative advantages that the private foundations can bring in, where we can absorb those risk of failures. And when we are partnering with a, say, for-profit private sector who are innovating a new technology or a new product, be that vaccine, be that some kind of a delivery system, or some kind of an app or something, there is no guarantee or assurance at the start of the innovation cycle that the product will actually succeed. But the partner is investing their huge resources into that. And if we can offset some of those risks, and if we can provide some of those resources to them, then they will be in a further advantageous position to actually take up that kind of research or innovation project. And that's one of the reasons why the upstream research on vaccines, or some of your research priorities, I'm looking at vaccine product development or newer vaccine development, why those researches didn't take place that much in the global south. Most of the earlier new vaccine breakthroughs came from the global north because they were carried out by the MNCs who are situated in the north. Now I think, one of the, I would say, game-changing thing that has been delivered by, foundations like ours is that we have helped to build an entire ecosystem of developing country vaccine manufacturers. The fact that India exports almost 70% of vaccines used in all the LMICs, particularly Gavi-eligible countries, itself is a testament to the capacity that we have. And Serum Institute is, by volume, is the largest vaccine manufacturer. And there are ample examples. It started with Menafrivac vaccine development, which now control the entire meningitis epidemic in the African continent. But I will not list down all of that. We have helped over these 25 years, almost 13 vaccines that way for the new vaccine development. But from the India, if you take up, we are speaking of the typhoid vaccine. So we have 4 typhoid conjugate vaccines available. 3 are WHO pre-qualified, and those are being used in other countries. And the first one of them was developed with our support, which has been tested and tried and already adopted in other programs. So, so the alignment and in the risk absorption and the being able to engage with the private sector. The third principle that we are following is engaging more and more with the domestic institutions. So what Vivek pointed out about the following the ICMR research priorities. So, you know, I mean, we are here on invitation of the government. We do have 2 memorandum of cooperation on program side with the Ministry of Health and on the health research side with ICMR. So within that MOC framework, whatever research priorities ICMR is identifying for the country, we are trying to bring catalytic help. At the end of the day, our resources are pretty much limited. But what we can unlock is probably the potential resources on right track from the domestic funding, as well as we can bring the needed global partnerships and innovations that are happening elsewhere. And that leads to the 4th principle, which is Rahul, you mentioned, collaboration. So what we call the translation and research is from laboratory to collaboratory. So we actually has established a global discovery collaboratory, which has 3 components. One has incubator function, which actually promotes all these original research in partnership with academia, private startups, or different kinds of research institutions. The second is a kind of a platform where all the partners can get free access to the tools that are being developed. So what you are saying that should we wait? I mean, you don't need to wait what others are doing if you actually come to know that what exactly they have achieved. And if you get an option actually to collaborate with them. So if you see that this is completely aligned, you can become probably an extended site of their investigation for the same project. Otherwise, you know, resource is limited everywhere. Otherwise, we may waste resources in duplicating things which are already happening. So that's why collaboration is much more important. The third prong of the collaboration is strategic initiatives. When you have identified a particular program, whether you can deliver a 360-degree outcomes on that. I would quickly give the example of rotavirus vaccine for India. You know, it's all started with a New York Times article of how Mumbai slum children are suffering from this. And one fine morning, Mr. Gates woke up to that fact. And that's probably a moment of inspiration. But what remains is that, so I think the socio-behavioral issues are being highlighted, but I would also like to point out there might be even more scientific solutions to some of the things which we do perceive as socio-behavioral. Say, for example, the measles vaccination uptake. Of course, autism is a huge thing, and I mean, we need socio-behavioral solution. But would it also be possible that, say, fear of injection is actually preventing something? Should we move towards a microarray patch, which will be much easier to administer, which may make this vaccine deliverable even at household level? So, you know, there might be even more innovative out-of-the-box solution for those kinds of things. So for Rota, the question came around, it's not the non-availability of the vaccine. Already the vaccine was available. What was not available is whether that vaccine could be produced at scale with quality at an affordable price that the country government like ours can adopt into the program. So foundation took a kind of a mission is to produce a quality WHO PQ'd vaccine in India at $1 a dose. So you are setting up for a kind of a challenging milestone, and that's where the value proposition lies. And ultimately, all of us, or at least in this room, know the history that in 100 years, what Roger Glass mentioned, that this is the first vaccine which was produced in India, discovered in India, and all developed by Indian scientists. And Professor Arora is here, who was associated with the vaccine since from the very inception from the isolation of the virus strain, so probably you can hear all the story from him. But just isolating and developing is not the first factor, first D, right? The second comes how you develop it through the manufacturers, and that's where Bharat Biotech was born. I mean, it was their first viral vaccine product, but then you need all the safety guards. You are talking about vaccine safety surveillance. And so INCLAIN was the first to actually test it in a kind of a program way and have a both retrospective and prospective surveillance for safety events around rotaviral vaccine. We also supported rotaviral safety surveillance by other partners, and that enabled the government of India to bring a white paper that there is no incremental risk associated with the indigenous 2 vaccines that we supported production here. Not only that, that helped the market to open globally for these indigenous vaccines based on the SAGE recommendations. But then when the vaccine gets adopted, you need to provide the TA to the government so that you can streamline the rollout and you can mitigate all the vaccine interrogation risk, including the communication challenges. And that's where partners like JSI and others played a huge role. And then also you need to measure the impact that vaccine was not there, rotavirus incidence was like this, now vaccine is there where we are. And that, that work was led by Dr. Kang from CMC Vellore in collaboration with other partners. But these are all happened in a kind of a very interlinked ecosystem way. So we ensured that every partner talking to the other. So INCLAIN, SHAS, CMC Vellore, KEM, everybody, I'm looking at KEM friend actually. So everybody was part of that ecosystem which actually made it possible that it happened. Now, which is also heartening, and we were just discussing before the start of this discussion that many of the polio lesions we didn't document. I mean, we are so busy in implementing it on ground. But Rota, I think, is a bright exception that from the discovery of the vaccine to the last mile implementation and impact evaluation, I don't know, I lost counts. Probably there will be 100 of publications which have come out of India. And I think that summarizes and that how we actually trying to build a research ecosystem. I just would like to highlight 2 points and I'll then finish it. One is we strongly believe in an open research, open data system. And for all our partners, I think you already know, but still I like to just highlight that our open data policy is little bit revised, open access policy for publications. Earlier, we were supporting all the open access publication fees and everything from the projects that we support. Right now, that has been withdrawn since 1st January 25. What we are doing, because we are seeing that is also creating a kind of publication apartheid with a bias towards a group of journals. So what we are doing, we are developing a partnership with PLOS. So you are very much welcome to actually submit your research products to PLOS, where you may not need to give any access fees there. But we are also encouraging to first submit your research product in some kind of a preprint, any of the 3 preprints which are valid. Because we believe, and all our projects have a global access clause in the agreements, that all the products which are coming out of it, even if it is proprietary, that has to go through some kind of a global access agreement. Otherwise, you would not get a vaccine $1 a dose. So that's the point. And secondly, we believe that this is catalytic what we are doing. Ultimate funding and ultimate sustenance of this entire ecosystem would be from domestic institutional capacity and the domestic funding. Thank you. Sorry, I probably.
Thank you, Dr. Arindam, for actually citing the Rota wheel, how the wheel actually moved in India from the inception to the thing and also the thing. Now I'd request Dr. Anurag.
Sir. Tell you the HPV story is also going to be something similar. Because foundation.
Yeah. So now I'll request Dr. Anurag Tomar to actually, you have been a clinician. You have been also a professional association member for the Indian Academy of Pediatrics, and we all recognize that the vaccines, a large section is being given in the private sector and also being taken up by the pediatrician and the clinicians. Without them, a large section will not move. So I'll request your views on that. How do you see these research priorities on immunization and the other things from an academician point of view and from a professional point of view, and how does it resonate with the professional, the clinician, and how do you like to contribute to this?
Thank you, Dr. Manoj. I would also like to thank the organizers of World Health Summit and INCLAN, especially Dr. Arora sir, for inviting me for this important research priority settings. As we all know that in India, large number of vaccines are being given in the private sector, in the Indian context, by the private pediatricians, in the private people in the settings. So most important, I think they are the most important persons, because they are the persons who are dealing with the end users, the mother, the babies, they are the one persons. And I'm sitting with such big giants, WHO, UNICEF and Gates, but these all, I think they are bigger giants, but the pediatrician, the person remains the most important tool for this research for the producers of the vaccines. Because the person, the baby comes to the pediatricians, the pediatrician decides and he consults the mother that this vaccine is important for the babies. This will prevent from such and such disease. So the first thing, that is the importance of the pediatrician. Second thing, if suppose untoward any adverse reaction occurs with any vaccine, so it is the pediatricians who is going to communicate and should communicate. Most of the pediatricians, I feel personally, they don't communicate. They just think it's a normal reaction. But I feel every adverse reaction should be reported so that the vaccine promoters, the manufacturers can have an idea that this vaccine has caused this adverse reaction. If all the pediatricians will start reporting and that vaccine, the same vaccine is causing that same adverse reaction, so the manufacturers will come to know that this vaccine is causing that reaction, and in that way they can always have in their mind that they have to do something regarding that vaccines. Mostly, and pediatricians, like in the small settings also, they can also do the research. Academic associations like Indian Academy of Pediatrics, as you said, I was the executive member for it for 2 years. They should also do the research activities and help the WHO, UNICEF, INCLAN, all those societies and organizations. So I feel the pediatricians and the professional bodies have a very big role to play in these activities. Thank you.
Thank you, Dr. Tomar. Now I'll request Dr. Archisman, who have been our methodology partner while doing the Chinri activity, and all of us know that research priority setting has been a systematic method, and we have used the Chinri methodology. So I'd request your views on that, that while there are several methodologies which are in the open domain and which have been used, how the Chinri is advantageous and how the issues which were taken up, and what are the challenges which are experienced by you or by the team while doing this?
Nice one. Yeah. Thank you, sir, for that question. I'll just try to connect with the audience a bit. I think that the audience is already noticing that there are different stakeholders on the panel. So we have policymakers, program managers, academia, philanthropic funders, and I represent the research constituency here. And even if like everyone calls out for collaboration, and I'm open for it, I must say that collaborating beyond your core area gives you a bit of stretch, right? And we always want to get to some kind of consensus zone and arrive at a list of priorities which could be acceptable to everyone, and we go on and implement. But we must also acknowledge this fact that whenever it comes to programs and governments or organizations like WHOs and UNICEFs, it's always important as well as urgent. So that's how operational research gets prioritized. And somewhere the methods part is okay, but we have to buy in to pragmatism. We need to suggest what really works in this kind of a context, in this kind of a situation. If we look at the science of priority setting, it has evolved over the years. One is like from just inviting some experts into a room, and then whoever manages to shout loudest has his or her say, to more structured mechanisms of consensus building, and then now more replicable criteria-based models. And also from what Anurag sir was suggesting, like, is it the pediatrician who should decide what kind of research should be done and just ends up communicating to the pharma industry or to the funder? Or is it like all stakeholders jointly join hands, as you were saying, sir, about the research ecosystem and contribute to overall development of this society? We get many options. One is the James Lind Alliance, which is akin to what Anurag sir was suggesting. We get the Essential National Health Research, ENHR mechanisms, which is similar to what you are suggesting, sir. We also have Methodist looking at evidence gap maps and systematic reviews and all, with this rider that even if there is a knowledge gap, it need not be a priority. If we look at conglomerating all of this, Chinri evolves as a clear-cut winner, where we have used cases where Chinri has been translated into national research portfolio and action. And it is also objective and replicable. So that's why we chose that let's go ahead with Chinri. It is an inclusive method. Nobody is rejected. Nobody is out of the arena. Everyone is included. Everyone's voice is counted in. We have a method which, if you click on the priorities, which are broad-based, you get a list of all potential research ideas, questions that you could follow up. And that's how we have been able to organize all those 1347, 1700 odd whatever questions we had into just 25 priorities. And if you click on those priorities, you can go down, you can evaluate from time to time, as WHO has been concerned, that it's not just about doing a priority exercise, but to evaluate, update from time to time, revisit. So Chinri was providing that kind of flexibility. And hence, we chose to go ahead with it. But the challenges that we faced on the way were more like, when you engage many, many stakeholders, their capacity to contribute a research question or a research idea is quite variegated. So people would not structure their research questions in a way that researchers or scientists could consume. We had to iterate. It has been an iterative process. And also, what we noticed is like they had flavors of development plus delivery, description plus delivery. So it was not actually compartmentalized to the 3 Ds that you're saying, sir. So it was cross-cutting. But we had to eventually label somehow and move ahead. And it seems to have been a successful exercise.
Thank you, Dr. Archisman. I think from that...
I would like to add that Archisman was also leading our previous major nationwide research priority setting for maternal, newborn, adolescent, child health and nutrition exercise. So Archisman probably is the most experienced guy in this country for research priority setting. Thank you, Archis.
Okay. So I think beyond this panel, we have also several experts who are here. Dr. Nirja Matla, who is also a member of the NITAG for the ND. And all of us know that NITAG recommends the government what new vaccines and what new strategies are to be taken up. So Dr. Nirja, I'll request you if you can shed some light on how do you see these research priorities from the NITAG's point of view?
Thank you, Dr. Manoj. And I think actually Dr. Arora is the best person to answer from the NITAG point of view because he is quite the expert on all these matters. And I think I can answer better from my point of view what I felt about his views on requiring research when it happened. And as you mentioned, it was a vaccine. When I talk about HPV vaccination, I'm giving the case in point of HPV vaccination. It seemed to me and to many fellow gynecologists that it was a no-brainer that this vaccine was needed. It is a quarter of the world's burden of disease. It's been shown to be so effective. And we need to do it because we know that vaccination is the most effective way to do it. Secondary prevention has been there, so we do it, but it's tedious, it's cumbersome, it's not so effective. And there was all the reaction that happened because of, it was unwarranted, it was uncalled for, it was shown later by the committee that there was no need to worry, it was not causing significant problems. And yet there was all this emotional backlash. And perhaps because it's a vaccine against an infection that is mostly sexually transmitted, so perhaps for that reason it causes a lot of emotions and concerns all around the world. Are we going to promote promiscuity? Is it a women only? Are we causing fertility issues? So many things. But as a gynecologist who was close with the data, doing our own trials, it seemed to be a no-brainer that it needed to be included. So cut to the point where NTAGI has to make a decision where it is being introduced or not, and there is all this resistance saying, no, we must have research first on what is the burden of disease, and do we need to put the vaccine, what is this thing? And it seemed to me as a gynecologist, Dr. Arora, I don't know whether I ever mentioned this before, that the pediatricians who are mostly deciding about the pediatric vaccines don't feel the need to do this research because they know the data, and now comes a vaccine which is for a gynecological thing, so now they're saying we have to do systematic reviews, we have to look at the data, we have to look at the cost effectiveness. And I do remember asking that, are you going to do this going forward with every other vaccine you bring into the program? But Dr. Arora was very clear in his view that if we did not have the research, we might launch it and have to move back 2 steps because of the fallout. And after all the time that has passed since then, and he's been chairing the working group, done all that, I think it was absolutely the right thing to do. So whatever we may feel very passionate about, but there are always contra groups, and it is evidence that is the only way that holds forward. So I think that was absolutely right, and that is the way we should do things.
Thank you, Dr. Nirja. I think I may request if there are any 1 or 2 questions from the audience.
I am Dr. Shobha Tomar, Managing Director and founder of NIMS University. I am a Vice Chairperson of IMT. Sir, as a gynecologist, everybody knows about so many vaccines, but in our cases, most of the, more than 60% cases of missed abortion are due to rubella and herpes and cytomegalovirus. And then what about MMR vaccine? Just, doctor.
So this is a question which has been going on for rubella vaccine. And so first of all, MMR, initially, MMR, actually rubella, no, you are talking about rubella, sorry.
Rubella, herpes.
And rubella. So let me answer about rubella. So in fact, you will be very pleased, although officially it has not been announced, that rubella has been interrupted in this country. There is no more rubella in this country. So, in fact, the government is, there are some final kind of validation testing is going on. And INCLIN, in fact, hosts the Secretariat for Measles and Rubella Eradication Program. And we know that there is no more rubella. Coming to herpes. Now you are talking about the current herpes vaccine. There are some studies and which show that the way initially, you must have noticed that Amitabh Bachchan was saying every 3rd person above the age of 50 or 60, and which was in fact a misinformation. And that's why that ad has been withdrawn. It's not so common. It does occur, but mostly it is in those high-risk individuals where there is immune dysfunction, whether it is because of oncology or other factors. So herpes vaccine, still there would be time. I think the more important question at the moment is something like RSV, which contributes to a huge pneumonia deaths in pediatric age group, particularly in the first year of life. And what is the other new vaccine? Dengue vaccine. So dengue vaccine trials are going on in this country. And dengue particularly kills, children between the age of 10 years and 30 years, the young people, where the maximum deaths occur because of dengue. And dengue has a political connotation, because when outbreaks occur, the most shor machta hai. So these are 2 vaccines on the anvil. Then the third is, which Rahul was mentioning, was typhoid vaccine, and Vinod also. And this, I think these 2-3 vaccines are there. and there is some action going on for this. Fourth vaccine, which is there, which a lot of discussion is taking place, I do not know how to move forward, is an influenza vaccine. Influenza vaccine, the current vaccine has limitations, but when we talk about adult vaccination, maybe sometime later we are going to hold a workshop and a meeting like this. Adult vaccination, and particularly for elderly, the immunity decreases. So for example, influenza vaccine at the age of 18 years has a vaccine efficacy of about 70%. But beyond the age of 70 years, it has a vaccine efficacy of only 17%. Not many people are aware of that. And that is why somehow in adult vaccination, particularly for elderly, the vaccination has not taken off. The current vaccines are really not so good about it. Their vaccine efficacy is around 30% or 20 to 30%. So there is a major problem. So I think a lot of work needs to be done. Sorry? New TB vaccine. In fact, again, there are 5-6 vaccines in the offing, and main issue is preventing reactivation at the adolescent and the adult age. We don't have the good answer at the moment. Recently, the trial which was done in India has not shown any promising results.
So, thank you for a very informative panel discussion and presentation. I am Gitismita, I am from AIIMS Kalyani, and I would like to, I saw there was some equity focus in the Chinri method, but when I read about it, I have already also read that there should have been stakeholder consultations, and like Dr. Vinod and Dr. Vivek, and from the example that ma'am gave, it was very apparent that maybe the methods have missed out some of the consultations with the community, because otherwise the problems that Dr. Vivek pointed out, that there are well established, a very best buy like measles vaccine is now facing problems. So this whole evidence, it always ends with end users. I think it's high time we should start with end users and then go on, take their contributions right from the beginning. So I would like your comments on that.
Should I respond to that?
Geeti, that's very rightly pointed out. Bottoms up build up always helps. But how Chinri works is like it mostly incorporates different experts to the level that they could contribute research ideas, and then takes up a larger reference group, which could be a surrogate for the community at large. So these are not exactly vaccine researchers, but people who could represent the community. But your point is very well taken, that like if we have more resources, more time, more representative sampling mechanisms available, a community consultation could be helpful. One of the criteria, if you could note, was equity. So there were 5 criteria, one of them was equity. But your point is very well taken. Thank you.
Vinod, you would like to compliment this, supplement this?
I think that's very right. And when we talk, because this was discussed with program managers also, the national API managers, and they represent community because they are right in contact with the communities out there, and but not per se, talking to mothers and all on that aspect, but organizations like IAP and all were consulted, in those things. But I mean, if you want that really bottom up, then that's a different aspect altogether. But yes, it has a big role to play in consulting communities on things.
Last one, I think, Kansal, we can take
just
a
to
last
add one more point on that, Dr. Vinod presented the 6 criteria for introduction of new vaccines. So out of the 6 criteria, 4 criteria are directly related to research. And the first criteria, where we actually see the disease burden and the need for the vaccines. So, what you were saying that we should first assess whether there is a need in the community or not. So that is a very important criteria for vaccine introduction. And that is, the first component of vaccine introduction deals with it. Thank you.
Thank you. I'm Dr. O.P. Kansal, currently in the World Bank. Just from a research perspective, Dr. Bura, you were saying that life course vaccination, right? That in fact, I know that adult vaccination has not been much studied as well, or at least research also. So first is that can this cohort, or who will take up the research on adult vaccination? That's one part. Second is, can there be an integration of the existing platforms of vaccination that could also offer adult vaccination, because while pediatric vaccination, immunization, which we call as, is well researched, many, 50 years old, as you have mentioned. But about the adult vaccination, even today, the awareness among the masses is also not there. Only few learned people, or if there is any disease or any, the use case is very, very limited. How can we strengthen that? Because we technically know that it is a very useful, advantageous scenario. Probably research opportunities are required even in that scenario. Thank you.
Hi, I'm Bhavya. I represent Takeda, but for now, my question is something similar, on the similar lines of what he shared. When it comes to pediatric vaccination adoption, of course, with ACVIP, IIP, bodies like IIP being in picture, the adoption is quicker once the recommendation flows in. But when it comes to a dengue vaccine, which is indicated for a broader cohort, when it comes to adult immunization, how do we tackle the adoption part there, if you have any views? Because NTAGI recommendation comes after a lot of work has been done, a lot of years have been spent on the vaccine being present in the market. So meanwhile, when there's a gap that vaccine is available in the private market, ACVIP although recommends, but how do adult physicians start recommending or procuring this vaccine to sell it out to the end consumers? If you have any thoughts on that.
I think we'll take one question and then together we can take the summary.
So I'm Dr. Navneet, I'm from Inclane. My question to all the distinguished panelists is about decision maker-led implementation research. We could see that most of the focus on vaccine research was particularly towards more of development and R&D. But as we see at this critical period of time that, as we are building capacity for different research, we see a lot of disconnect from research to policy making at local stakeholder level, local policy maker level. So in regards to new vaccine development, like Dr. Arindam mentioned the success story of rotaviral vaccine, which was more oral by route. And now for the new vaccine introduction for HPV, where we need to assess challenges at vaccine demand, system, as well as delivery. How do you think we can strengthen decision maker-led implementation research for the current aspect in this region, which we saw that in the there is a huge gap, a disarray in the research at this area. So I would like to ask, how can we strengthen this at this period of time?
I request Dr. Arora to respond and then we can close. Or anyone else?
Yes, implementation research, anybody would like to answer?
Implementation, I can answer that. So, Dr. Navneet's question, I mean, the current exercise of prioritization which we have done in collaboration with Inclane is exactly for the same. The idea is to bring the policymakers and the program people on board with the people who are actually generating the evidence. And that is why, I use the term impactful research or impactful implementation research. So it is very important that we do the research which is needed, rather than, we ourselves deciding that, this is the knowledge gap and doing the same research. So that is also good, I mean, for a few aspects, but not, it may not be a very impactful research. So we need to understand that, what the program people need, and then, move on the same lines.
Yeah, can I just add to that? Dr. Navneet, what you actually asked is where the genesis of priority setting started actually. It all started with decision makers deciding everything. Now gradually it has opened up. In fact, if you look at methods like CORED and all, they deliberately enforce this equity as a criteria when it comes to decision makers embarking on decision making for priority setting and all that stuff. And what ma'am you said and what Kansal sir you also pointed out, like coming to your question about engaging who really does this kind of research when it comes to life course vaccines or adult vaccines and all. This has been well recognized again by CORED and by WHO, where they have not stopped at priority setting, but at managing this entire course of prioritization and its implementation. So WHO really emphasizes that you should not stop at plan, implement, but also evaluate and handhold people by releasing RFPs and then mentoring researchers to undertake that kind of a research and arrive at acceptable evidence, actionable evidence.
Thank you, madam, for the compliment given to IIP and ACVIP. Yes, IIP do follow the immunization schedule and they pass on to the immunization schedule to all the pediatricians and they start following it. So I think our babies are safe because of IIP. Thank you very much for the compliment to IIP.
If you remember, our first priority is for life course adult immunization. And the question you asked, that till ANTAGI, so the key will be doing socio-behavioral studies within the communities, one side, but also on the providers. That means those who prescribe. And one of the biggest obstacle and barrier to adult vaccination is that adult physicians themselves don't get themselves vaccinated. They are not convinced about the value. So two things. If I ask for cervical screening, there are a lot of doctors sitting here. I'm sure hardly anybody would have got cervical screening. Similarly, for adult vaccination, most of the adult physicians don't get themselves vaccinated because they are not convinced about it. So, and third is community. So, what you are asking, the answer is that it has to be socio-behavioral research. It is just not awareness. It's the other barriers they have in their mind which need to be done.
And just to complement, the platforms don't exist. How do you deliver mass vaccination? For children, we have platforms. We have a primary health center, we have systems where children can be brought and vaccinated. To some extent, adolescent vaccines can go through a school-based program, but school health programs are weak in many countries. So how do you deliver en masse? And in COVID days, we realized this problem. We had to go to workplaces to vaccinate, we had to go to transit places, people traveling. So there are a lot of challenges in that. And another big challenge with Dr. Roy is the behavioral aspect. Why children are getting vaccinated? Mother wants them to survive. She wants them to grow healthy. But a 20-year-old person thinks I'm healthy. So currently, I mean last year, Sri Lanka had an outbreak of measles in adults. Because there was a policy issue when they shifted from 1 dose to 2 dose, they had missed few cohorts which were not fully vaccinated. And time and again the country was told that you have a cohort of 5 years people who do not have 2 doses of measles vaccination, they have only 1 dose. And they always thought this is a healthy population, everything is fine. And last year they got infection in those. And it was so difficult for that country to vaccinate that cohort because everybody is saying I'm healthy. Why should I take a measles vaccine? It's for a small child. So, and even the health system was thinking that how can we vaccinate a nurse? So it was a lot of behavioral issues, a lot of policy issues which came forward. And finally they vaccinated adults. With great difficulty they vaccinated adults to control that outbreak. So you're right, adult platforms don't exist. So there's a lot of work to be done on that. Although we have good products like the dengue vaccine coming up, but there are a lot of implementing challenges out there. Thank you, sir.
Thank you, sir. As Aurora sir said, that is a behavioral issues. I would like to tell you, though I'm feeling ashamed, I took my COVID second vaccine when the COVID second vaccine shot was going on, realizing that I hope it is safe. So, and I gone to a government setup to take my first dose when the second dose was given.
बॉबी पिक्चर थी, उसमें एक गाना था पहले तुम याद है आपको? So because of lot of doctors were worried, वो पहले अपनी नर्स को कह रहे हेल्थ में पहले तुम लगवा लो फिर उसके बाद मैं लगवाऊंगा, because to get the safety issue. तो ये पहले तुम वाला था उस समय, but the whole vaccine hesitancy disappeared after mid-April. Then everybody was started taking it. But these are issues which are important, and require research kind of activity. And particularly, so one finally before we conclude, and I'll give it back to you, and that is today more adults above the age of 60 are dying as compared to children below the age of 1 year. So about 12% infants die of 100, if I take 100 deaths, 10 to 12 infants die in a year as compared to 45 to 50 individuals above the age of 60 years. This change has occurred in last 30, 35 years, and which again indicates why adult immunization is important. Thank you.
Thank you all the learned audience. I have received the message from 5-6 audience. They want the photograph with the panelists. So you all can join us. We have a photographer who can take the photograph.
We have last one. Thank you. This discussion was very rich, and I'm sure that this can go on. Even the panelists, their faces are showing that they want to discuss more. But unfortunately, time is a big issue. So, yes. So before I end, one last question to Dr. N.K. Arora, and this question is going to sound very simple, sir, but I'm sure the answer would be difficult. And you are the one who has taken, worn several hats, from evidence generation, from evidence utilization, and so many things. So you are the right person to answer this. And my question is to you is, how aligned are the research priorities identified with the government goals and priorities?
The whole issue is that context is very important. And according to context, there are challenges. And if my research priorities do not resolve those challenges, then or whatever work I want to do. So many times academicians do research more from a publication point of view, or to score a point over the neighborhood, meri kameez tere se zyada safed hai. But the fact is that if I want to have an impactful, and what does impact means? Impact means it influences the policy, it influences the program, and it influences the impact on the community. For all the three, when these three, and wherever studies look at these three dimensions, and this can come only by this widespread consultation, crowdsourcing and consultation, and therefore research priority is very important. And the other important thing is that we can catch hold of people like Arindam and request them to invest little more or align their funding also that. It is very important, both national funding agencies as well as philanthropies and private funding agencies, they also feel more confident. He made a very important statement, if you remember, that they would like to invest in conditions, in situations which aligns with national priorities. And that is what now we can say it's a national priority. Please invest. Okay. And I'm asking Takida also on that.
Okay. Thank you all panelists, and thank you all audience for this, I think, energetic and also engaging discussion. Hope it has solved certain issues, but all participants are requested to
all can join us for a group photo with the panelists.
Okay. Thank you all.
Thank you. Okay.
Look at the pillars if all are coming.
मेन फोटोग्राफर कौन है? सभी मेन है। सभी मेन है। सबकी तरफ देखना भाई। कोई प्रायोरिटी नहीं है, यहाँ प्रायोरिटाइजेशन नहीं हो रहा।
गार्ड साहब कोई छुप रहा हो तो उसको बता देना। हाँ बैठ दो। जो आगे उसकी फोटो सबसे अच्छी आएगी।
ये बहुत आइटरेटिव प्रोसेस है, ऐसा ही होता है। प्रायोरिटी सेटिंग ऐसी होती है। सब अपने अपने नजरिए से सेट कर रहे हैं प्रायोरिटी। थैंक यू। अच्छा, थैंक यू, थैंक यू, थैंक यू, थैंक यू, थैंक यू,
Thank you.
Thank you
very
very
much. Thank you everyone.
Hello. Tinku.
Just hold on one. Change the number one. The card I've got so many. You can keep the card. Just give me this one. स्क्रीन बंद कर देना भैया एक बार।
सर मैं स्क्रीन के बिना भी काला ही हूँ।
स्क्रीन बंद कर दो ये। आपकी सुनेगा वो यार हमारी। एक में सब आ जाए बेटा, एक ही फ्रेम में।
लग रहा है
Thank you. I'll share with everyone. Okay. Thank you, Manoj. Thank you, Dr. Manoj, very much for guiding the panelists, especially me.
मेरे थे, बोल मैं रहा था मार्जिन नहीं थे। अच्छा बोला ना? हाँ। Just nice meeting you, Chandra. Same here, sir. I just give you my card for today. You just give me your number, sir. Sir, तेरा काम रह गया मेरा। काम रह गया वो फाइनल वाला रह गया। पार्टी सब बंद हो गया इसको कोविड है कोई नहीं आया लेकिन वो अच्छी चीज थी इसके बाद क्या हुआ बाबा रामदेव ने हमसे डायरेक्ट किया कोरोनिल कोरोनिल के फार्मेसी डिपार्टमेंट को फार्मेसी डिपार्टमेंट फाउंड आउट कि जो हॉस्पिटल हफ्ते हैं वो एक आध दिन कम हो जाते हैं मॉडरेटर बूस्टर है और उन्होंने उसको प्रमोट किया एज अ क्यूरेटर इट ट्रीट्स कोविड मतलब सब इंटरप्रिटेशन
Good afternoon, everyone, and welcome to this important session on women's cancer burden during the World Health Summit Regional Meeting 2025. The Women's Cancer Burden session is being organized under the aegis of the Cochrane India Network, and I acknowledge Dr. Anju Sinha, who is co-chair of the Cochrane India Network, to having given us this opportunity. The way we've structured it, we have esteemed speakers and panelists, and the way it is structured is we'll have three speakers give us a didactic talk on the women's cancer in India, and followed by a panel discussion. So may I now invite the chair for this session. Dr. G.K. Rath was supposed to chair, but he has not been able to come, and Dr. Neerja has very kindly, graciously agreed to chair this session. So big round of applause for Dr. Neerja. She has been the head of gynecology and obstetrics at AIIMS Delhi. So thank you, ma'am, once again for helping us out for chairing this session. We also have the speakers include Dr. Prashant Mathur, who's the director of NCDIR at Bangalore. So big round of applause for Dr. Mathur. Dr. Sudeep Gupta, who's the director of Tata Memorial Center. Welcome, sir. Big round of applause for Dr. Sudeep. Dr. Gauravi Mishra, who's the deputy director of the Center for Cancer Epidemiology at Actrek Tata Memorial Center in Mumbai. And Dr. Anushil Munshi, who is the director of radiation oncology at Fortis, Noida. So big round of applause for Dr. Anushil as well. So may I just request Dr. Neerja to give her introductory remarks, and then we will proceed.
Thank you, Dr. Gupta. Thank you so much, and thank you for inviting me to chair this very exciting session with a real galaxy of speakers. So I definitely do not want to take up time away from what they are going to offer as deliberations, but just a moment of reflection that cancer definitely is on the uprise. It is one of the most important contributors to morbidity and mortality today, and I think there will be nobody in the hall or anywhere, even within the premises of this Bharat Mandapam, who doesn't have some member of the family or a very close associate who has suffered from this condition. And while it is one name, cancer, but the causes are very varied, very varied. So they vary from infections to lifestyle factors to exposures to different toxic elements and so on. It list is quite endless of carcinogenic elements. So we had a burden of disease which was very different. It has changed over time. Dr. Mathur will illustrate on that. But now we have this problem that we have cervical cancer, which was the commonest at number 2, and breast cancer, which we thought is a disease of the affluent and rich, has been going up in every registry, including rural registries. So it has reached a point where I tell all our gynecology colleagues that it is unethical to screen a woman for cervical cancer and not screen for breast cancer, which in fact is her more likely, the more likely problem she is going to face. So the good news is that we have solutions. A lot of people said, called it the big C. They were even scared to utter the word. And a lot of people said, if I have a cancer, I don't want to know. And we say, trust us, you do want to know. You want to know, and you want to know early, because then it is curable. If Dr. Rath had been here, he would have said that you can be cured of cancer, whereas you cannot be cured of diabetes and hypertension. And he would have also told you his 80-20 rule, that if you come, what was it? If you are in the, kya hai, Abhishek? 20% of cases. Yes. So please don't tell him I had to take Abhishek's help to tell this, but this is what he tells everyone who walks to his office. So it's true that we need more focus on early detection, prevention, because we have tools. We are even recognizing that familial cancers can be have solutions. People didn't want to know that they have a cancer in the family. They thought their children will not get married. Today they recognize that we can have solutions and we can modify lifestyles based on that. So, as I said, I don't want to stand in between these wonderful talks that we are going to have, and I will ask Dr. Gupta to carry on with the proceedings.
Thank you so much, ma'am, for your insights. And we begin with the first presentation of the day, and it's visible. I think you can sit here. Okay. Sure, sure. So may I request Dr. Prashant Mathur to deliver his talk on changing epidemiology in women's cancers in India.
Good afternoon, everybody. Welcome back from the lunch. Thank you to the organizers for giving me this opportunity to present on the women cancer based on the data available from the National Cancer Registry Program. Okay, some settings problem. The National Cancer Registry Program collects data mainly through two mechanisms. One is, on your left, are the population-based cancer registries, which collect data on all cancers in the defined geographic area and defined population. And on the right side are the hospital-based cancer registries, which collect data from the hospitals, irrespective of the patient's residence or geographic where they come from. The PBCRs inform more us on the population dynamics, on incidence, burden, mortality, trends, etc. And the hospital-based cancer registry gives higher details on the clinical aspects of cancer. And India does not have cancer as a notified disease, unlike the Western countries, but we have been able to work, and 17 states in India have notified cancer as a notifiable disease. And so because of the large expansion of the registry and linkages, we now have data coming in from more than 7,800 data sources across the country, which also includes data coming from the Armed Forces Cancer Registries, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the Tamil Nadu Cancer Registry, and the registries run under the aegis of the Tata Memorial Centers. India is not one, so it's a continent. And on the y-axis are listed the registries, and males and females. The color coding is depending on the region. So these are rates per 100,000 population. The northeastern part of our country is where the maximum cancer burden is being experienced, and there is a 10 times difference between the top to the bottom. So India is a lot of heterogeneity in the incidence of cancers. There are certain registries which are showing, and these are 23 registries out of all of them, which are showing higher incidence of cancer as compared in females as compared to men. And when we look at some site-wise incidence of cancer, if you look at breast cancer, the urban metros, Hyderabad, Bangalore, Chennai, Noida, Thiruvananthapuram, Kollam, are experiencing the highest incidence, whereas in cervical cancer, it's a reverse story. But if you look at the incidence, highest incidence of breast cancer is 54 per 100,000, whereas cervical cancer is 22.6. And there are a lot of registries which are reporting a figure for cervical cancer which is nearing the elimination target. Similarly for ovarian cancer and corpus uterine cancer, just to show the heterogeneity of the cancers. Then we looked at distribution of incidence for major cancers of women by geographic classification. So we classified our registries as predominantly urban, predominantly rural, and a mix where they have a different ratio of urban and rural. Very clearly, breast cancer is highest in the urban registries, whereas cervical cancer is highest in the mixed registries, but rural registries also have a higher incidence. Similarly, ovarian, corpus uteri are more towards the urbanized cities and geographic areas, whereas gallbladder cancer was being more reported, and this is also a very peculiar problem in the female gallbladder cancer in this Indo-Gangetic belt of our country. We looked at annual percentage change in cancer from 2002 to 2019 for men and women, and we are majorly experiencing an increasing change in the incidence of cancers across all registries except for very few of them which are showing a decline, a significant decline. The sex-wise age-specific incidence rates between the ages of 25 to 59 years of age, female cancer incidence rates remain higher than the men. And this is little opposite to what the global picture shows, where there is more men. So we have a higher burden of reproductive women cancers. And the peak age of cancer reporting incidence is between 60 to 64 years of age. Then we try to look at by menarche and menopause. Breast cancer is way ahead in terms of the total incidence of and the age at which it peaks compared to corpus uterine, cervix, ovary, and other women cancers. And this gives us an idea as to what kind of interventions, what kind of burden are we expecting in our population. We also looked at breast cancer as per the menstrual status, premenopausal, perimenopausal, and postmenopausal. There are northeastern registries and registries from Kashmir showed very high proportion of premenopausal cancers as compared to the rest of the country. So there is so much of variation, so much of divergence in the distribution and occurrence of breast cancer. We need more deliberations and more kind of information as to why is and what is driving this. So what has changed between 2004, 2005 and 2025 estimates? Breast, cervix and ovarian cancer continue to hold their positions as number 1, 2 and 3. But corpus uteri from number 7 comes to 4, and lung cancer, which was not there in the first 10, comes at number 5, and thyroid cancer emerges from the bottom. Gallbladder cancer goes down. So there is a lot of exposure related. So women cancer, more to do with air pollution exposure, particularly indoor air pollution, could be a reason why this is being experienced. We looked at four of these are 6 registries, the old registries since 1980s, to look at trends in breast, cervix, corpus uterine and ovarian cancer. Very unanimously, cervical cancer is declining across all these registries, so this is a data of almost 40 years trend, whereas breast cancer, corpus uterine and ovarian cancers are rising. This is a graph to show what happened when breast cancer in the red and cervical cancer in blue exchanged their positions. And we looked at these 5 old registries. Somewhere between late 1990s and 2000, this crossover happened. And this, where cervical cancer was declining, where breast cancer was rising. And cervical cancer decline at that time was nothing to do with screening. That was not practiced. There was no vaccination talk. Something else was happening in our ecosystem which was bringing down cervical cancer rates, probably outside the health sector, education, health literacy, personal hygiene, age at marriage, girl-child education. So the message is that while we continue our medical interventions to reduce cervical cancer, we should not lose focus on these social determinants which will drive the decline in cancer. This is what a registry can show over the last 20, 30 years. Then we looked at period cohort analysis between 1987 and 2012 for breast cancer. Bangalore, Barshi, Bhopal, Chennai, Delhi. You see the systematic rise across all these registries between 1987 to 2012. Similarly, the reverse happens for cervical cancer. This is a period cohort analysis. Then we looked at birth cohort analysis. When we looked at breast cancer, the recent birth cohort, the incidence rates were higher than those of the earlier birth cohort. Whereas for cervical cancer, we are observing an opposite pattern where it is the earlier birth cohorts which experience the higher incidence rates than the recent birth cohorts. I've just picked up one interesting slide which we came up for histology of lung cancer. We have now 49% adenocarcinoma being reported in lung cancer in females as compared to 32.4 in men, whereas squamous cell carcinoma was 21% and 10%. Again indicating to a change in exposure rates, where air pollution, indoor air pollution is driving this kind of an, so the incidence rate came up, the rank of lung cancer gone up, the histology is also changing. Stage at distribution of women-specific cancers. The pink bars are the localized, the blue bars are loco-regional, then distant metastatic. We are experiencing a lot of advanced cancers in women, and it will take a lot of efforts on screening and early detection campaigns and strategies to bring down and downstage cancer, to bring higher proportions of early diagnosis of cancer. And many of these cancer, uterine cancer, ovarian cancer, we need to start thinking very aggressively on some screening or an early detection method where this can be. And as I think Dr. Nirja very rightly said, you know, opportunity. When a lady is there, why just check for cervical cancer? There are many other things which should be, so it's a lost opportunity. I think all these thought processes, epidemiology can help to augment it. We published this 5-year age standardized relative survival on 11 registries for breast cancer. And this is, all India is 66.4. So we have improved by a margin of around 10% in the last 10-15 years. And you can see the difference in the 5-year survival of breast cancer. But cervical cancer is still aggregate of around 52% with a lot of difference in the survival pattern. We can ask more questions, why so? Is it early diagnosis? Is it better health systems, better patient cooperation, treatment, etc., etc.? So to conclude, cancers in women are increasing across all age groups and regions of the country. Though we are seeing very declining trends for cervical cancer, it should not put us off guard. If we do not accelerate this reduction, we will see the rise again, as has happened in some countries. Lifestyle-related cancers are rising. Thyroid cancer and gallbladder cancers are showing regional distribution. Earlier, we picked up the first rise in thyroid cancer in Kerala. But now, some more registries, particularly northeastern registries, are also showing a rise in thyroid cancer. Screening and early detection for breast and cervical cancers to be strengthened. Awareness of risk factors, suitable interventions in diagnosis to be strengthened. And registries should be the fulcrum of cancer information system. Whatever you do, the outcome will be very long, and this long telescopic view only a registry can provide, right from screening, even including vaccination, screening, treatment, to show the decadal and long-term change in patterns of cancers over here. So thank you very much for your kind attention. We take this discussion forward.
Thank you very much, Dr. Prashant. I think we can just have a couple of very quick questions or comments if there are any from the house. Dr. Abhishek.
So, sir, I think you showed in the registry that we know that cervical cancer incidence rate is higher in the rural population. In your registry, it's not statistically different. Any thought why it could be? Because
And
it
if
is
I can add one more and you can
Yeah.
answer them together
Yeah.
maybe. When you say that there are 17 states which have it as a notifiable disease, do you perceive any difference in the data which you get from the notifiable system now, and has it made a change over the previous data you were getting in terms of trends?
So the last question first. No, it has not made a significant dent because implementation is a problem. You know, merely notifying is not enough.
Yes.
But implementation is a problem. And currently we are running 3 state cancer registries, Rajasthan, Andhra Pradesh and Himachal Pradesh. They have notified cancer, and we have made them very clear that you have to somehow see that your coverage is high and use the implementation of the notifiability to that effect. But otherwise, in general, it doesn't make a difference unless there is a implementation issue. And same with many other issues. So we have not checked for statistical difference between urban and rural. There are many registries which have a, I mean, for simplicity, we took, you know, highly urbanized, fully urban, fully rural, but that mixture of urban rural, somewhere it is 30-70, 40-60.
Okay.
So that is contaminating the.
And one quick question. So in your registry for the lung cancer, you know, do you think that how many percentage of women or young adult has a non-smoker who has been identified as lung cancer? A lump sum percentage. I just want to know about it.
We cannot answer that.
But
That is the whole problem I flagged
Dr.
yesterday.
Sudeep can answer that.
Yeah.
So there was an analysis done by my colleagues Kumar Prabhash and others, and they actually found that more than 20% of patients did have lung cancer that was not related to tobacco use. I also wanted to comment that the shift from squamous carcinoma to adenocarcinoma is not only in lung, but, you know, for example, also in esophagus, also in cervix. So for some reason, wherever both histologies can occur, adenocarcinoma as a proportion of cases is going up and squamous is coming down. So, you know, we need to think about why that might have happened. And the last comment that I said, you showed the sharp decline in cervix cancer. Might I add, and this is just my own hypothesis, that the HIV epidemic that happened in late 80s and early 90s led to widespread adoption of safe sexual practices. And I think, you know, that might also have done something to reduce the incidence of many, many different diseases, including cervix cancer.
No, also, you know, I like to think also there are a couple of others which you didn't mention was multiparity. In fact, the very fact that cervix and breast are showing this opposite because their risk factors are exactly contra. So one thing is that also, and this syndromic approach for sexually transmitted infections, which has decreased the prevalence of these, which we know to be as cofactors in the progression. So we don't know because we've not looked properly maybe. I mean, we know that CA uterus, body of uterus comes early, and we always think that, you know, it's a very dramatic presentation. Patients come usually within 3 months and they get diagnosed. I'm surprised only that vulva doesn't get diagnosed early more often because it should be very evident, and I hope everyone takes back the message that any old lady complaining of pruritus vulvae, please ask them to get checked up. There's a lot of barrier to checking up and they can be caught early.
Sure.
Thank you so much.
Thank you once again. A big round of applause for Dr. Prashant Mathur. It's my proud privilege to invite Dr. Sudeep Gupta to deliver his presentation on breast cancer in India.
No, I'll introduce myself. I'll just get on with my talk. Can I have the slides? So my name is Sudeep Gupta. I'm a medical oncologist at Tata Memorial Center, and I'm delighted to be here. I would like to thank Dr. Tejpal Gupta. I'm also. No, I'm also currently, it's written there, I'm also currently, I have the privilege of leading the institution, and it's a privilege for me to be here, and I'm especially delighted because Dr. Neerja Batla has been my mentor at All India Institute of Medical Sciences, where I did my MBBS and training onwards. So thank you very much. These are all the hospitals of Tata Memorial Center. They are located in 7 other cities of India apart from Mumbai. And we were started by the House of Tatas, but we have been under the Department of Atomic Energy since 1962. These are all the locations of our hospitals. And you will note that in the most recent year, that is 2024, we registered 129,000 new cancer patients in our hospitals. At 150,000 is a mistake. So I will give you an Indian perspective on breast cancer. We recently published this task force report on breast cancer in India for the National Academy of Medical Sciences. It lays out not only the problems, but also the possible solutions and a roadmap for the next 5 years, 10 years, and 20 years. And maybe some of you will take the opportunity to read it. So this is India, and this is the population pyramid, and I did that a decade apart. And the point that I'm trying to make is that the population is still predominantly a young population. And what that means is that on the right is the age-specific incidence rate, and you see that the age-specific incidence rate is highest in the older age groups, but because of the large denominator, the large number of young individuals in our population, the number of cancers is actually very high among individuals who are 50 years or younger. So which is why in every series of cancer, you will note that the median age that is reported from India is 49 or 51, whereas the corresponding number from the West would be 63, 65, and so on. So this is breast cancer, and you can see that it constitutes the largest proportion of, not the largest proportion, but it is the most incident cancer among women, and also actually if you combine both sexes, it is the most incident cancer. And I was actually surprised when I was doing this task force report that the current estimate of the number of breast cancer cases in India has crossed 200,000, so which is actually a very large number of patients. This has been shown by Dr. Mathur, but let me just make that point again that there is a large intra-country variation in the incidence, and you see those population-based urban cancer registries where it is much higher than the rural cancer registry. So this is a single year analysis of patients registered in our hospital. We did it a long time back, and we found that about 30% of our patients had triple negative breast cancer, and this is in contrast to about 10 to 15% that is seen in the developed countries. And we also found that the age-specific incidence of triple negative breast cancer actually declines with age. So because we have a large number of young women with breast cancer, therefore the proportion of patients with triple negative breast cancer is higher. And subsequently, our colleagues performed this meta-analysis of several different reports, and indeed the proportion of patients with triple negative breast cancer is much higher, and this is important because TNBC is a rather aggressive variety of breast cancer. More recently, we published this paper between my colleague Dr. Shona Nag and myself from Pune and Mumbai, and we looked at the risk factors for triple negative breast cancer and non-triple negative breast cancer. So Dr. Bhatla just mentioned multiparity, early menarche, etc., and so on. So all breast cancer is lumped as one disease. So might it be the case that the risk factors for triple negative breast cancer are different from those of, for example, ER positive breast cancer? And we actually found that central obesity, as measured by waist-hip ratio, is preferentially associated with ER positive breast cancer, and lower socioeconomic status is preferentially associated with triple negative breast cancer. So the risk factors for these different types of breast cancer are actually different. But the question is how to improve outcomes. And I will just show this to you. Many oncologists in the audience know about it, but many of you are not oncologists. So some of you know that platinum is a very important drug for breast cancer, especially triple negative breast cancer, but proof that it works in the neoadjuvant setting definitive proof had been lacking. We conducted this randomized control trial in our hospital, and I had the privilege of presenting it at an international conference. We found that the pathological complete response was substantially and significantly increased in young women, but not in older women, with the addition of platinum to the standard chemotherapy. We also found that event-free survival was substantially and significantly improved in younger women, but not in older women. We also found that overall survival was substantially and significantly improved in younger women, but not in older women. And if you look at the survivals, 65% and 77%, they closely track with the population-based survival that Dr. Mathur just showed you. And this is largely because of the fact that most of our patients come with relatively advanced stage of the disease, and I have not included that slide here, but almost 80% of patients in this randomized trial had primary tumors that were larger than 5 centimeters. If you read the contemporary trials from Western countries, their survivals are 93%. But the simple reason is that their average tumor size is, let's say, 2.1 centimeter. And the simple fact of downstaging the disease substantially and significantly improves the survival apart from the interventions that I've been showing you. So we definitively proved that platinum is a useful drug for young patients with breast cancer, and this has become the standard. Oncologists are using it more confidently after the presentation of this study. My colleague, Jyoti Bajpai, also evaluated the unique challenges and outcomes of young women with breast cancers at our institution. And what we did was to look at patients who were younger than 40 years of age over 2 calendar years, and there were almost 8,600 patients, and you will note that almost 16% of these patients were younger than 40 years of age. This is a much higher proportion than what you will see in any Western country. But look at the stage. 50% of patients had T3 or T4, 75% had node-positive disease, 90% had high-grade disease, and stage 3 was in 56%. So when we talk about early detection, and let me just tell you that there has been one randomized trial for self-breast examination, and that was a negative trial, so everybody says that self-breast examination is not a good idea. Now, if you perform self-breast examination in a society where the ambient tumor size is 2 centimeters, you will not show a benefit. But if you perform self-breast examination in a population where the ambient tumor size is 4.5 or 5 centimeters, I can lay you a bet that it will show an actual benefit in terms of downstaging as well as reduction in mortality. So these were our patients. Only 38 of these 1,228 were in stage 1 and 692 were in stage 3. And this is the 5-year survival for these young women younger than 40 years of age. Event-free survival 60%, overall survival 80%. And if you look at it stage-wise, in stage 2 and 3, it is again 55 to 65 to 70 to 80. It should actually be an event-free or a disease-free survival close to 90%, but no intervention will do it except for downstaging of the disease. I'm also focusing on young women with breast cancer because that is a particularly important problem for our country. So we know that young women have many other issues: fertility, chemotherapy-induced nausea and vomiting, alopecia. So we have tried to conduct a few studies to address these questions. This is some data from our colleagues at the All India Institute of Medical Sciences. They analyzed 240 consecutive patients with breast cancer, actually 236, and they found that there was 19% rate of a hereditary pathogenic mutation that could predispose to breast cancer. This is astoundingly high. 1 in 5 patients with breast cancer carries a germline pathogenic mutation, and this is not patients selected for family history, for bilaterality, or some of the classic correlates of hereditary breast cancer. This is all comers. So it also tells us that, you know, going forward, we have to become more sophisticated in our workup, in our analysis, and what we do for our patients. In Tata Memorial, we conducted a randomized control trial of scalp cooling to prevent hair loss, and we actually found that it is very, very useful. And these are some pictures, and then we published this RCT in a journal. And now, of course, there is widespread adoption of this technique to preserve hair while patients are receiving chemotherapy. We also conducted a randomized control trial of giving low dose versus standard dose olanzapine. So olanzapine is a drug, it is a sedative, and it actually prevents nausea and vomiting. The standard dose is 10 milligrams, but it is highly sedating. Most women cannot tolerate it. Chemotherapy-induced nausea and vomiting is a particular problem in young women, and we showed that they are non-inferior. So now, after we published this paper in the Lancet Oncology, 2.5 milligrams has become the default standard of care for these women. I mentioned fertility and pregnancy. This was actually run this is a multi-center analysis, and this survey was done to evaluate physicians' knowledge and preferences about fertility practices. And most oncologists, as usual, including myself, I'm not segregating myself from that group, people are uncertain. And you can see that discussions about fertility happen more often actually with young men compared with young women. And that's also true for many other practices. So you can see here, semen cryopreservation was offered more often than was ovarian or oocyte preservation. So what we need to do is to foster a culture of excellence, of going by the protocol, of developing standard operating procedures, so that most of these modern techniques are then brought to bear for our patients when we treat them. My colleague has also run a gestational cancer registry. So over the years, we have seen a number of women who were pregnant when they had breast cancer, actually other cancers as well, but this is for breast cancer. And we have collected actually a good amount of data. So these are 104 women, and you see 34 of them were antepartum, 70 of them were postpartum. And there is actually good fetal outcome as well as maternal outcomes, which is comparable to the international results. And what we show here, that again, as with non-pregnant women, even with pregnancy-associated breast cancer, stage is very important. And the problem is that in pregnancy, it is very easy to miss a breast cancer because of several changes that happen in the breast. We have also tried to evaluate access to and increasing the accessibility to expensive drugs. So most of you know that there is a drug called trastuzumab for HER2-positive breast cancer. We conducted 2 surveys, one in 2008, the other one in 2016. In 2008, only 8.5% of our patients could access this drug. In 2016, almost 60% did. And in the meantime, we had randomized control trials, 6 randomized control trials that tried to evaluate whether to give 1 year of that drug or get away by giving 3 to 6 months. And the reason was that not only is it expensive, but it is toxic as well. And we conducted an individual patient data meta-analysis that we published in JAMA. And you can see here that 3 to 6 months of trastuzumab was non-inferior to giving 1 year of this drug. Now, of course, there are biosimilars, but in collaboration with our colleague from PGI Chandigarh, Dr. Shankar Prinja, we found that even at biosimilar prices, giving 1 year of this drug is not cost effective in India. So most of us sitting in our big hospitals think that everybody should receive these expensive drugs. They're actually not available, they are not accessible, and actually they are life-saving. So there is a case for trying to alter the dose, alter the schedule, and try to make them more accessible. This is not the occasion, but my colleagues from lung cancer and other groups have done the same for a number of expensive immunotherapy drugs and showed that 1/6 or 1/7 the dose works as well as the full dose. So this is also something that can increase accessibility to these drugs. And in the end, this is a randomized control trial on cervix cancer screening that was done in these slums of Mumbai. This was with the help of an R01 grant to my colleague Dr. Indranil Mitra. 150,000 women were cluster randomized half and half to either receive breast and cervix cancer screening, not by mammography and pap smear, but by clinical breast examination and visual inspection of the cervix with acetic acid, delivered by trained female individuals who were sourced from the community, who were 8 to 10 standard pass and who had only received training for about a few weeks. And this study, I'm not showing the cervix cancer component of this study, that showed a 32% reduction in cervix cancer mortality. But the breast cancer component of this study that was published in the British Medical Journal a couple of years ago showed a 33% reduction in breast cancer mortality using clinical breast examination delivered by trained female healthcare workers. So a couple of days ago, I was speaking with a very important policy maker, and they asked me whether we can have, 100,000 vans fitted with mammography machines going all over the villages. And I said that is not possible. It is not desirable. It cannot be done. First of all, those mammography machines and vehicles are wide body. They have, a whole lot of, their axle is heavy. And we have actually experienced that they cannot even navigate the roads of Mumbai. So clinical breast examination is a good screening procedure for breast cancer. It needs to be delivered on a countrywide scale, and it will bring down the mortality. This is access to screening for breast cancer pointed out here. This is what we publish in our paper in the National Academy of Medical Sciences. You can see that it is very, very low. And given the fact that breast cancer is becoming more incident, this proportion does need to increase. So everybody knows about these things, so we need to do all of these things. What I want to show here is that when we talk about manpower, we don't talk about, for example, manpower to create awareness in a systematic manner, early detection in a systematic manner. We think about doctors, nurses, technicians, but we also need individuals for palliative care, for early detection, for awareness, for maintenance of the cancer registries, and only when we have a more holistic and inclusive view of what the human resource requirement is, then we will be able to tackle these problems. So those are the barriers listed on the left, and you can see this is an estimate, and all estimates are not completely accurate, but you see the number of medical oncologists that are required and the number of trained medical oncologists that we have. The same with surgical oncologists and medical physicists. But this is a projection for 2040, and it seems that the way we are training more individuals in more number of centers now, we may be going towards a better optimal utilization of many of the treatments for cancer, including chemotherapy. So we need to organize ourselves at various levels, not just in Tata Memorial Center or in AIIMS, but at primary, secondary, and tertiary, and there needs to be a seamless integration. It seems to be happening. This is not just something out of thin air. For example, our hospital in Muzaffarpur in Bihar is now coordinating 6 daycare centers in 6 districts of Bihar. And in all the 38 districts of Bihar, we are organizing training for ASHA workers to roll out screening for breast and cervix cancer, as I have told you. It is happening. The policy makers of Bihar are invested in that project, and it is making a difference on the ground. This is radiotherapy. You see how deficient we are in radiotherapy infrastructure, and Anushil sitting here will tell you that even the machines that are listed here, many of them are possibly non-functional. So we do need to tackle that and take care of all of these problems, but it is happening. Financial toxicity and coverage for health. I think one thing that we need to congratulate ourselves and our government for is the PMJY, the Ayushman Bharat. You see the government health insurance 43.3%, that was close to zero about 15 years ago. It has made a substantial impact, not only for cancer, for many other diseases, but also for cancer. And I think this needs to, but you see that uncovered population 40.8%, that's people who are not officially poor, but who are not officially also, who don't have the resources to get the full complement of healthcare that they need. So this is also something that we publish in our report in NAMS. This is our group at Tata Memorial Center, and thank you very much for your attention.
I think, ladies and gentlemen, you will agree, Professor Sudeep Gupta, one of the best orators in the country. And also, by virtue of his scientific acumen, which you have seen proof of, his interest in original research, and the position he commands, all of them make him the loudest voice for any cancer-related decisions. So we need him to take away our messages, and your comments and questions are welcome at this stage.
Yes, they have some question. Yeah. Yeah, you can say it loud. I think we can hear you.
So thank you for that. I just wanted to say that I don't come from the cancer field, and your presentation really appealed to me despite being a lay person in your field. So thanks for that. I'm Urvita. I work with a mental health research NGO in Goa called Sangat. My question for you, Dr. Gupta, is given all of that you've presented, and given that triple negative breast cancers can have significant adverse outcomes if there is a delay in help seeking, what do you think are the conversational and behavioral shifts that are required at the community level? Also thinking beyond the health systems, what do we need to do differently so that we can get more women into treatment earlier?
That's a good question. I will think about it. Maybe I'll take one or two other questions and then I will answer you, because I don't have a quick answer to your question. There are many, many things that come to my mind, but I think you formulated the problem exceedingly well, that there are several barriers, there are constraints which lead to the current situation. Now what should be done is something that maybe...
Yeah. Thank you, sir. I'm Dr. Upi Kansal from World Bank. Last year, earlier I was working in American Cancer Society in India. So basically, we tried to organize or attempt at reaching out to the organized sector, say FICCI, etc., that at least within their circles, the employees and others, they should be made aware of that breast cancer and women's screening. As Dr. Mathur was also saying, that let's try to see comprehensive. I'm trying to understand what are the roadblocks that, briefly, which are inhibiting us at least to go into our educated class to make them aware and get them preventive screening for women cancer.
So let me answer both your questions because they are related. Your question is why at least among the more educated or affluent classes there is no screening. The reason is that first of all, we have not organized ourselves well. Proof that, for example, clinical breast examination works is relatively recent, not very recent, it's about 10 years old now. The problem is that on a country of India's dimensions, it is hard to implement something as like vaccination for MMR. It can't be done. Somebody cannot just think today and implement it tomorrow. But let me tell you that 21 states of India are now implementing screening for breast and cervix cancer exactly with the two techniques. And for example, in Maharashtra and in some other states, we are engaged with the policymakers there to try to train the healthcare workers to deliver it. It's not just enough to say that in a randomized control trial, I proved that this is doable, therefore it can be done everywhere and by everybody to the same. The second thing which she said, I think very importantly, I was thinking about what you said, that what to do, what sort of conversations, etc., that we need to have. It is not just conversations. You see somebody in Purnia in Bihar, if she has a breast lump, you don't expect her to, first of all, be aware about it, then go somewhere to seek diagnosis for it, and then travel to Delhi or Mumbai or somewhere to actually seek treatment. The first order of business, in my opinion, is to decentralize the delivery of healthcare so that people don't have to travel vast distances and become dislocated geographically to receive the care. The second is, of course, to increase awareness. So I will give you one more number. In 1991 or 92, I was not at Tata Memorial, but I'm told by my colleagues, the average breast cancer tumor size of women who came to Tata Memorial for breast cancer was 5.4 centimeters. The same analysis was repeated around 2016 or 17. The average tumor size had come down to 2.6 centimeters. Now, how did that happen? Nobody went about doing mammograms. Nobody did clinical press examination on a population-wide scale. It happened because there was awareness, because women did not sit over their lumps until they became 10 centimeters. They approached the healthcare system earlier. And I think the idea is to encapsulate that in a systematic program that can then be implemented to increase awareness. Now I go about seeking funding for awareness. The problem with awareness and early detection is that the hard endpoints are hard to prove at the population level. Everybody agrees that they are very useful, but how would I prove that an awareness campaign has actually made a difference? So maybe Dr. Mathur, in collaboration with you, with your population-wide data, we can think of some linkages that can be established between systematic delivery of awareness and downstaging and mortality at the population level. But I don't have a quick fix answer to your question. Unfortunately, triple-negative breast cancer occurs at a younger age, and in younger women, all screening methods are not optimal for breast cancer. The number of false positives is higher, including with mammography, with clinical breast examination. So the problem is compounded by discovering many more benign lumps than cancer, and then having women undergo a lot of anxiety and other tests that go along with it. Maybe she and then. You can speak, actually, it's a small room, yeah.
Thank you, sir, for the excellent presentation. I am Dr. Sanchika. I am from ECHO. Just wanted to add my views that when any person is detected or a woman is detected with cancer, then it's a end point, they think. There's a lot of fear and stigma around it. So that is also one of the reasons that they do not want to get it screened. And also, I have observed in the past few months, there was a lot of celebrity, or one celebrity came up that the campaign around the cervical cancer was very bad. And so that is also instilled a lot of fear among it. If there are survivors of those cancers and turn up and give some positive thing that there is a life after getting screened and treated, then that will add on a positive influence among the society and will come forward to have screened in all the status of the society. Thank you.
You're absolutely right, and many celebrities and other people with influence over the society are actually doing it. So you're absolutely right. Okay.
Thank you, sir. Big round of applause for Dr. Sudeep Gupta. May I now invite Dr. Gauravi Mishra, who is the Deputy Director of Center for Cancer Epidemiology at Actec Tata Memorial Center, to deliver her presentation on screening and preventive strategies in cervical cancer.
Good afternoon, everyone, and thank you, Dr. Tejpal, for having this session. It's actually very difficult to speak after Dr. Gupta speaks, but I'll still try to deliver my talk. So when we are talking about cervical cancer, and we saw Dr. Mathur speaking that how the incidence has gone down over the decades, however, it still remains the fourth most common cancer among women globally. And if you look at the disparity, there is a lot of disparity both in terms of incidence of cervical cancer, with more than 40% of the burden still being in the low middle income countries. And when you look at the mortality due to cervical cancer, you see that there is a 50-fold difference between different countries, with high-income countries reporting the mortality rate of below 2 per 100,000, whereas we have some countries in Africa where the incidence, the mortality rates are still above 40 per 100,000. Unfortunately, because also of the population size, India accounts for 1/5 of the global burden of cervical cancer, and it still remains the second most common cancer among Indian women, just next to breast cancer. Every year we diagnose around 125,000 new cases of cervical cancer, and around 75,000 women die of it. Now, WHO has already announced a call for elimination of cervical cancer, wherein it will not remain as a public health problem if we get the incidence down to less than 4 per 100,000 cases. And for that, the 90-70-90 strategy has been announced, wherein we are looking at 90% of the girls receiving the HPV vaccine, 70% of the women being screened at least twice, once at the age of 35 and then again at the age of 45, and 90% of the women who are diagnosed with either cervical precancer or cancer receiving appropriate treatment. So then this is the life course when we are talking about cervical cancer prevention and cervical cancer elimination. Again, it's not just, yes, HPV vaccination is very important, but then as Dr. Mathur and Dr. Gupta have pointed out, we need to look at awareness regarding other risk factors, including sexual health education, use of protective measures, and then of course secondary prevention, which involves screening and tertiary prevention with appropriate treatment. I'll just divide my talk into primary, secondary and tertiary levels of prevention. So primary prevention, the focus is on HPV vaccination and also creating awareness among both men and women regarding the risk factors. HPV, we know the exact cause of cervical cancer. It is infection with high risk oncogenic HPV virus, which is an essential cause of cervical cancer, though this is not a sufficient cause. And most of the women who are infected with HPV, they clear the infection on their own within a year or two. Many women, when they initiate their sexual activity, are infected. It's a very common infection. And though there are more than 200 HPV types, we are really worried about the 12 oncogenic types which can cause cervical cancer. The most infective, of course, HPV 16 and 18 that are responsible for 70% of the cervical cancer cases, but adding 7 more high-risk type, 90% of the cervical cancers are due to those. Now, though oncogenic HPV virus causes many more cancers, both in men and women, around 90% of the HPV-related cancer among women are cervical cancer, and hence most often this vaccine, HPV vaccine, is also called as cervical cancer prevention vaccine. Now, it has been nearly 2 decades since the HPV vaccine has been introduced globally, 2006, and now we are in 2025. And there have been a lot of evolution in terms of HPV vaccination, wherein we started with 3 doses, and then we are talking now about 2 doses, which has been completely established that 2 doses are sufficient at an interval of 6 months. And then there have been evolution in the form of bivalent, quadrivalent, and now nonavalent vaccine is also available. So 6 vaccines, prophylactic vaccines, are available with us, and WHO has strongly recommended giving just 2 doses that are sufficient at an interval of 6 months. There is absolutely no need to give 3 doses of the vaccine. And in India, we have these vaccines that are available, Gardasil, we have the quadrivalent vaccine, we have the bivalent vaccine, the nonavalent vaccine, introduced at different periods of time, and these are all licensed vaccines in India. And of course, now we have the indigenously launched Sarvavac vaccine that has been launched in 2023. Globally, where do we stand, and where do we stand in India? In India, it's still not been incorporated in our national immunization program, but let's see that 125 countries globally have introduced this vaccine in their national immunization program for girls, and also 47 countries have introduced this vaccine in their national immunization program for boys. So, however, the coverage is still low, and especially the coverage is low in Southeast Asian countries. So, what are the barriers? One is, of course, the cost, and the second is logistic challenges of reaching the adolescent girls, because we have good system of reaching the under 5 children for vaccination, but we need to find out strategies how to reach the adolescent girl, whether it's going to be school health based or community based or a mixed method. And then again, the other challenge is how do we catch the girls for the second dose? Giving a single dose is much more easier than really following up. There have been a lot of trials now to see if single dose would be sufficient, and these are all the trials, randomized and non-randomized trials that are underway, and we are soon expecting the results of a single dose HPV vaccine efficacy. However, the results have been so encouraging, the intermediate results are encouraging, and hence WHO has also recommended that you can go in for a single dose vaccination, and many of the Western countries, both developed and developing countries, have already introduced single dose as a strategy of HPV vaccination, including the UK, Ireland, Australia, and many of the middle income countries. And some of the countries are now thinking about starting the immunization program with a single dose HPV vaccine. So this is regarding the primary prevention. What about secondary prevention? When we are talking about secondary prevention, it's screening for cervical cancer. And we need to remember here that women are actually asymptomatic when they have a precancerous lesion. And this is one disease where we have completely understood the course, that a woman gets infected with HPV virus. She then, over a period of next 10-15 years, she goes through the process of precancerous lesion, CIN1, 2, 3, and then develops an invasive carcinoma. So we have a large interval of 10 to 15 years during which the women could be screened, a precancer could be picked up, and the women could be completely treated. Cytology-based screening, it was going on for decades together in all Western countries, and they got down the incidence of cervical cancer. Our institute, Dr. Sudip Gupta just shared the trial wherein we have shown that VIA-based screening, that is visual inspection after application of 4% acetic acid, actually reduces mortality due to cervical cancer, and this is what has been incorporated in our national cancer control program. We do have a lot of evidence showing that HPV-based screening does reduce mortality due to cervical cancer. So all these methods are effective. However, WHO has strongly recommended that one needs to go for HPV-based screening, and the reasons are it is much more objective. The negative predictive value is very good, so you need not screen every 2 yearly. You can lengthen the screening interval to 5 to 10 years. And then there is an opportunity for self-sampling. So there are a lot of advantages in terms of HPV-based screening. However, WHO has also said that if you are not able to start up with an HPV-based screening program, you may continue till the time the logistics are in place. If we look at the globally, what is the screening scenario, then we see that most of the Western countries are now transitioning from the cytology-based screening to HPV-based screening. However, India and a few African countries are still continuing with the VIA-based screening. Then what about, do we stop at the screening stage? In fact, I would say that if you don't have diagnostic and treatment linkages, one should not initiate the screening at all, because you cannot, create a problem for a woman who is now happy and then tell her that, you don't know what to do about it. So establishing diagnostic and treatment linkages is absolutely essential, and anyone who is screened positive ideally should be referred for a colposcopy and establish a diagnosis with the help of cervical biopsy. But in places, and there are so many places in India where colposcopy may not be feasible, and therein you can go in for a screen and treat approach. Very simple methods of treating cervical precancers in the form of cryotherapy and thermal ablation. These are ablative methods, but can be performed at the OPD level. But then if you have the facility, then you can really treat a precancer and have the histopathology in place with the help of LEAP, and if there is an endocervical lesion, going in for cervical conization. If a woman is diagnosed with an invasive carcinoma, of course, all the combined modalities will need to be in place. So what are the challenges and what is the way forward? We do have a national cancer control program. In fact, we may be one of the initial people who had this in place since 1975. And the program has now been changed. We have incorporated all the other non-communicable diseases also in the program, because the risk factors are same. So now we call it National Program for the Prevention of Non-Communicable Diseases. Though this program hasn't been in place and always awareness and screening were a part of it, still less than 2% of our women have been screened for cervical cancer. So what are the barriers? I think in the last two presentations also we were talking, what are the barriers why women do not undertake cervical cancer screening? Of course, I think there are lots of barriers, but then lack of awareness is one of them. Not having the screening facilities in place is one of them. The screening services being non-accessible, they are not there in the nearby area, is also an issue. And then many a times women are actually not the decision makers. It's the spouse, the in-laws who are taking decisions for the women. But someone just asked a question that, if the woman is aware, and then also why she doesn't undertake a screening. For cervical cancer, I can tell you that many of the women, they don't like to go in for a gynecological checkup. They find it embarrassing, they are shy about it, and there's always a preference to be screened by a female gynecologist rather than a male doctor. So there are many barriers, but herein we have a solution because we are HPV self-sampling. Now, HPV self-sampling has been tested in Western countries, in India, and the results are as good as a physician-collected sample. And we have done a lot of studies on HPV self-sampling at Tata Memorial Hospital as well. So then, years back, we thought if it's working in Western countries, will it work in India? But then India is really so diverse. We have the slum population, we have the non-slum, we have villages, we have tribal groups. And I was just thinking, if we are going in slums, they don't even have a washroom inside the house. So where is the woman going to collect her self-sample? Then when we are talking about rural India, where the literacy rates are so poor, and the women is, will she be able to follow the instructions on a pamphlet? And Dr. Gupta was then the head of Gynae DMG, and he suggested, no, you randomize it, not just urban, rural, and non-slum, but you have to randomize it into a pamphlet arm and also a health education arm, and then see what the differences are. So we did all that, and we also looked at whether women in tribal area will be able to take it up and whether it would be really a valid thing. And we published several papers and did several studies, and one of our papers is now published in the International Journal of Cancer, and where we saw that women in all these regions were able to collect the self-sample properly, and there was very good acceptability, and the validity was very good, and some of the differences that we have published in our paper. Of course, we developed a lot of health education material, very innovative material that we put in place. We developed animated videos on how to collect a self-sample. We had pamphlets that were completely pictorial. And to address the barriers, we actually made a movie looking at the different kinds of barriers and stigma. This is a 45 minutes movie on cervical cancer barriers, and it is prepared in such a definition that it could be relayed in theaters also, and we got it translated into 8 different languages. We have storyboards in place and very different material in place. Again, when we talk about, we are based in Mumbai, but then India is so diverse. So we thought that if HPV self-sampling is working in Maharashtra or in Mumbai, is it going to work all over India? So we took this huge study under the GACD, where we are looking at 8 different states in India, north, south, east, west. And we were looking at how would this work. Now, whenever we are going to the area in the community, it's so important that we establish a rapport with the stakeholders. So stakeholders at the district level, at the taluka level, at the village gram panchayat level also. Unless you talk to them, unless you are telling them what you are going to do, and if they are not involved, they are not going to allow you to be there. So establishing rapport with the stakeholders and actually telling them what we are going to do is important. Even after having the villagers, the women with whom you are going to conduct this study or the program, they need to be completely informed, and these are at 8 different locations that we are doing it. And then look at the village settings. They are so varied in India. Difficult to reach villages, difficult to reach hilly terrain, having to cross rivers and go, and we actually reached all these groups. There are opportunities also. We went to Trivandrum, and they have this Arogya Shri Yojana, and where the women, they anyway assemble there, so we went and delivered our education programs over there. And then these are the different steps that we take. Whenever you go to the area, you need to really go and do door-to-door survey. You need to enlist your population. But one thing that I would like to mention here, which we just started few years back, all these decades, we used to focus our programs only on females, educating females, talking to them and creating awareness. But we realized that they are anyway not the decision makers. So now we have our programs that are equally directed to the male partners as well. And the entire education that we do, the interventions that we do are also with the male partners. And this is the SHE session, the sexual health education session being run for males as well as for females. And the movie being shown together, we are showing them how to collect the self samples and how to transport it. Again, before I end, any community-based practice or program that you undertake, it's very important that you monitor it. The quality assurance is very important. You can't just leave it to the field workers and not monitor it. And these are the different sites where we are personally visiting and doing it. Involvement of ASHAs, because the sustainability of the program is going to be if you involve the ASHAs, and this is what Dr. Gupta was talking about, that we need to really build capacity and train them in conducting standardized awareness program. Awareness is not just, you go and do awareness. No, you need to train them, and we engage with the ASHAs and ANMs. And during the COVID times, of course, we were doing it virtually, but we are actually doing all offline sessions with the ASHAs and ANMs, training them how to conduct standardized awareness program. And this is one of my last slides, wherein now we have introduced one more thing, that is actually training the peer ambassadors, that is identifying women from the village, 10, 12 women from the same village who are very vocal, who are ready to give that time, and we are training them to conduct awareness program. And this is actually the peer ambassadors training 30 other women to conduct, telling them about the cervical cancer awareness, and we are monitoring these sessions. So to summarize this, I would say that cervical cancer is a preventable disease and can be completely eliminated by multi-pronged approach. We need to look at systematic community-based awareness, and though our NCCP program involves VIA, we can go in for HPV-based screening, and we have a big opportunity in terms of self-sampling. We need to have treatment, referral, and treatment linkages, and involve the male partners as well in decision making. So all our coordinated efforts would definitely lead to elimination of cervical cancer. Thank you.
Thank you, Dr. Gauravi. I think because of shortage of time, we'll just get to the panel, and questions can be addressed to Dr. Gauravi. May I invite all the speakers on the panel for the panel discussion? Anushil, you can join us on the panel. Dr. Sudeep has to leave, so thank you, sir. So we come to the last part of this session, which is the panel discussion on the women's cancer burden in India. And we all heard from all the three previous speakers regarding the global burden, the Indian burden, the changing epidemiology, the prevention and screening. So I would start with Anushil. Anushil, what, according to you, I mean, we saw what are the challenges, what are the barriers. What, in your viewpoint, is the roadmap ahead, not only for women's cancer, but in general for access and equity in cancer care in the country?
Well, this is I think, a very broad question. I think, first of all, I think starting from even the registries, I think there needs to be a lot of crosstalk, a lot of interaction between the databases that we have, be it registries, be it other hospital-based stuff, and continuous interaction in terms of what strategy is working and what is not. Because unless we know what is working and we continuously keep on, for example, the other day, we have these pictures posted on the cigarette, this thing, of looking very dangerous kind of pictures of throat cancer, this thing. Some, societies and NGOs gave me a feedback that such kind of dangerous or non-appeal, they actually put people off. They don't even.
But that's the whole idea, to scare you.
No. So the thing is, you don't need to scare them. You need to educate them. You need to make them read what you want to convey. So what I mean to say, there needs to be a dynamic interaction between what you do and how the society perceives it, and whether you need to do some course correction. So that is the message I would like to give. I mean, one, some interaction between the databases that you have, and then interaction between the society at large and what you are doing as a policy.
I also want to ask you, can you sort of share your thoughts on augmenting capacity building and augmentation of infrastructure as far as cancer control and cancer care is concerned?
So you would appreciate and you would definitely agree that although the problem of cancer is spread across our country, rural as well as urban, the majority of the facilities are there in urban. The majority of the setups is there, majority of the focus is there on the urban, majority of the information access, majority of literacy rates being higher is there. So everything is higher in terms of facilities in the urban scenarios compared to the rural. So this asymmetry needs to be addressed. We need to see where the cancer, which are the areas which have density of, for example, if I take the example of radiation oncology infrastructure. So we had 2 publications on what is the symmetry or the asymmetry of radiation oncology setups across the country. We have maybe around 800 or 850 or 900 machines, maybe around 550 centers which have these machines. And you would be surprised to know the gross asymmetry that we have. For example, we should be having 1 per million.
That's the
on
minimum.
An average. That's the minimum. On a national average, we have around 0.6. Delhi would be having around 2.5, or maybe a bit even more. There would be states which are having 0.08. 0.08. So for example, UP, Bihar, West Bengal, they need a whole lot of more machines compared to others. South is doing better compared to other states. So our infrastructure is not commensurate with what is happening in that region. It is influenced by many, many other more factors, be it financial factors, be it government policy factors, which are not necessarily always in tune with what is the ground reality and so on and so forth. That is my take on this.
So coming to Dr. Mathur, you did show all the changing epidemiology, and we are all aware that breast cancer has now become the #1 cancer, and there is a clear decline in cervical cancer. So what do you think are the main reasons driving the decline in cervical cancer and the increase in the breast cancer? Yeah, I mean, you briefly covered that.
Yeah, I mean, these are all related to exposures. So, I mean, for breast cancer, lifestyle changes. So, rising obesity rates, sedentariness, so metabolic syndrome, these are the prime drivers. Whereas for cervical cancer, we discussed it at length, I think, some of those.
Yeah. So Dr. Prashant, can I ask a question?
If I may just say one thing, what do you think about delayed childbearing for breast cancer? Because I read an article that said that having the first pregnancy after the age of 30 is the most important risk factor for breast cancer. And this is a feature we are seeing increasingly.
Yeah, it is increasing.
In
so that could be driving that, but maybe in a certain section of our society.
And the other thing which I've read some papers on is this increasing exposure to light at night. The decreased period of darkness ambient that we are exposed to, especially in some of the jobs like these call centers and all, where they are working all night. And
So,
things
I mean,
like
lifestyle includes all these sleep patterns, physical activity, stress. They have yet not been measured in that sense, but as a package, these are drivers.
So, Dr. Prashant, I wanted to ask a question. Have you been able to identify 2 or 3 same factors which have increased breast and decreased cervix?
No, I don't. So, as I said, a registry will only show you a problem. It will give, it is a means towards an end, not an end in itself. So, it will show you this is a problem, but further maybe analysis, further research. A lot of things need to be.
So I was just thinking, maybe if you take lifestyle as a broad factor, so we say lifestyle has increased breast cancer risk, but the same lifestyle in perhaps propagating cleanliness or things like that may have reduced cervical cancer.
That's what he said, I think, about hygiene. But see, increased age at marriage will decrease cervical cancer, will increase breast cancer, not the marriage part of it, but the childbearing part of it. The first child, having the first child later, and fewer children and less lactation will increase the breast cancer, but it will decrease the cervical cancer. And generally speaking, we used to see the cervical cancer patients as being very lean, thin, underweight. But now in recent years, we are beginning to see overweight cervical cancer patients, which we never used to see before. So those things are clearly not hard and fast.
So, Dr. Gauravi, you talked about HPV vaccination, and I just pulled out this meta-analysis that looked at the knowledge, attitude, and practices. And you can see that the knowledge about the vaccine is pretty low, only 22% pooled prevalence. The positive attitude, fortunately, is slightly better. 45% are sort of positive about it. But the coverage of vaccine is less than 5%. So, I mean, really, I think there is an opportunity there to increase this awareness and improve this uptake of HPV vaccine in the country.
Yeah, I think we now have a tool, right, for primary prevention of cervical cancer that has been shown to be really, it has a good efficacy, it is safe. Once it is really incorporated and implemented in the national immunization program, we, of course, like we saw with the MMR vaccine and COVID vaccine, the country has capability and capacity to go about and increase the awareness, change the awareness levels totally, and also to implement it, whatever different methods that it may be school-based, it may be community-based, or I would say a combination of everything. And I think the acceptability will be much more if it's a single dose vaccine rather than giving it in multiple
You mentioned
doses.
that WHO now suggests that you can go ahead with a single dose vaccine.
Yes, yes.
So in fact, the IARC India trial, as it is now called, our trial which started in 2009 as a 2 versus 3 dose trial with about 9 centers. Tata is one of them, we are one of them, and then there are others in Pune and Barshi and in Hyderabad, in Ahmedabad, Mizoram, Sikkim, so it's all around the country, and which got suspended inadvertently because of problems in another study, has been the largest contributor actually to single dose information so far. It has served as the proof of concept for the RCTs which are ongoing. And the JNCI has brought out a monograph in November, which is a free download, and anybody who wants any information on single dose, that's the one to go to. And the IARC trial now has the longest follow-up of a single dose population, averaging 12 years, max 15 years. So this is one of the ones which has been the basis for the WHO's current 1 or 2 dose recommendation. And even in UK, the JCVI has used the information from this trial to go to a 1 dose now.
So I think I'll open the last few minutes to the floor. So if there are questions, please feel free to ask any of the panelists.
Thank you. Not a question, just wanted to add to the discussion. When we were talking about, you showed that the awareness on the cervical cancer uptake was very low. I was in actually American Cancer Society last year, and we had partnered with Foxy and IIP because it was identified that doctors themselves are not having a very good awareness on the HPV vaccine. So I still remember, I think I might have attended more than 100 webinar sessions across India, across the pool of doctors, and there was very good interest, especially among the our Foxy colleagues, and amazing interest that they had shown. Now the same program is being run under IMA, that IMA has, and the Foxy, they have a partner, then under IMA branches. Last year it was limited only to, let's say, Foxy and IIP members, but now it is open to any specialty, be it a pediatric, the veterinary, the skin, and anyone. So this program is going, and the point is, this is probably is going to be one of the building blocks Of course, as you rightly mentioned, whenever the government of India rolls out the vaccination, it will have a very good impact. But then all these factors are going to have a building block to increase the HPV vaccine. Thank you.
We had a very good experience when we went out to vaccinate, and we did our vaccinations back in 2009, 2010. And there was really practically no refusal on grounds of education, religion, occupation, or anything at all. The only people who refused vaccination were those who had refused all EPI vaccines. And there were those who said that when the government rolls it out, we will take it. There is so much faith in vaccination in this country, and there is so much faith in the government's promotion of it. And historically, every time there has been a new vaccine, the moment the government has put it in the public program, even the private market uptake has increased. You're right that that program is a good program. I have a problem with that program. And that is that it falsely gives the impression that if you have not done this training, you cannot prescribe HPV vaccination. It's actually leading to hesitancy among others. Now you have 44,000 people in Foxy. You've trained 10,000 of them supposedly. And let's not talk about the ones who just switched on their mobiles and left them on and never bothered to really hear it. But the others are saying, I'm not trained to vaccinate, and we should dispel this myth. Let no one go and ask the doctor, do you have a training certificate that you can give me vaccination? Because it's a simple vaccine, it's a safe vaccine, it's as safe as the tetanus toxoid is what the CDC has said. There have been no identified problems with the vaccination. It's an intramuscular injection. Some girls get hysterical reactions. A 3-room strategy is recommended by WHO. As I said that to somebody, someone said, you know what happens out in the villages? There is not a single room. I'm like, okay, you have to put up a curtain maybe and see that the girl is not being watched by the rest of the village when she's being vaccinated. So whatsoever it may be, that you keep them in 3 different areas, before you give, when you give, and after you give for observation. And there should be no doubt that a majority of people have 0 contraindications to this vaccine.
Yes, at the back, please.
You
wanted to add that you mentioned that later age marriage lowers the risk of cervical cancer but raises the risk of breast cancer because of delayed childbearing. What do you recommend, what would strike the right balance in this case?
That's a tricky one.
It's a very tricky one. And some people even say that talking to women about having more children, there are countries which are saying have more kids, and the is actually also a gender issue. It's actually coming in the way of women's careers and their progress and so on. So you really can't decide what is right for anyone. But yes, they must realize that when they postpone their first child after the age of 30, there is a certain risk, and what best can be done is to make sure, double check that your screening is going right, so that if at all it happens, then you catch it early, treat it early, and then it has become much simplified. It's not that huge mastectomy anymore. It's just a lumpectomy with so many good people here to treat you. So at least you should be aware of the level of risk and counter it with the level of protection.
I think for lack of time, we have to end here. And thank you again to the chairpersons, the speakers, and the panelists, and the wonderful audience for their engagement. A big round of applause for all our chairpersons and panelists. And may I invite Dr. Yamini. I'll carry. So, can I request Dr. Nirja to present a memento to Dr. Prashant Mathur?
This one for you. For you.
So, Dr. Anju, you just want to give a concluding remark?
This was one of the greatest, I think, very good session conducted by Dr. Tejpal Gupta, and especially the talk by Dr. Sudeep Gupta and Dr. Prashant Mathur and Dr. Gauravi was great. I really enjoyed the whole session. It was really very informative and people were listening very attentively. Thank you. So Dr. Gupta, this is for you.
Thank you. Thank you.
Thank you so much.
I was in Dr. Dickinson medical device. Once we had connected because we were aiming to do something that couldn't materialize. After that, last year I was in American Cancer Society. At that time, actually, it was not into the screening per se, but then I was doing this vaccination. Now in the
Wanted to congratulate you for your great work that you are doing. Despite how busy people are, I know in Tata Memorial Hospital, you care patient care so much every day.
So can I actually see the presentation on this laptop as of now? So is there a pointer that I can use here? You said no? Yeah, yeah. And how do I actually activate the pointer? Sorry?
टोटल प्रेजेंटेशन कितनी होगी आपकी? एक ही चलनी है?
एक ही चलनी बस,
एक
बस,
चलनी है ना?
पूरे सेशन में।
कोई नहीं, ये ओपन ही रहेगा आपका।
हाँ।
यहाँ से आप कंट्रोल जो भी जैसे
हाँ।
बस आप स्क्रीन पे मैं शो कर दूंगा जब आप प्रेजेंट के लिए बोलोगे।
नहीं, ये स्लाइड आप रहने दीजिए।
ये लगा रहा है ना?
हाँ, क्योंकि ये सेशन का पूरा यही है ना।
ओके, ठीक है।
और बट ये है कि व्हेन आई एम एक्चुअली यूजिंग माय ओन लैपटॉप,
हाँ श्योर, तो नहीं इसे आप डाउन कर लेते हैं वो।
इट विल स्टिल अपीयर, राइट? एंड देन आई कैन पासवर्ड नहीं है इसका कोई?
नहीं।
So if I just do this and pick it up after I'm done. Okay.
यस सर। आप ये सजेस्ट करेंगे कि बाहर ही लगा दें ना? मैं तो सोच रहा हूँ बात ये है कि अगर आप
सेशन खत्म होगा तब कर लें, यहाँ पे फिर उसको ऐसे ही कर लेंगे। ऐसा करके नहीं, एंड में फोटो के लिए ऐसे हम खड़े होके जो पैनलिस्ट हैं या पैनलिस्ट वहाँ पीछे खड़े हो जाएंगे तो सामने चले।
आप ये बताओ कि ये अगर यहाँ रख दोगे तो वो संतान
अभी एंड में फोटो के लिए अभी के लिए तो
डायनेमिक्स का पर्सन है लाइक कम एज में इतना बड़ा फाउंडर इतना डोनेशन लेकर आया सही है वो बट कंसेप्ट देखो हाँ ये लोग ऐसे बैठे हुए अपना इंटरनल डिस्कशन कर रहे हैं नहीं रहेंगे
बार में पूरे सब पैनलिस्ट आ ही नहीं पाए पैनलिस्ट ऑफ जिसे प्रेजेंट करना है वो करना also there's a confusion कि जो पैनलिस्ट का नाम है वो हैप्पी है नहीं है because that's also happening कि पैनलिस्ट चेंज हो रहे हैं कम हो रहे हैं ज़्यादा हो रहे हैं
I think this is where we'll have the most interaction is from the audience. Everyone knows, what happened during the COVID-19. If at all people are active. I'm sure everybody knows a story. Everybody can give an anecdote about. Hello. from One Health Trust, eGov. Hello, sir. We have 2 more minutes before we start. Yep. 1 minute. So I think we'll start. No patient should die from lack of medical oxygen. With this thought in mind, I'd like to welcome everyone in the room to the Lancet Global Health Commission on Medical Oxygen Security South Asia Report launch. We are thrilled to have all of you here for the last session of this event. My name is Dr. Varun Manhas. Before I proceed, I'd like to invite the dignitaries for this session on the stage. I'll start with Mr. Mohammed Amil, a technical officer from WHO CRO office, who's also in the past worked at PATH and NHSRC. He will also be our moderator for the session. Dr. Surinder Singh Bisht from National Neurology Forum. Mr. Manoj Jalani ji, a former Additional Secretary and Mission Director, National Health Mission at Government of India, and now currently serving as the Director of Health Systems at WHO CRO Office. Ms. Blessy Kumar, a patient advocate from Global Coalition of TB Advocates. And finally, we are also privileged to have Dr. Jayendra Kasar, a Senior Program Officer at PATH, who leads the oxygen portfolio under the Family Health vertical. A very warm welcome to all of the panelists here. 2.5 years in the making, the Commission released its report on 17th February 2025. The Commission found tragically wide gaps in access to medical oxygen, focused on specific regions of the world, including this one, that are contributing to a large burden of death and disability and putting many nations at risk of mass fatalities when the next pandemic strikes again. I'm honored to be here today representing the Commission to moderate a discussion on its key findings and recommendations as they relate to South Asia, and to hear from key regional stakeholders, including the WHO Southeast Asia Regional Office, the NGO PATH, National Neonatology Forum, and critically to hear from an advocate with direct experience of medical oxygen services in the region. I'm confident that the discussions and presentations will be both insightful and impactful. Before I proceed, I would like to brief you all about the Lancet Global Health Commission on Medical Oxygen Security. The Commission was announced in September 2022 to identify medical oxygen coverage gaps and to provide recommendations to ensure that no patient dies due to lack of oxygen, even during the public health emergencies like COVID-19. The Commission was led by 18 commissioners with expertise in medicine, economics, engineering, epidemiology, public health policy, and representing all regions of the world. Representing India among 18 commissioners is Dr. Ramanan Lakshminarayan, who's an economist and an epidemiologist and an expert in antibiotic resistance. He's the founder and president at One Health Trust, formerly known as Center for Disease Dynamics, Economics and Policy, based in Washington, and now in Bangalore in India. He could not be here today, but I was honored to work closely with him on the commission. In addition to this, the commission existed of 40 advisors representing United Nations and global health agencies, donor organizations, academic institutions, and non-government organizations. Furthermore, an executive committee coordinated the work of Commission and included representation from Mackay University, Uganda, International Center for Diarrheal Disease Research, ICDDRB, Bangladesh, Murdoch Children's Research Institute, Australia, Karolinska Institute, Sweden, and Every Breath Counts Coalition, United States. The commissioners deliberated over 2 years, consulting with governments, global health agencies, clinical groups, patients, to produce a series of findings and 52 recommendations to address them. The report has a lot to say about South Asia. The region is home to the largest population needing medical oxygen each year, which is about 91 million, and also has the region has the second widest gap in access after sub-Saharan Africa. The commission found that just 1 in 5 people who need medical oxygen in South Asia for acute purposes actually get it. The greatest inequities are for people, particularly children, attending small health facilities in rural areas. The Commission estimated that closing this regional oxygen gap will require about $2.6 billion per year until 2030. The Commissioner did not quantify the gaps in long-term oxygen therapy, but given the burden of chronic respiratory disease in the region and air pollution, this is going to be very large. We know how much at risk we are. We can recall what happened to the region during the recent COVID-19 pandemic. The Commission reports that almost 30%, which is about 4.4 million, of the 16 million excess COVID-19 deaths occurred in South Asia. Since that time, many countries, including India, have stepped up, and we will hear about some of those developments today. Dr. Ramanan and I, with support from Gates Foundation, worked on designing, developing, and implementing a national medical oxygen grid, which is a state-of-the-art IT platform to monitor and track oxygen demand, supply, consumption, and availability across hospitals in the country. The platform also actually tracks the functional status of oxygen assets that are present in the hospitals. This IT platform has been piloted across multiple tertiary care, secondary care, and primary care hospitals in Uttar Pradesh, Karnataka, and is now currently being implemented across all district and sub-district hospitals in the state of Madhya Pradesh with the support from Global Fund. Now we move ahead with the carefully considered and planned agenda, which includes a presentation on the report that was launched in February this year, a panel discussion, and an interaction with the audience. We will close the meeting with important remarks from Mr. Manoj Jalani ji, who is the Director of Health Systems in WHO CRO region. We encourage all of you to actively participate in the discussion. I'll kick off the meeting with a presentation on the Commission report. Unfortunately, Dr. Ehsan Rahman from ICDDRB, who's one of the authors, could not be here in person today to present the findings. Following this, we'll have a panel discussion, and some of the questions we'll try and answer in the discussion are health systems in South Asia region able to meet the oxygen demand? What is the most likely scenario if at all we have another pandemic around the corner? Are we prepared? What are some of the leading innovations that appeared from the region during the COVID-19 pandemic to tackle the oxygen axis? We expect to have some key outcomes. First one is basically to have more governments from the region to develop national medical oxygen guidelines to close the oxygen gap. Second, to create a momentum to address the problem of idle oxygen concentrators and PSA plants that were distributed during the COVID-19 pandemic, and also ensuring that there is the lack of biomedical engineering expertise or financing is addressed. Third, to increase the government and partner attention to the 52 recommendations that have been provided by the Commission, and to ensure that uptake of new tools that have been presented in the report, such as medical oxygen scorecard and the oxygen coverage indicators, are used for monitoring progress. And fourth, to increase investment in innovation and research in medical oxygen. So these are the four things we are trying to address. I'd like to add, for those who question the focus on medical oxygen, when there are so many other health priorities, I would like to remind you that medical oxygen is an essential medicine and with no substitute for treatment for at least 20 conditions, including HIV, AIDS, TB, malaria, pneumonia, COVID-19, COPD, etc., etc. Together, these conditions cause around 40 million deaths in 2021 alone, which is about 60% of all human deaths in that year. Finally, I would like to express my sincere gratitude to the World Health Summit Organizing Committee, as well as Leith Craneslade and the Lancet Global Health Commission on Medical Oxygen Security for their tireless efforts in making this event possible. I would also like to thank all the speakers who would be sharing their thoughts today. I'm truly excited to be here with all of you today and look forward to a highly engaging and productive meeting. Let's make the most of this opportunity to learn, connect, and grow together. Before we proceed, I would actually request the dignitaries on the stage to formally launch the Commission report, which was released earlier in February 2025. So without wasting much time, I'll just jump into some of the conclusions or some of the key findings of the report. So I'll be talking about 5 thematic areas that were covered in the report. First one, trying to address or trying to estimate the oxygen need in the region. Yeah. So yeah. So I will actually sort of base my talk around these 5 thematic areas. The Commission estimated the oxygen need of the region globally, and then also try to understand what is the current coverage. And then based on that, they try to figure out the gaps, and then how much would it cost to fill those gaps. Finally, they've actually given some solutions which would be actually sort of useful in addressing those gaps. And finally, there are recommendations for various partners, basically all the players in the ecosystem, starting from government, donors, private players, manufacturers, hospitals, clinicians, and policy, people from policy background. So who actually needs the oxygen? So it has been estimated about 374 million people globally annually need oxygen. And 306 of those, 82% live in LMICs. You can see here on the slide that 30%, about 93 million people live in South Asia. So we've basically got the highest burden of oxygen need. And we are closely followed by East Asia and Pacific region, which is about 29%, 88 million in total. And then Sub-Saharan Africa, which is about 24% of the total burden. And how much oxygen is required to sort of, address this need? It's estimated 4.6 billion cubic meters, which is about 6 million metric tons per year, is required to meet the oxygen requirement of the people who need them. So now looking into the coverage, so 30%, it's been observed that in LMICs, only 1 in 3 people who need oxygen receive it. And if you see that about from 299 million people, 89 million people actually receive the oxygen who have the needs in acute medical and surgical conditions. In contrast, if you see the requirement or treatment requirements or the treatment that people receive for HIV and AIDS, 75% of the people receive medicines for TB and HIV. So the coverage for oxygen is much lower in comparison to the medicines that are required for TB and AIDS. What are the coverage gaps? So 9% of the patients in Sub-Saharan Africa, they are of the total, only 9% of the patients in Sub-Saharan Africa receive oxygen, which is about 1.8 million of the 20.6 million. And in South Asia, the gap is about 22, only 22% of patients receive oxygen, and the gap is somewhere around 78%. Whereas if you see in high-income countries such as Eastern Europe or Central Asia, the gap is much lower, where 50% of the people, approximately 47% of the people who need oxygen get it. So why is there a coverage gap in South Asia? So it has been basically sort of pinpointed to about 4 different gaps that have been identified. First one is the contact gap. So contact gap is when people actually want to go to people are not seeking care, and or there is a referral breakdown. Then you have another gap which is called readiness gap. Once the people decide to go to the hospital, there is not actually adequate oxygen infrastructure in the hospital that hospital can use to provide oxygen. Then you have a provision gap. Either the oxygen treatment is too expensive, or you do not have adequate HR to sort of provide oxygen therapy. And finally, there is a quality gap, which is related to irrational use of oxygen or not following adequate guidelines for treatment. So in South Asia alone, 32.1 million people need oxygen. And you see on the slide, it's been divided into 2 different facilities, level 2 facilities and level 3 facilities. Level 2 facilities here are defined as general hospitals or secondary care hospitals, whereas level 3 facilities are the tertiary care hospitals. And you clearly see that the gap is mainly at the secondary facilities or the general hospitals. So you start with the contact gap at 22 million people, whereas if you go to the quality gap, there are only 4 million people who can actually access oxygen from these facilities. So there are health inequities in LMICs. And if you look at the oxygen infrastructure, the basic infrastructure that is required is pulse oximetry and access to oxygen. And you see across facilities from primary healthcare centers to general hospitals to tertiary care hospitals, the primary healthcare facilities only have access, about 10 to 12% of these facilities have access to pulse oximetry and oxygen. Whereas if you go towards tertiary care hospitals, the numbers are actually better. About 80% of those facilities have access. But if you compare rural versus urban, the rural facilities are 3 times more likely to not have access to medical oxygen and pulse oximetry. Whereas if you compare public to private hospitals as well, you would see that the oxygen provision at private hospitals is 3 times better than the public hospitals. And if you compare between different wards in the hospitals, you see that pediatric wards are only like 30% to 40% of the pediatric wards have access to pulse oximeters and oxygen, and whereas emergency departments and surgery departments actually have better access. So this clearly highlights that the most vulnerable are the rural hospitals and the children who actually need oxygen, because these sort of the wards where children get treated are most likely to not have access to pulse oximetry and oxygen. So we've identified the need. What is the cost of covering or filling the gap? It has been estimated that about 6.8 billion a year is needed to close the coverage gap globally. And if you want to understand the gap for until 2030, the amount that would be required is about 34 billion. And of that, Asia alone, South Asia alone would need 2.6 billion per year to fill that gap. Whereas if you see Europe and Central Asia, the requirement there is much lower, about $148 million per year. So now moving on to the solutioning, the most basic equipment that is required in a hospital to sort of give oxygen therapy is having access to pulse oximetry, which is going to be used for tracking or monitoring the SpO2 readings or for hypoxemia detection in patients. So it is very, very significant to have access to pulse oximetry, which would actually highlight the need of oxygen, which will lead to the delivery of oxygen, safe and effective delivery of oxygen. In addition to this, many other solutions have been highlighted in the report. First one is basically, the first major point is that all solutions do not fit to all hospitals or all entities. So basically one size fit all solution would not work. Different systems would need different sort of solutions. For example, a hospital can have mixed sources of oxygen. Right now, in a hospital, you have 4 different options. You have PSA plants, LMO tanks, concentrators, and gaseous cylinders. So the hospital alone should not sort of rely on one particular source, and they should always think about having secondary and reserve supplies, ideally 3 to 5 days. And then also think about having clean energy and access to continuous energy throughout, because some of these assets, especially PSA plants and concentrators, they require 24-hour running electricity. And as of now, a lot of hospitals have been provided with diesel generators as a backup, but then we need to think about sort of cleaner solutions, which are basically sort of solar-based solutions. And one important solution for impact is having adequate monitoring and evaluation framework. So here on this slide, they've identified that evaluation and monitoring is required at different levels, ranging from local to national to global. And the indicators would differ from the various levels that have been highlighted here. So at local level, you can have service readiness indicators or quality of care indicators, whereas at national level, you would have indicators related to availability of oxygen therapy or oxygen equipment, or affordability of oxygen therapy and adoption of various guidelines and sort of standards that have been sort of published. And at global level, the WHO has come up with the 2023 WHO Oxygen Resolution, based on which an Atmos card has been sort of prepared, which is also present in the report for you to actually go through in detail. In addition to this, various other oxygen innovations have been highlighted, over 20, and they basically fall into 4 different categories. First one is pulse oximetry and oxygen use. Second is the oxygen supply mechanisms. Third is coordination and collaboration. And finally, the fourth is the oxygen market access. So there are multiple solutions sort of provided in these sort of different buckets. For pulse oximetry, basically thinking of designing new pulse oximeters which are more accurate, and also sort of designing new sort of oxygen delivery devices like masks, which are going to be more efficient in delivering oxygen and would focus on sort of ensuring there is no wastage. Related to oxygen supply mechanism, ensuring that the PSA plants or any other technology that comes is green in nature and actually is less dependent on 24-hour electricity supply from the grid. Third, for collaboration and coordination, the governments need to actually sort of collaborate and coordinate with various stakeholders in the ecosystem. Could be private players, could be policymakers, could be patient groups who would actually sort of suggest and improve the oxygen delivery. And finally, the market access. The private players have to ensure that there is transparency in pricing, and they also need to focus on strengthening production of oxygen across LMICs and not only focus on high-income countries. So finally, the 52 recommendations that have been provided in the report, and these recommendations are actually for various players in the ecosystem, which I've already highlighted, starting from government, industry, donors, professionals, which are clinicians. Then you have global health agencies, civil society, and organizations that make standards, and also academic institutions. So I will go through in details what these recommendations are. For government, so basically first and foremost step is to have national medical oxygen guidelines. Every state or every country should have that. Then They should actually increase domestic spending to strengthen oxygen supply chain. They should update the clinical guidelines and policies related to delivery of oxygen. They should also integrate indicators in understanding the performance, not only of the clinicians, but also the technicians. Then also negotiate an affordable and reliable oxygen contracts with industry suppliers, especially wherever there is dependence on third-party players, for example, for LMO refilling or gaseous cylinder refilling. For industry, the recommendations are basically develop new sort of initiatives, commit to price transparency, think about innovations, think of new methods of producing medical oxygen, could be on-site, off-site, which are cost-effective and cleaner, and also have higher manufacturing across LMICs. For global health agencies, it's basically to include pulse oximetry and oxygen in all health and pandemic-related clinical guidelines. For example, when you walk into a hospital, your blood pressure, your height and weight, these sort of vital signs are sort of measured. It should also be made mandatory to have pulse oximetry or SpO2 reading included in those vital signs. Then you also support national governments to develop oxygen plans. So thank you, everyone. So I'll just continue. So also ensuring that 50% of future oxygen initiatives, their operational costs are covered, and then also increasing access to oxygen data so that a lot more insights could be drawn, and we could take better measures to ensure the gaps are covered. And for the donors, basically contributing to the Global Oxygen Alliance, which has target of about $4 billion until 2030, then support the full replenishment of the Global Fund that has actually worked tirelessly in strengthening oxygen across the globe, especially in Africa. Then also respond to the pandemic fund calls for oxygen, also include development bank financing for oxygen solutions, also ensure that quality oxygen devices are procured, and then finally increasing funding for maintenance of these devices, especially PSA plants. For civil society, I think they'll have to hold governments accountable for all the actions. They'll have to support development of national oxygen roadmaps as well. They'll have to play a significant role here. They'll have to establish many more patient advocacy groups as well, and then also strengthen civil society voices in the Global Oxygen Alliance. For the academia, they should actually increase research in 20 priority areas that have been highlighted in the report. There should be support on the implementation science, health systems, and health economics research. There should be also champions to use the oxygen care, oxygen coverage indicators for research, and then also identify gaps in workforce capacities, especially biomedical engineering graduates, and then also include oxygen in clinical and biomedical curriculum when they teach both clinicians and biomedical engineering going forward. For the ISO standard organization, they have to review all the standards and keep updating from time to time, ensuring we align with WHO oxygen resolution. Then also reduce fragmentation in standards across different regions. They could be related to equipment, they could be related to clinical delivery of oxygen. Then also ensure that 50% of the participating members are from LMICs in the ISO TC 121. And finally, for the professionals, you may have to formalize the National Biomedical Engineering Professional Associations in country, also fortify regional professional associations, and then also ensure clinical professional societies support workforce development to strengthen access to pulse oximetry and oxygen. So with this, I will actually stop here. And then just to highlight that you can actually find many more resources at the link that has been shown on the on the slide here, which is Stop Pneumonia -lancetoxygencommission.org. You can find a report with comments, you can find media statements, you can find policy brief in various languages, and then you can also find the Atmos oxygen scorecard and patient and caregiver testimonies. also the 10 important indicators, and also the 20 priority areas for oxygen innovation. Also, you also have access to the case studies that have been published by Bangladesh, India, Malawi, Nigeria, and Sweden, Uganda on the website. So thank you everyone for your attention. And now I'd like to pass on the dais to Amil, who will be moderating the panel discussion. Over to you, Amil. Thank you.
Thank you. So may I request the panelists to kindly take their seats on the dais first. And of course, very comprehensive presentation, Varun. Really appreciate that the work the commission has done. And we, of course, miss all our friends who worked really hard on this, Leith, Ramanan, and of course, there are so many in the rooms that who have already contributed to it. And as Varun mentioned, oxygen has no replacement. And from a public health perspective for medical oxygen, we need to find sustainable solutions. Solutions where we are not dependent on external sources so that we are able to mitigate any challenges that come our way. And in pursuit of these sustainable solutions, one of the actions that we as WHO took in the past is, for example, installing oxygen generation plants within the hospitals and powering it through solar panels, making it self-sufficient, not just from an operational point of view, but also from an economic point of view. And that has been documented and been a model which needs to be talked more and more. What we also did during these times, especially COVID and after that, we documented promising practices that countries adopted in oxygen, improving oxygen access during the pandemic. And a lot of colleagues who are in this room have contributed to this. I can just show you the glimpse of this book. Apologies, we don't have many hard copies because these are times where we more believe in digital copies, and we are happy to share the link of this. Very well researched document this is, where where countries across the region have contributed to their lessons learned and the good practices that they undertook. Now, without much further ado, I will move on to the task that has been given to me, that is to moderate this discussion. I think one of the easiest ways for me is also to, because this audience is also so enthusiastic about this subject, I can give a lot of time to you to ask questions to the panelists or otherwise, but there are certain questions that we wanted to, of course, direct towards the panelists. And let me take this opportunity to talk to my friend, colleague, and Jayendra, who comes from PATH. So, Jayendra, my first question to you is, during the pandemic and otherwise also, PATH has contributed significantly in this area. And with the help of course, the donors and partners, which of course we need to acknowledge and mention. You've done some incredible work. There's the Oxygen Library also, which has been shared with you. Despite all these efforts, the Commission shows there are significant gaps. What do you think are the reasons, and what do you think steps could be taken going forward that we can close these gaps and mitigate the challenges that are coming forward to us time and again, not just pandemic, we hear instances otherwise. So, Jayant, you may take the floor, please. Thanks.
Thanks, Amil, for the very pertinent question. And pleasure to be here as a part of this discussion. Before I answer to your question, I would really like to congratulate Lancet Commission for the regional launch of Medical Oxygen Security Report. And also thanks for putting all the data, which is available now region-wise. Data in terms of what is the current need, what are coverage gap in different regions, also provided the solutions and then the recommendations around it. So many congratulations those who are online attending. I think Leith is joining online. So congratulations for the regional launch of this report. Again, to start with reiterating what Varun has mentioned, and what we need to understand is that medical oxygen is an essential medicine. It's being used into the system for more than 150 years now. First time it was used in 1885 for the treatment of pneumonia, for the hypoxemia. From there till now, in 2017, WHO has included into the essential medicine list as an essential treatment for the medical oxygen with no substitute. And you might be aware that medical oxygen is required for wide range of healthcare conditions, pneumonia, cancer terminal treatment, road traffic accidents, and these diseases like the burden is going up. Also acute diseases, also from neonatal to adults to the elderly care services, medical oxygen is required. It's an integral part of the health system and it's not any vertical subject as such. It's required at different level in each healthcare facility at different capacity, for sure. And we also seen, though in spite of having so much of importance, medical oxygen was not prioritized till we saw COVID-19 pandemic. It's required in crisis as well as it's required during the peace time. And what Varun has mentioned and what Lancet has put out, around 70% people in LMICs, those required medical oxygen for acute condition as well as operations do not have access to medical oxygen. So he mentioned that 22% have access. Also, yearly around 400 million people will require globally medical oxygen. So that's a huge amount. And if we linked SDGs to the medical oxygen, out of 9 SDGs of goal 3, 8 targets are linked with those. So the case is very clear. Investing in medical oxygen will accelerate progress of achieving SDG. It will also help us to achieve USG, universal health coverage. It's largely because if we provide free access to medical oxygen, the out-of-pocket expenditure can come down, and as it is required for multiple conditions, and cost is high, and that may be the reason for the coverage gap, which highlighted into the Lancet series. So moving back to your question, Amil, Path with experience of working on medical oxygen for more than a decade, and multiple countries have worked closely with these governments in India, with state governments and national government as well, for providing technical assistance to improve the capacity of the medical oxygen in terms of the production as well as the storage capacity. Introduce lots of innovations which can be scaled up, including the solarization of PSA plant, which we piloted in Karnataka. Develop various tools in terms of forecasting, demand estimation, and as well as the regular monitoring. Moving that, at global level, we have relaunched the Access to Oxygen Resource Library. It's a house of around 1,600 resources, which includes various tools on forecasting, various publications, the guidelines of different government from different countries. It also has the various published articles housed into it. And recently with this launch of Lancet Commission report on medical oxygen security, all the resources which were released and published now, this library is the official house of all those resources. Moving forward, what will be the priority? Again, aligning with the Lancet Commission's recommendations, our focus will be on working and piloting and generating evidence on the new technologies. New technologies which are affordable, which will have the less energy consumption, which will have less carbon footprints, the technologies which are easy to deploy at different conditions, high altitude, high temperature, the density, different level of density into the air, also difficult to reach area, and which can be easily deployable at difficult to reach area. That's one focus area. The another kind of barrier in access to medical oxygen is the medical gas pipeline. And current system of medical gas pipeline is very complex. So kind of working on the newer technologies which are easy to, which are very flexible and also easy to install. Such kind of medical gas pipeline systems will be focusing on. Again, during COVID time, I think government has put lots of effort in ensuring the resources. Now I think focus should also be given on how do we utilize these resources in terms of by improving various processes. For example, putting up a booster plant. We worked with the army in Jammu Kashmir, to put a booster plant on PSA plant and then supplying filled oxygen cylinders to the border area for the residents there as well as the army there during the crisis time. So similar kind of innovation, whether those can be deployed so that hub and spoke model can be formed, and then primary or secondary health facility will receive the oxygen cylinders. In terms of the energy efficient, like solarization is one of the component which we tried in Karnataka. I think generating evidence whether it's cost effective or not, because at the end solarization is also a biomedical equipment maintenance task, and current challenge is on the biomedical equipment operations of the PSA plant. So looking into the evidence whether that's cost effective, whether that operationally feasible, so we'll work on that aspect. One more challenge which is highlighted here is the non-availability of data. So our focus is also on digitalizing and automizing the data by using the technology like IoT devices for PSA plant and telemetry into the liquid medical oxygen storage tank. That will help us to have the automatic data without the manual entry, which is being practiced in few places, but I think having the consolidated dashboard connecting all the LMOs and PSA plants will give the consolidated picture for the entire state on trends of oxygen consumption, utilization of it, and then further rationalizing it and plan it as and when required. One more important area, as Blessy is here, is that and she is from the patient support group and civil society organization. Is important area for us will be to raise the voices of community for the people who are actually going through this crisis and facing the challenge of acute shortage of medical oxygen. So bringing the need from community, raising awareness among the civil society organization to understand what is medical oxygen, why it is required, and how we can work together to raise these voices to the policymakers. So these are few areas where we would like to work, and thanks. Hope I answered your question.
Thanks, Jayant, for quite a comprehensive response. And one of the key highlights is actually during the COVID, a lot of investments were made in setting up these oxygen generation plants from the government, from the donors, from partners. And now we need to make sure how do we ensure is operationalization, because we can't wait for the next pandemic to hit us to wake up. And so I think it's our shared responsibility, especially not just the agencies that invested in the capital of it, but amongst all of us to make sure that how we make it operationalize. So thanks, Jayant, for this. We'll come back to you with another question. Now I move to the next set of question to Dr. Surendra. Thanks for being here. Dr. Surendra, my introduction to oxygen came with needs of oxygen for the newborn. And as you know, it is such an important, essential medicine for the newborns. Significant improvements have been made in provisioning of oxygen, especially for the newborn. Your take on where have we reached where we wanted to, or there's still a big gap reflecting from what we spoke just? Thank you.
Thank you, Amil. And first of all, thanks to World Health Summit and NIMS and Leith for having invited a professional organization. We are, let me tell you about National Neonatology Forum, which is an more than 11,000 strong member body of newborn specialists across India and in some regional countries as well. And this is an organization which has been founded in 1980, and these have this organization is associated with making guidelines for government and in fact for the regional sir, and I'm so grateful to be seated next to him, who has worked very much and during his tenure in ministry, so many good programs about newborn birth started. And oxygen as such, and I'm really thankful for this use, because here in newborn, we tread very carefully while we are trying to use oxygen as a, we want to emphasize that it's a drug, and it's just not that oxygen can be given to anybody and just give it to the whole room and just give it. So for newborns, we really want it to be used discreetly, and so that it doesn't have its complications with this. Having said that, and as rightly told by Varun, the use of oxygen even in neonatal wards is around for 50%, 40%. In the tertiary hospital and in it is around 60% or 70%, whereas in primary hospital or secondary hospital it is around 40-50%. This is the state in South Asia. You have seen that. So imagine, despite when we are saying, sir, we have opened up around more than 1,000 special care newborn units, and the same has been replicated in the regional countries in the SAARC region, in this region, South East Asia region also. And still, the use of oxygen, and you said actually the 4 gaps which were there, and one of the gaps which was there was the need to identify which babies would require oxygen. There is an issue about not only about the quality, it is about which of the babies would require, and for that we would require pulse oximetry. And when we are talking about newborns, the machines which were just available during COVID, which was around 1,200 rupees or 1,500 rupees, some few dollars, and these are machines which are actually not able to pick up the oxygen saturation in a newborn. So as rightly said, benchtop or machines which are available, which can pick up signals from a baby who is cold, who is moving a lot, who is in shock, and who has some metabolic issues. And these are babies where the sick babies where oxygen picking up right oxygen saturation would be required to prevent them going into irreversible hypoxemia and ultimately death. So this was a big challenge. I think the quality pulse oximetry availability is something which you have said which would make a big dent, and the cost in actually procuring. I'm really thankful to PATH for having invested in my hospital in Delhi. It's a district level hospital in Delhi, in providing us the pulse oximeter that sometimes which were high level signal extraction technology. And I'm not trying to advocate for one brand of pulse oximeter, but that kind of technology, sir, should be available which can pick up signals in newborns, because this is a vulnerable. In fact, you look at the Global Commission, I'm really thankful, they have given neonates need. Around, you see out of all that, 5.4 or almost million normal cubic meter is something which would be required by neonates only. And this is the deficit which we need to fulfill in coming years also. More so in other countries. India, having established its SNCU level and with the generous provision in the NHM of providing pulse oximeter, yes. But as rightly said in the Global Commission, if you read it, our NICUs have become, or the ICUs have become cemeteries of non-functional equipment. So that kind of a maintenance is required. So this is a big challenge. You can procure it one time, but if those machines are not maintained well, in some of the states, like in Madhya Pradesh and some, so they have the maintenance being given to a big one company, which goes around all SNCUs, and you just, the nurse have to just call them and immediately it gets corrected by second or third day. That provision is not there in many of the places, not in Delhi, in my hospital also. So this is big thing that having procured, you need to have a functional equipment. That is about the pulse oximetry, which is there. Oxygen availability, as rightly said, I'm just saying about the installation of PSAs, which just became a fashion, and every hospital was forced to have one PSA just put somewhere, and they are not working. And you have rightly said, the commission has found it that it is actually, some of the hospitals have said that they are white elephants, and some of them have done good audit of the things. In the national medical oxygen guidelines, which has come from this year only, it is a Supreme Court mandated audit. And that audit also, sir, is very, very brief. That doesn't actually give you the dashline indicators of how we are going to audit our oxygen need in this country. And I think I must congratulate the commission, I think, to all the members who have done it, that they have openly said that auditing, and there are indicators which have been mentioned, but the same are not translated in the national medical guidelines also, oxygen guidelines. I think oxygen availability and those will remain a challenge. Functional pulse oximeters, and I'm really, now this, from sir SNCU level, where we were not providing, we are just giving some oxygen. Now we need to move with the help of this to tier 3 levels, CPAP availability, which is that non-invasive kind of a ventilation support, which proved so beneficial in the COVID time to even adults, was always a provision for newborns, but because it was not being provided even at SNCU's level. Now, the government has chosen some of the good SNCUs and providing them with CPAP facilities. I'm really thankful to PATH that in association with NNF, we have done in 2 districts of UP, Gorakhpur and Agra recently. We have actually trained them in CPAP, the NBSU's people as well as the SNCU's people, the nursing staff and the doctors. We have trained them in how they are going to give CPAP also. So that kind of availability of machines should be there, and the low-cost CPAP machines which can run on oxygen concentrators, which has been used in the IKMC studies in Safdarjung and multiple countries also, the Diamedica. Those kind of innovations was one of the innovations that you enumerated. So those low cost, easily available those CPAP machines, which can run even at solar, because otherwise it requires electricity. And in many of the places, electricity is not there in for many hours, and generators are sometimes not available even in the district hospital. So these are challenges which need to be addressed, and I think the Global Commission has kind of addressed every bit of it. I'm really thankful for actually making me a part of that, reading that report also. Thank you.
Thank you, Dr. Surendra. I think a very comprehensive response from a clinician point of view perspective as well. And I was really elated to hear that when you mentioned contribution of National Health Mission in setting up SNCUs to close this gap, and the biomedical equipment management and maintenance program, example from Madhya Pradesh, but of course many states have taken up. And I was just passing a smile to Mr. Jalani, who used to head the National Health Mission as Special Secretary and Mission Director in Government of India. And being one of the spoke in the wheel, of course, all of us take pride in the good work that has happened and continue to happen. But of course, as you mentioned, as WHO and as partners, we are happy to support wherever the gaps are. For example, you mentioned the equipment maintenance part, and we are happy to provide any technical support that might require. We can work with our country office and partners here to do that. Thank you. I think we have taken enough time because of course we have so much to speak to, but going forward, my request to all the panelists would be to be a bit brief, because I want to give more and more time for questions and answers for the audience, because I see some of, for example, colleagues from CHAI and others who have been contributing. So my next question is to Blessy. Blessy, like so many of us, and we'll come to question answers, of course. I was just trying to we have significant time for the panel as well. So Blessy, like so many of us that we know, you were one of the patients who were directly impacted and required oxygen, and your case study has been highlighted in this global report as well. But I think it would be very important that we hear directly from you and how you overcome this. Over to you, Blessy. Thank you.
Thank you so much. And thank you to the organizers for ensuring that there is some input from the lived experiences as well. I've enjoyed working with the Commission immensely, sharing my story and seeing it being made, taken up seriously and action being followed. My name is not Bless Kumar like it's written there, actually Blessina or Blessy, yeah. So when I got COVID in April 2021, I really didn't realize the gravity of the situation when my oxygen levels started falling. And oxygen wasn't available anywhere. Delhi was completely out of oxygen. Everybody was running from pillar to post in desperation to find oxygen for family members. The hospitals were overflowing. Healthcare workers were overburdened. It was a disastrous situation. So when my friends who are doctors heard, they actually said, don't come to the hospital, because if you come, we are afraid that you may not go back alive. Just stay at home and we will manage you at home. And like everyone else, my family was also running around. It was also a time of lockdown, and there was no oxygen available. I work very closely with WHO headquarters in Geneva and in CRO. They were calling me up. There was nothing anybody could do. Government couldn't do anything. Ministries couldn't do anything. Nobody could do anything. So we got scammed by many people who said they will give us oxygen concentrators, and they were quoting a price of 10 to 15 times more than what it costed. But when it comes to saving life, you try and do everything. But we got scammed, we lost money, but we also realized that people were really trying to take us for a ride. Finally, one of our neighbors offered to lend us a concentrator for 24 hours. And I was able to sleep that night. It's very difficult for me to recollect because having come so close almost to not seeing the next day, it's difficult for me. So we got a very small concentrator for 24 hours. I slept, and the next day they sent for it to be returned back. And I kept asking my husband when he said they want it back. I said, but do they have anyone with COVID in their house? You know, I need it. Why don't they let me have it? But I think people were scared. What if we needed it and we didn't have access to it? So, and later on, my husband said that one of the most difficult things in his life he's done, which would haunt him for the rest of his life, is to disconnect the tube and return the concentrator back. So it was a really difficult situation for everyone. Finally, we did manage to get a small concentrator paying 15 times more what it costed. But the reality was that we can never be complacent. You know, we can't say it will not happen to us. I'm a TB advocate, global TB advocate. It won't happen to me. Nothing could, you know, stop it from happening to me. And the realities, you know, long COVID, brain fog, loss of memory, things are something that I grapple with almost to this day. And as I said, when they were writing, interviewing me, I said it really, the memories continue to haunt and shake me. So I want to advocate for a system that is in place so that lives are not lost unnecessarily for lack of medical oxygen. We've heard over and over that it's one of the essential, it's on the essential medication list. I think it's also a question of right. Everyone should have access to oxygen, whether it is a neonatal or an elderly person. And those who have a mandate for protecting the health of the people need to ensure that there is availability and access to oxygen. Yes, COVID was scary for everyone. It caught us off guard and completely dismantled our lives. And we lost hundreds of thousands. Family, friends, neighbors, colleagues. Everyone who died was someone to somebody. The pictures of people gasping for oxygen in Delhi haunt us even today. I know we forget very easily, but we saw in reality the inequitable access to oxygen and other life-saving resources. But we also saw the good side of people. People helped each other when systems collapsed. There were faith-based organizations. I mean, one of the memories is the Sikh community feeding people on the road, running around, getting cylinders filled. There were churches offering, mandirs offering. So people came. We saw the good of people, which is one thing that gives us a lot of hope. And we also saw technology and development. For someone who's been working in TB for the last 20 years, not seeing a vaccine, and to see 4 vaccines come up within months was like magic for me. And in India, we had experts giving us updates on television every day. people had access to good and right information. It killed the WhatsApp University because we knew that at such and such a time, Dr. Guleria from AIMS was going to tell us what the situation was. Many other colleagues came and said, don't be scammed. This is what needs to be done to be treated. So people had access to the right information. And, you know, we cannot forget the catastrophic experience that we all went through. All of us sitting in this room perhaps went through as well. You know, Band-Aid solutions after a cut to stop the bleeding will not prepare us for another pandemic. And my colleagues tell me that it's not far. We are prepared, but are we fully prepared? The world cannot afford another COVID-19 experience. My country, India, cannot afford the lives that were lost. Professionals, the poor, the rich. It was just really disastrous. So I would really ask everyone, it was really encouraging to hear from you, Mr. Bish, but I think all of us have a duty to be prepared, not forget, build systems that are resilient, learn from this, and go on to ensure that we are 100% there so that this doesn't repeat again. Thank you very much.
Thank you, Blessy, and the claps in the room are a response, but we need to answer, are we prepared? And we know it's a rhetoric question, but we also have an answer to that. And to this, on the preparation side, may I go back to Jayendra? And Jayendra, my request to you would be to be brief in your response, but the Commission also mentioned, and you also tried to allude in your first response, is the need for working on the training for human resources, especially the clinicians and the engineering, the biomedical engineering side of it. Your take on these recommendations from the Commission. Over to you. Thanks.
Great. Thanks. So I think during COVID-19, the amount of investment was made was largely on the production or the biomedical equipments which we have as of now for the health facilities for medical oxygen. But comparatively, investment which needs to be made into the systems or the people. I'm referring to biomedical engineers or the ITI technicians and the clinical healthcare workers, nurses and medical officers and doctors. That was comparatively less. So having equipments without skilled resources, I think is a key gap. What we need to do is helping these healthcare workers, biomedical engineers, technicians and clinical staff with the capabilities, with knowledge, skills and tools which are required to enable them to use these resources, tools in terms of the spare parts and then to make them operational. So that's what is required as a key aspects. I was referring to the report and what is recommended when I refer to biomedical equipment maintenance engineers. The need is on an average around 0.4 biomedical engineer per 10,000 of population, which is around 1 biomedical engineer per 100 beds of the patient. I was again referring back to the report which was published in 2017 by WHO to assess the current status of the biomedical engineers in different regions. So which was ranging to 0.33 per 10,000 population and ranging from different regions, like from low and middle income countries it was 0.06 to high income countries it was 0.6. So there is a huge difference. There is inequity in availability of biomedical engineers. Again, depend upon the facility type, what different resources, what different types of oxygen resources which we have and other equipments, we need to rationalize and multi-skill them. We cannot just put having biomedical engineers, but we need to make use of existing resources rationally, scaling them to look into the entire ecosystem of biomedical equipments as well as the entire ecosystem of the oxygen, not only the PSA plant, not only the LMO, but also the supply system, storage system, and at the patient bed end, what is it required. Uh, uh, I think government of India initially started during COVID time to utilize existing ITI institutions as well as the National Skill Department. They develop a module for the medical oxygen operations and maintenance. I think such system needs to be strengthened so that we have the employment generation opportunity for the people and also the planning for absorbing them into the health system so that our resources can be utilized properly and maintained by these skilled resources. Moving to the clinical staff, I think what is it required is about, I think I'll refer to the three main aspect is their capabilities, their motivations, and their opportunities. Capabilities are much more important for the clinical staff because these are the acute conditions and we are dealing with the very vulnerable patients. We need to administer oxygen very rationally and appropriately using the technologies. For example, doing intubation is not that easy task. We need a skilled staff who will be able to administer oxygen or do the intubation to the newborns or to the adults who are already into the emergency and going through lots of pain. So building those skills of these doctors, staff nurses, medical officers is important. And we are working with the guidance of Ministry of Health, at least in the Neonatology Forum, with NNF to build 1.5 days of the exclusive training module, again in collaboration with AIMS, for the new safe use of medical oxygen among the newborns. In terms of, so that's about the building the capabilities of the healthcare workers. What about the motivation? We did see there is lack of availability of the pulse oximeter. So if we do not have the pulse oximeter who can accurately read the saturation level of a patient, I think we will not be appropriately administer the oxygen. Not having the pulse oximeter is also kind of a demotivation that how we will diagnose timely and accurately the hypoxemia condition of the patient. And beyond the pulse oximeter is also availability of the oxygen into the primary health settings. If that's also not there, then that also kind of a demotivation for the healthcare workers. Also, that's more about the facility level of the scaling of the healthcare providers and availability of medical oxygen. But one area which also needs lots of strengthening is the referral transport. Lots of deaths happens during the referral transport not having the appropriate oxygen and also not appropriately administrating it. And that time gap leads to the overall burden of the deaths because of the lack of oxygen. I think that area also needs to be strengthened to skill emergency medical technicians, which we have to appropriately administer, timely administer, and have the medical oxygen in the ambulances, emergency ambulances, which we have. So that's my perspective. Thanks, Amir.
Thanks, Jayant. I think a very rightly said, and I think there is a lot to work in this regard so that we are able to ensure that whatever investments, capital investments have been made, they are functional and operational going forward. My next question is to Dr. Surendra, and being aware of the time, you know what my intended request to you is. Dr. Surendra, you've seen the report that you said you've mentioned, that gone through as well. The report requests the governments, and you work closely with the Delhi government and other state governments, request them to have their national plans, their national budgets, or even sub-national plans and budgets. What is your take on, as a clinician, as a technical expert in this? What is your advice? Thanks.
So, Amil, I think everything has been said so. And the government of India is good that we have a plan ready by this year only. So we have a plan, though the plan looks a little sketchy to me. So it is more of a textbook chapter than the actually calculated plan on operationalization of the system and whatever the scaling and strengthening which Jayendra is trying to tell and you are, Varun was telling. Those things have not been addressed. It's more of a theoretical textbook. What are the kind of oxygen, what are the kind of cylinders, PSA, what is there. and they have given that Supreme Court mandated kind of audit list. And apart from that, they have actually, the good thing in that report is they have actually now categorized for 50 bedded, these very beds actually should have oxygen. The commission says every bed where there is a patient should have an oxygen availability. But the government of India is aware of the situation that it is still not feasible. It is not practical for them to provide oxygen with each bed. So they have given for 50 beds, around 22 beds, for 100 beds, around 67 beds, from 150, 200, 500. So that is actually, that's a good beginning. And I must congratulate to the government for actually having now set up at least some practical thing. Because I know in my hospital, even in Delhi, in a 120 bedded hospital, we are not able to install a good oxygen system pipeline in Delhi for last so many years. So that if having given a guideline, now all hospitals in India can actually have some, and they have given, in this hospital you will have to have this many cylinders, and then there will be a manifold. So they have actually given what needs to be given in that hospital. So now the administration and the health administrators will not be worried of signing the amount budgeted sanction for actually providing in that hospital. I think for me, this is a good beginning, really good beginning.
The commission is also aligned with the what the technical experts think, and especially what is practical, and if that is being taken up by the countries. I think that's a big win-win for the commission's report as well. The countries are taking up in a phased manner what is practically possible, because as Varun said, not once is a size fits all. There we need to be very practical in our approach as well. Now my final question for Thanks. Yeah, this is working. Thanks. So, Blessy, you must have seen the commission recommends a scorecard to measure the progress we are making in ensuring access to oxygen security. What are your views on this kind of scorecard? Is it good enough, or is there certain other advice you have on this? Thanks.
So the scorecard measures architecture, availability, affordability, and adoption. And I think this is a very good tool to track and provide early information and bring any warning signs to the program to set things right immediately, way ahead of the problem becoming huge. And communities are actually well equipped to lead this exercise, measure and report back for quick action. And this information will also ensure and support the efforts to ensure equitable access to the important actions to follow. India has also medical oxygen guidelines, but for these guidelines to be translated into action and reality at the ground level, you need the civil society. Because the civil society, as even the slide showed, is well placed to support the government, holding accountable. And, you know, it's not like finding fault, but it's to work together, joining hands and working together. And civil society is well equipped also to provide that last mile services. In a country like India, it's so huge. Our areas are so remote. We can't expect the ministries and governments to be there right till the end. Civil society will be able to do that because they're already working in those areas. And civil society also can be the eyes and ears at the ground level. So, you know, an early warning system, the minute there is something wrong, you get a call saying that in this sub-district, things are not going on okay. So you can immediately put things right, which is what we've learned and we do in TB in terms of drugs. We have people in the remotest corners who report to us if there is a stock out or shortage. So I think working in a collaborative manner, trusting each other, this can be a great way forward. And civil society also can advocate for increased funding. I saw the numbers that you projected, Varun. And who's going to advocate for that? Governments can't do that. Perhaps they can, but if there is a voice, someone with lived experience saying that this cannot be acceptable, you need to invest. It is a responsibility. So, like you said, it's a win win situation if we work collaboratively together. Thank you.
Thanks, Blessy. We take your point that we need to measure progress. We need to measure how well investments are made, and not just financial investments, investment of all resources that we just heard from you. So that's it from the core panel group part. Now we move on to questions from the audience. I know there are very good people with their experiences sitting here. So I think we already have a hand up from your side, and Varun could help us coordinate that itself. So can somebody pass on to the mic to the gentleman in blue jacket? I think. Thanks. Please introduce yourself first, and then you could.
Hello everyone. Yeah, it's small room. Even though if I don't speak without mic, it will work. Oh yeah, on YouTube. Yeah, live. Anyways, hello everyone. My name is Ashwini Tudeja. I was listening the whole conversation. It's very interesting. It's not about interesting because we are not here for fun. We are here for improving the oxygen quality, and we cannot do that. But we can remove the negative part, which is the negative impact. So that naturally when the oxygen is there, because it's natural, it's not fabricated. Something we store and give the oxygens to the hospital. So my company name is One Infiniting, and we are working in remote sectors. I work in forest areas, remote areas. I work for rural and tribal women development. In terms of, so there are two reasons. One is obviously oxygen. Second, for prevention of premature baby deaths. How? Even in India, I work for Asia, Africa, and Latin America, and even still in India, more than 10 million families, they are facing this oxygen problem in rural areas I'm talking about. I'm not talking about urban right now because I specifically work for rural and tribal people. Like Blessy ma'am, thank you so much for appreciated you have raised this concern. So they're still cooking food in mitti ka chulla, in traditional cook stove. Why? Because they don't have money to refill LPG. I work pan-India with them. And I have the realistic data report, not on papers that on papers we have mentioned that they have LPG, it's all gone. No, nothing. I'm practically working on that. I'm making environmental products for them. I'm making smokeless cook stoves, and I'm making. Yeah. Let me see why I'm telling you from the base, from the source, so that you understand where I'm coming from. Make sense? Yes or no? Thanks. So I'm making smokeless cook stoves, giving to them. So when they cook food in traditional cook stove, there's a lot of carbon dioxide. What happened? You okay? Yeah. So there's obviously a lot of carbon dioxide in the room. They were not able to, inhale properly because they inhale equivalent to 50 cigarettes in a day. That type of smoke I'm talking about. So where the oxygen will be there? No oxygen. The oxygen partition is very less. So in order to take action from here, how can I work with you guys, even for rural and tribal people? I'm ready. I'm available for action. My work is action. I do action on the field. That's it. And so that's what I appreciate all of you. That's what we are here for, And I'm in process to make world's slimmest solar induction, so that it will be more benefited to them. Thank you.
Thank you. And in fact, I have a similar scenario because I belong to rural areas of Uttarakhand. So like he said about smoke. So my brother-in-law went in Angji in the night, and he CO2 narcosis, he was there, carbon monoxide poisoning, and in the morning they were all they fainted. My brother-in-law, real brother-in-law, fainted because the door was closed. And in Uttarakhand, the CHC, they went to the CHC in the morning, and we were here. I'm a doctor. His daughter is a doctor, and we were calling from here, take him to the hospital. The CHC there had only a oxygen concentrator, no oxygen availability. It's a CHC. It's not a PHC. It's a CHC and no oxygen cylinder available, which was filled. It was because it's a remote hilly area and takes time to reach there. Maybe the reason was that. The oxygen concentrator was there, but the electricity was coming at such a low voltage that he said, the doctor called me, ki inko bacha rahe hain, so you have to take him to a district hospital. So we moved to district. So there are inequities, and the availability of having a solar kind of a concentrator or a oxygen concentrator would be something which will be more required. And I think your emotion, passion and whatever the appeal is very close to my heart also, and I think the panel feels that such solutions should be there, and Varun actually mentioned few of the innovations which were there. I think that was what we are looking
Thank you for understanding. In addition to this, for your generator problem in rural and tribal villages and these remote areas, I'm also making solar portable light kits. I'm making off-grid inverter. It has a backup from 4 hours to 20 hours. So in case my portable off-grid inverters can help you out for that, for the solar concentrator. Thank you. That's what I'm going to say. I'm available for action 24/7. My question is that, if I can help you out, if I can help you out, guys, and we can work together as a team for actions. Thank you.
So, hello everyone. My name is Mark Lenhart. I'm a director of global initiatives at the Society of Critical Care Medicine. We represent 17,000 intensive care professionals worldwide. We're based in the United States. So this is a very passionate and very personal mission, especially for oxygen, especially for critical care teams. And I want to congratulate the Lancet Commission, Leith, and Every Breath Counts, all of you, everyone involved worldwide, because this is such a needed program, such a needed initiative, and you've set a tremendous baseline for us to grow from. Just briefly, my organization has provided some funding and received funding to build 3 facilities, actually, in West Africa, Sierra Leone, Gambia, and Liberia. We did it under the assumption of low carbon footprint. So high efficiency VSA plant, not PSA, much more reliable, uses 30% less energy, less moving parts, more reliable. We also have supplied solar, not only for the plant, but also for the entire hospital. Because we look at oxygen as one component to the entire critical care or entire healthcare strengthening system you need in a hospital, right? So you can't just say you've solarized the oxygen. You need to solarize maybe the whole hospital. Something to consider for moving forward for bigger projects. But my question is, it's the elephant in the room. I see the numbers on the board. Where's the money? Show me the money, right? The great line. And that's the challenge. How do we motivate lawmakers, politicians, social philanthropists, you name it? How do we say this is a priority? Because no matter where they are in the world, they could walk into an ICU, in my case, with no power and no energy. No matter how much money they have, how much influence they have, they're just like you were, just struggling for breath. So that's my question. I know we don't have the answers, but I would like to start the discussion if we could. Thank you.
I'm sorry. I'll just add to him that the demand is high. The demand is high. Supply is less due to less funding. So in order to this, yes, there's a problem. I'm working for Asia, Africa, and Latin America. Thanks.
Colleagues here are requesting me to respond to it, and as a ex-mission director of National Health Mission, so the National Health Mission, there is a fair amount of flexibility and resources available for health system strengthening. Now, some of the colleagues here have been involved and worked with NHM or NHSRC, etc. And essentially, what really is required to be done is around preparing more like a template which will enable to prepare costed medical oxygenation plans for the states. And it could be done in a phased manner. And once those templates and guidelines become available, I mean, we have seen how JSSK or RBSK and now the STEMI or whatever programs have been successfully launched is you have the guidelines, you have an enabling provision. The enabling provision is already there, so that's not an issue with the NHM. The only thing is that when states want to put in the money, they need to know how much money to put for what kind of activities, for what kind of facilities. So if you have a district hospital or a medical college or a CHC or a PHC, depending on the location, then you will need to really identify what really would be an appropriate solution. And I think the national guidelines, I believe, would provide that. And through that, at least for a country like India, there is at least a mechanism and vehicle available to find resources to provide for medical oxygen in a phased manner. Thank you.
I just want to quickly
Yeah.
add. So as sir mentioned about India having the PIP and then putting the resources through PIP, I think such kind of examples needs to be replicated into the other countries to have the local contextual funding of their own in their overall financing than depending on the external funding. And also the way we have the CSR corporate social responsibility, I think similar kind of mechanisms can also be explored into the other countries where private sector or philanthropy can play a role to fill the gap of funds availability and ensure. Again, it's not a vertical activity, it's an integral part of the health system. So it comes under newborn care, it comes under maternal health care. So I think those resources can be tapped through these different the integrated health systems and not putting it as a overall vertical program, because it's not a vertical program, it's part of the entire health system. Thanks.
Thank you. So I think we'll have the last question from Namita from Chai.
Okay.
You can make a comment as a question as well. So
Sure. Yeah, I'm Namita Bansal. I am leading our Essential Medicines and Oxygen Access program at Clinton Health Access Initiative. And it feels proud to be part of this journey, to be working on oxygen system for the last 3 years, particularly specifically on oxygen, and then for many years on pneumonia and other programs. So CHAI has been working in a number of countries in Asia, Africa, including India, on improving access to oxygen and particularly hypoxemia management. And it feels good to also look at the theme for this WHS, which is scaling access to ensure health equity. And Blessy talked about that point too, even Dr. Bish talked about that point, that how do we leverage the infrastructure that has been set up during pandemic and bring that access to everyone, even at the peripheral level, even to the remotest areas, even to the tribal locations, even to populations like neonates we're talking about, to mothers who require, to trauma patients, to emergency care, referral transport that Jayendra talked about. So the commission report has touched upon very important recommendations that go out to different stakeholders who are part of this ecosystem. And it's good to see that those stakeholders are coming together to talk about oxygen, which has been an essential medicine. That has been part of the system. So one piece that I want to talk about is the SpO2 recordings. So being one of the 5th vital signs that has come out, but then still in some of our patient records, it is still not mentioned, right? And even if we talk about the pulse oximetry, so where to record and how to identify early. So a lot of efforts have already been started. We have been working in a number of states in India as well as in other countries to look at that piece. So maybe that is one thing, maybe pointing out to Dr. Bisht on that. And quickly on another thing that may go to WHO, Mr. Jalani, on how to bring all these stakeholders together. So we have Goal Coalition. We have for other diseases, there are many stakeholders coming together. But then oxygen is not a vertical program. Jayendra also mentioned. So it requires integration. Oxygen as a chapter is included in all curriculums, right? So is there a need to bring all those stakeholders together? And then WHO, how are you going, looking at, what are your views on bringing this discussion up? Yeah, thank you.
So I think, Namita, thank you. I will be very brief. SpO2 monitoring is has become, should be there in all, and the commission said it was not done in many of the places, almost 40-50%. And in maternity wards, actually, you see only 10% of the maternity ward has oxygen availability, sir. Leave aside pulse oximetry and recording, availability of pulse oximeter are there, and still pulse oximeter are not being used. Whether functionality because of this or the correct usage, as you rightly said. So there is need, which Jayendra alluded, that we need to train them, tell them, and then there needs to be some regular audit of how we are using it. The indicators should have one of the how many hypoxemic, the indicator is in commission is given how many hypoxemic patients who were actually, who died within that 30 days is one of the indicators, which is we may track with local numbers.
So with this, thank you to all the panelists and to the audience for actively participating in the discussion. It was an informative session, and we actually had a lot of insights. Now I think with the time that we have in hand, I would like to pass the floor to Manoj Jalani sir to give his last remarks on the session and officially close the session.
So thanks, good evening and good everyone. I recognize that now I stand or sit between you and finally the break on a Sunday evening. So I want to sincerely thank the Lancet Global Commission for prioritizing medical oxygen security and also launching this vital report in our region. And also thanks to all the distinguished speakers, panelists for their valuable practical insights. Everyone has alluded to it. Medical oxygen is well recognized as an essential medicine, and the recent WHO resolution underscores its role in strengthening health systems and also for its criticality in pandemic preparedness. The Commission has come out with a very practical and excellent set of recommendations. At this WHO Zero, we are committed to translating these recommendations, which are well aligned to our WHO resolution, translating these recommendations into action. WHO has the convening mandate, and we will have all the relevant stakeholders to come and deliberate on how we advance this agenda in our region. Together, we have an opportunity and also an obligation, a moral obligation, to ensure that no life is lost for lack of something as basic and essential as oxygen. Okay. So I'll repeat. So together we have an opportunity and obligation, moral obligation, to ensure that no life is lost for lack of something as basic and essential as oxygen. So let's all work together to make medical oxygen security a reality for all. Thank you so much. Have a nice day.
send you a WhatsApp.